A very good morning to one and all present here. It is my great pleasure and honor to welcome you all to Thalcon 2025 at the Pink City, Jaipur. On behalf of Mahatma Gandhi Medical College and Hospital, I, Dr. Nikita Pal, Assistant Professor, Department of Paediatrics, extend a warm greeting to our esteemed guests, keynote speakers, participants and delegates who have travelled from near and far to be with us today. This conference brings together brilliant minds, passionate professionals and dedicated researchers to engage in thoughtful discussions and forge valuable collaborations. Before we dive into the program, I would like to express my sincere gratitude to Mahatma Gandhi University of Medical Sciences and Technology, Jaipur, whose support makes this event possible. Over the next few hours, we have an exciting program lined up: oral paper presentations, debate, engaging panel discussions, and informative scientific sessions that promise to challenge our thinking and inspire new solutions. Let's begin with oral paper presentations. This event is not just a platform for academic sharing, it is a celebration of research, innovation, and the power of ideas expressed through speech. We have a panel of esteemed judges with us. I request and invite the judges to please come upon the stage. Dr. Jitendra Gupta Sir, Professor, Department of Paediatrics, Mahatma Gandhi Medical College and Hospital, Jaipur. Sir holds a special interest in pediatric neurology and is an IAP BNS certified instructor. Our second judge for the event is Dr. Abhishek Saini Sir, Associate Professor, Pediatrics, Mahatma Gandhi Medical College and Hospital, Jaipur. Dr. Saini has various degrees to his honors, including fellowship in neonatology from New Delhi and specialization in pediatric nutrition from Boston University, USA. Dr. Ajay Goenka Sir, Assistant Professor in Pediatric Department, Mahatma Gandhi Hospital, Jaipur. Dr. Goenka is a renowned child neurology and epilepsy specialist with over 12 years of rich experience in USA and India. Without further ado, let's begin the paper presentations. The candidates are requested to finish the presentation within 3 minutes precisely, and 1 minute will be provided for question and answers. Please do not waste time in introducing yourself. I now invite our first participant for paper presentation, Ritu Yadav, and the title is Thalassemia Major with Post BMT.
Good morning, everyone. My topic is to study nutritional management of Thalassemia Major with Post BMT. It is a case report. Introduction is Thalassemia is an inherited blood disorder that affects the body's ability to produce hemoglobin and healthy red blood cells. Types includes alpha and beta thalassemia, may cause to experience anemia-like symptoms that range from mild to severe. Treatment can consist of blood transfusion and iron chelation therapy. Advances in patient care have led to significant improvements in the life expectancy of patients with thalassemia. However, the aging of this population leads to increasing development of new complications such as lung disease, heart disease, and endocrine disorders that lead to morbidity and premature mortality. Aims and objectives are: the aim is to study nutritional management of Thalassemia Major with post-BMT. The objectives are: first one is to assess nutritional status by anthropometric measurements, biochemical reports, clinical signs and symptoms, and diet intake. Second is to compare diet intake with the requirements. Third one is to diagnose nutritional status and to plan a suitable nutrition intervention on the basis of nutritional diagnosis. Methodology: the study design is observational study. Locale of the study: Mahatma Gandhi Medical College and Hospital. Study type is a case report, and a 6-year-old girl was selected for the study. Data collection: the subjective global assessment was done to assess the nutritional status of the patient. The following anthropometric measurements were recorded and compared with the IAP guidelines, which is height, weight, BMI, MUSC, mid upper arm circumference, tricep skin fold thickness, which were assessed to which were taken for the nutritional status, and biochemical parameters, CBC, calcium and electrolytes, clinical signs and symptoms was noted. Dietary intake was recorded with the help of 24-hour diet recall method, and the patient was monitored throughout the hospital stay. As a result, the anthropometric measurement was showing that the patient was severely malnourished, as her body weight was 15.2 kg, and MUSC and tricep skin fold thickness was also low for the age. Biochemical reports were showing that patient has
30 seconds better.
Platelets count was low, as it is a symbol of bone marrow disorder. Hemoglobin, as the patient was anemic, and she is also hyponatremic, hypochloremic, and hypocalcium. Result: clinical signs and symptoms were, at the time of admission, patient was having fever, nausea, vomiting, abnormal body movements, respiratory failure, encephalopathy, and nasal seizures, and also difficulty in swallowing and chewing food. Past medical history was post.
Sorry, I will interrupt, but the time is up.
Good morning, everyone. I am Dr. Shikha Gupta, first year pathology resident at Mahatma Gandhi Medical College and Hospital. Today I am here to share my insights on my study titled A Study of the Perception of Family Members of a Thalassemic Child in a Tertiary Care Teaching Hospital. Thalassemia is an inherited blood disorder, autosomal recessive in nature, which results in chronic anemia and hence requiring multiple blood transfusions. Globally, it affects around 4.4 out of every 10,000 live births, and India unfortunately bears a huge proportion of the share. India contributes about 10,000 live cases annually. While the clinical aspect of thalassemia is well recognized, what often goes unnoticed is the emotional, financial, and social toll this disease takes upon the families of the affected children, especially the parents. Our study was done at Southeast Asia Institute of Thalassemia in Mahatma Gandhi Hospital for over 4 months. We used a cross-sectional study design and interviewed 50 parents of thalassemia children and were divided into 2 groups on the basis of the gender of the child to see if the perceptions varied. This was the questionnaire we prepared for the family members. The findings were eye-opening. 80% of the parents were unaware of thalassemia before their child was diagnosed. This gap in awareness clearly highlights the urgent need for education and antenatal screening, which 74% of the parents agreed to. Social stigma and emotional distress were a major theme. Many had to withdraw their children from school and also had to avoid work to fulfill the treatment and the follow-ups of the patient. Financial strain was another major issue. 64% of families struggled to keep up with the treatment cost, often missing work and compromising their basic needs. Although many families avail government schemes, but many were also unaware of government schemes like Thalassemia Bal Seva Yojana until much later. One of the most disheartening findings was the presence of gender bias. Approximately 20% of the parents of female thalassemic child believe that if their child would have been a boy, they would have been more supportive and would have contributed more financially. Yet, despite these challenges, there were also stories of resilience and hope. Many parents have started donating blood for others in need. Several expressed deep gratitude towards medical fraternity and the transformational effect of bone marrow transplant. Some children showed incredible courage, motivating their families through the toughest phases of the treatment. In conclusion, thalassemia is not just a medical condition. It's a lifelong challenge that deeply impacts the entire family unit. It is clear from this study that there is a significant gap in awareness and long-term psychosocial support for these families. Moving forward, a more structured, multidisciplinary approach is essential. One that includes not just the medical treatment but emotional support, social integration and financial support for the families. Only then can we truly improve the life of these children and the unsung heroes around them, their families. These were the references for my study. Thank you.
Thank you. Good study, Dr. Shikha. Just one question. How do you get this questionnaire? Like, is it a standardized questionnaire? How do you come up with this questionnaire?
Sir, we thought about what issues must a family be going through. So we prepared a questionnaire according to their things we thought we could cater to according to the government schemes that were going on, and also there was a special column that they could add upon their own opinions, whatever they felt like.
So it's based on your observation and your clinical practice, you
Yes,
developed
sir.
this questionnaire.
It was
Did you go
purely
through
based.
the patient's perspective also? Did you ask the different
Sorry, sir.
difficulties go through?
Sorry, sir.
Did you, in preparing your questionnaire, did you go through the parents' perceptions also? Did you ask what different type of difficulties they face through?
So we didn't directly ask to the patients. We asked to family members about the patient what they thought they felt, because our study was very limited to the family members.
Okay, thank you.
Thank you, sir.
Next participant is Dr. Nisha Raj, and her title is Hematopoietic Stem Cell Harvest for Thalassemia Patient, a Single Center Experience.
Today I am going to present hematopoietic stem cell harvest for thalassemia patients, a single center experience. So hematopoietic stem cell harvest refers to the process of collecting stem cells, and this is done by a process known as leukapheresis. So how does the transplant happen? So once the healthy donor has been identified, the stem cells need to be mobilized with injection GCSF, and then through the leukapheresis procedure, the stem cells are collected, and then just like a blood transfusion, the stem cells are transplanted to the patient. How do we do it? We need equipment. So we are using the Comtech machine, which works on the principle of continuous flow centrifugation. Now for the machine to draw the blood and process the blood, we need venous SS. So it can be either through a central vein using a hemodialysis catheter or a peripheral vein. Now stem cell mobilization is needed. How is it done? It is done with injection GCSF, which is given as a dose of 300 micrograms subcutaneously, and we give total of 10 doses 5 days prior to the harvest day. And we use injection GCSF because it is a CXCR4 SDF1 bond inhibitor, causing the stem cell to become free. It gets mobilized into the circulation, and then from there it can be easily collected. The donor needs to undergo some pre-procedure workup, which includes the HLA typing, the CD34 count of the donor prior to the procedure, testing for transfusion-transmitted infections, which include the HIV, hepatitis B, hepatitis C, malaria and syphilis, blood grouping and antibody screening, cross-matching with the patient sample and the CBC. This is a picture of one of our recent stem cell harvests, and you can appreciate the stem cells being collected in the sterile bag in the last picture. Now the CD34 cell enumeration is very important because it gives us an accurate measure of number of stem cells that we are getting collected. So prior to the procedure, the CD34 count is done for the donor, and once the harvest is complete, we do the CD34 count of the harvested product for the purpose of dose calculation, and this is done through flow cytometry. The dose calculation, how do we do it? So the CD34 count is multiplied with the total volume of the collected product in microliter and divided by the patient body weight in kg. And what would be an ideal dose? So there are multiple studies which have stated that 5 to 8 into 10 to the power 6 CD34 cells per kg are associated with optimum survival outcomes. The results showed that all procedures were completed uneventfully, and none of the donors experienced any short-term or long-term side effects, and neither did any of the donors require to undergo any second procedure. Adequate CD34 dose was achieved for all the patients who subsequently underwent the hematopoietic stem cell transplant with an 80% success rate. In conclusion, the number of stem cells infused during the transplant is predictive of a better outcome. Therefore, as a first and main step of transplantation, the harvest must contain enough stem cells. In conclusion, to increase the success of a hematopoietic stem cell transplant, it is necessary to continue improving the mobilizing and harvesting techniques. Thank you.
One question, like how do you prove your conclusions? Like you have, it's a very bold conclusion that you have made here. Does your study back those things? Like do you have like number of the stem cells and the outcomes? Do you have any data to support all your conclusions?
Sir, actually, due to constraint of time, I was not able to explain my chart. But we have done 10 stem cell harvests for specifically thalassemia patients in the last, since July 2024. All of the collections, I am presenting this in the transfusion medicine point of view. So all the collections that we had done showed adequate dose. So prior to the transplant, the physician had the stem cells which showed adequate dose. And once the transplant was done, as I said, 80% success rate, we had lost 2 of those 10 patients because of other complications. It was not because of a lower dose.
I don't know anything about bone marrow transplant. From research point I am saying, whenever you put a term better, then there should be something good also. There should be a comparison. Okay, if you gave you this much amount, let's say A amount of stem cells, this was the outcome. If you give B amount of stem cells, that was the outcome. And that's how you make this conclusion that this was better, because you have a group which did not do that much better. So that's why I'm saying, do you have that number to put this conclusion?
Sir, that is a part of my thesis, and I'm still in the process of that.
Because it's a single-centric study experience, so have you gone through other centers also, what their results and all these things?
Sir, I'm not comparing with other centers at the present, so no. Thank you.
Thank you, Dr. Nisha. Our next participant is Dr. Nikita Yadav, and her title is The Impact of Thalassemia on Maternal Health, Exploring the Intersection of Chronic Illness and Parenting Abstract.
Topic of my paper is the impact of thalassemia child on the maternal health, exploring the intersection of chronic illness and parenting. Thalassemia is a genetic blood disorder that significantly affects the lives of those diagnosed and their families. While medical advancement have improved the management of thalassemia, the emotional, psychological and physical toll on caregivers, particularly mother, remains largely unexamined. Understanding the intersection of chronic illness and parenting is crucial for creating holistic care approaches that support both the patient and the caregiver. Aim of the study is to explore the impact of thalassemia on maternal health, specifically focusing on the psychological, emotional and physical challenges mother face in managing the child with a chronic illness. Objective is to identify key stressors associated with caregiving, understanding the coping mechanism employed by mothers and examining the need for targeted support system to improve maternal health outcomes. A mixed method approach was employed, combining qualitative interview with 20 mothers of children with thalassemia and a quantitative survey measuring levels of stress, anxiety and physical health. The interviews aim to capture personal experiences, while the survey provided a broader understanding of the impact on maternal health across different socio-economic backgrounds. Data was analyzed to identify common themes and correlation between caregiving responsibilities and maternal well-being. All questions were asked in their response recorded through face-to-face interview to ensure validity. The study questionnaire was pilot tested and necessary changes incorporated before start of the study. This is the survey questions for assessing maternal impact for caring of the child with thalassemia. The emotional and psychological impact on mother was seen as stress related to medical appointments, which is 72%. Physical health challenges reported by mothers were like sleep disturbance, which is 61%, and role of support system like spousal and family support were 68%. The primary finding of the study highlighted the profound emotional and physical impact of raising a child with thalassemia on maternal health. A significant majority of mothers reported experiencing chronic anxiety, while aligned with the existing literature indicating that parenting is a chronically ill child is associated with heightened psychological distress. Social isolation was another recurrent theme. Despite these challenges, the presence of support networks, particularly family members and healthcare professionals, was found to mitigate some of the negative effects. These support systems can provide practical assistance and emotional reassurance, reducing the overall burden on mothers. Conclusion: the finding underscored the critical need to integrate care models that consider the health and well-being of mother as a part of thalassemia treatment plan. Healthcare providers should recognize the psychological and physical toll on mothers and offer targeted intervention, including mental health support, respite care and caregiver training. Additional fostering robust support system within the community can elevate some of the emotional burdens. This research highlights the importance of family-centered approach to chronic illness management, ensuring that both patients and their caregiver receive comprehensive care to improve overall quality of life.
Thank you, ma'am. Today, I will be talking about the significance of echocardiography in patients with thalassemia major. Thalassemia is one of the most prevalent genetic disorders globally, with India contributing to over 10% of the global disease burden. These patients require lifelong regular blood transfusion, which ultimately leads to iron overload, affecting vital organs such as the heart. Despite sedation therapy, cardiac complications remain a major cause of morbidity and mortality. These include reversible myocyte damage, vascular damage, and pulmonary hypertension. With this background, my study aimed to assess whether echocardiographic findings could help detect early cardiovascular complications in thalassemia major patients receiving regular transfusions. The objective was to investigate cardiovascular complications and to determine if echocardiographic screening has a role in young thalassemia patients. This was an observational study involving 50 patients aged 2 to 16 years registered in Mahatma Gandhi Medical College and Hospital. All had normal ECG findings at baseline and showed no clinical signs of heart failure. On admission, a 12-lead ECG was performed versus the RS ratio, and thus this formula was used to calculate the QT interval. Echocardiography was done at least 48 hours after transfusion using 2D and mode and Doppler techniques following ASC guidelines. Pulmonary hypertension was estimated while the tricuspid regurgitation jet velocity using the modified Bernoulli equation. Talking to the results, the mean age was 6.2 years, 66% were male, 44% were born from consanguineous marriages, over half reside in rural areas, 86% of thalassemia major, and were dependent on monthly transfusion. Nearly half had at least one affected family member. Mean hemoglobin was 7.31. There was no significant correlation between ferritin level and tricuspid regurgitation, nor between pulmonary hypertension and demographic factors. Comparison between ECG and echo findings showed a sensitivity of 77.8%, specificity of 48.3%, and an overall diagnostic accuracy of 64%. A study from the US showed high rates of pulmonary hypertension, thalassemia intermedia compared to major. Another study in Egypt used a higher ferritin threshold, found a link between chronic anemia and cardiomegaly. One other study out of Iran reported a weak association between ferritin and echographic findings, while another study out of Iraq found no correlation at all. In conclusion, the study underscores the burden of thalassemia major in young children, particularly due to iron overload from frequent transfusions. Overall, the study provides valuable insights into demographic and clinical tasks of thalassemia patients, guiding future research and healthcare strategies. Here are my references. Thank you.
Good morning, respected judges and fellow delegates. Today I will be presenting a study on psychological distress among bone marrow transplant nurses, which is a cross-sectional study from a tertiary care medical college and hospital. BMT nurses have an innate exposure to psychological distress as they are frequently challenged with ethical dilemmas and exposure to death while providing critical care. Common stressors include job dissatisfaction, high workload and poor support. Quality nursing care is linked to better patient care and outcomes. Although they are more prone to psychological distress, there is paucity of data addressing this. This study covers this research gap by identifying the levels of depression, anxiety and stress. This was a descriptive cross-sectional study involving 28 nurses from the Paediatric and adult BMT units at Mahatma Gandhi Hospital. It was conducted using a self-reported questionnaire survey, which include demographic details and years of nursing experience and employment status. This was shared through a web-based platform or offline printed copies, and it emphasized that participation was voluntary and anonymous. The survey completion implied consent. It was measured using the 21-item DAS-21 scale, which assesses depression, anxiety, and stress. It is a 4-point Likert scale ranging from 0 to 3, and the total scores are 0 to 126, with higher scores meaning increased severe emotional distress. The statistical sample was 28 nurses, response rate was 100%. The majority were males, and the mean age was 32.4 years. The majority had more than 5 years of experience, with mean being 8.14 years. Now, in the results, we can see that the rho value is 1, which indicates that there exists a positive relationship between the two variables. When one variable increases, the other increases consistently, and vice versa. So, when we see the rankings are identical, over here, the mild cases are high levels are seen in depression, anxiety, and stress. Also, in extremely severe cases, also the similar findings are seen. We can also see this in similar findings due to burnout, compassion fatigue, and long shifts, understaffing, and emotional bonds with the patients, which increase stress. All of this lead to reduced focus and higher likelihood of medical errors and hampered team dynamics. We can see similar findings seen in critical care and pediatric oncology nurses conducted in other studies throughout the world. To address these issues, institutes can encourage counseling, stress management, self-care, manageable workloads, and encouraging open mental health discussions which will reduce stigma. To conclude, psychological distress is a common issue among BMT nurses, stemming from emotional burden
and physical challenges for caring for critically ill patients. It can lead to significant consequences for both nurses and patients. Support systems, work-life balance, mental health awareness are a great solution which would lead to enhanced well-being of both nurses and patients. These are my references. Thank you.
Good study, Dr. Vivanshi. One thing I want to advise all the residents and students, whenever you do behavioral study, neurological study, one very important thing, again I'm not commenting about BMT, I'm talking more from psychology and neurology perspective. There is a huge bias that when are you doing this cross-sectional? So, किसी की लड़ाई हो गई, स्टाफ ने डांट दिया, उसके बाद आपने उसको जाके क्वेश्चन पकड़ा दिया, वो कहेगा मैं दुनिया में सबसे स्ट्रेस आदमी हूँ. 2 घंटे पहले आपकी सैलरी बढ़ी, आपने क्वेश्चन पकड़ा दिया, कहेगा मैं दुनिया में सबसे खुश आदमी नहीं हूँ. So there is a huge bias in these things. Similarly, मान लो किसी को there's a high-grade fever and you are doing a neurological examination, he will look horrible. 4 घंटे बाद he will look completely different. So you can make these studies even better by doing this as a prospective, like multiple stages, removing the bias. It's a good study. But behavior and neurological studies, these things has to be prospective. It increases its importance so much better. One cross-section always gives so much bias in these studies. It's a good study, but we can make it even better.
Yes, sir. Definitely. Thank you.
Moving on to our next participant, Priyanshi Garg, with the title Nutritional Evaluation as an Indicator of Complications Post-Hematopoietic Stem Cell Transplant, a Retrospective Observational Study. Priyanshi Garg.
Good morning, everyone. Today, my title of the study is Nutritional Evaluation as an Indicator Complication for Post-Hematopoietic Stem Cell Transplant, a Retrospective Observational Study. These are the table of contents. So, we'll start with the introduction. Nutritional status is a key indicator of malnutrition, which greatly influence clinical outcomes in pediatric population undergoing HSCT, a vital treatment modality for the range of hematological, oncological, immunological conditions in children. HSCT receives a conditioning regimen that includes high doses of chemotherapy, total body radiation within a short period of time, resulting in harmful effects on the gastrointestinal system. Additionally, graft versus host disease, immune-mediated complication triggered by activated donor T lymphocytes can directly affect the gastrointestinal system, leading to severe diarrhea and malabsorption. These complications negatively affect the nutritional status of the patients, marked by significant weight loss and malnutrition. Objective of our study is, this is a retrospective analysis conducted with an aim to evaluate the role of nutritional assessment as the predictive indicator for post-transplant complication in pediatric patients undergoing HSCT. So this is the review of literature. Review of literature, mostly the study states that if the patient is malnourished, then it's a longer hospital stays, plus there is longer engraftment times, and aggressive nutritional therapy and aggressive nutritional support is needed. Our methodology, a total 44 subjects who underwent transplantation between 2021 to 2024 were included in the study, of which 9 has deceased during the course of the study. Patients were administered diet meticulously calibrated to conform with RDA 2024. Nutritional status was evaluated using SGA tool, including background information, anthropometry, biochemical parameters, and again it was assessed after 6 months of post-transplantation. This was the diet menu. Results, primarily data revealed that there were 16 males and 9 females. The median age of the participants were 8 years. When we compare the weight of the patients, before transplantation, it was mean age was 18.3 with the standard deviation of 5 plus or minus 5 kgs, was increased to 19.2 and with the standard deviation of 5.6. When we compare it with RDA, it was 27 was the mean weight and increased to 9.3 kgs plus minus standard deviation. There was a statistically significant correlation between the nutritional status and weight instability in these kind of patients. This was the graphical representation. The conclusion of our study was Despite a modest improvement in the study weight post-transplantation, there was a significant gap between actual and ideal body weight as well as persistent elevated serum ferritin levels, and highlighted the ongoing risk of malnutrition and iron load in this population. I'm sorry I just overbought the time, but yeah, this was my study.
What do you say about the limitations of your study?
Sorry, sir?
What were the limitations? What do you say there?
The limitations of the study was, sir, first the sample size. Again, another limitation was the diet compliance. When it comes to nutrition, there is a huge diet compliance due to these GI symptoms only. So, when there is regular chemotherapies and regular radiation therapies, there is a taste palatability and diarrhea and other vomiting symptoms that we see. Just because of that, the patient is not able to follow the diet for a very longer period of time, and that leads to malnutrition. So, in further studies, we can always go for the diet compliance. Thank you so much, sir.
Our next participant is Dr. Soumya Sharma, and her title is The Value of Transfusion of Phenotype Blood Units for Thalassemia Patients at a Tertiary Care Teaching Hospital.
Value of transfusion of phenotype blood units for thalassemia patients at a tertiary care teaching hospital. Thalassemia is a hereditary disorder which is characterized by defective synthesis or decreased production of hemoglobin. The major types are alpha and beta thalassemias. Transfusion of red blood cells is essential for patient treatment and management. However, due to difficulties in locating suitable blood donors, the process of blood transfusion continues to carry the risks like allogenization and hemolytic transfusion reactions. Allogenization refers to the development of antibodies in response to the exposure with foreign red cell antigen derived from the same species, but the first one lacked that antigen. Hemolytic transfusion reaction is a condition in which the recipient's antibodies react with the antigens of the donor red blood cells, mainly due to incompatibility. It was a retrospective study which was conducted in January 2024 to December 2024 at our blood center. The patient samples were subjected to RH and KL antigen typing. Phenotyping determines the types of antigen present on the red blood cells. It determines the antigen expression other than the A, B or D antigens. For example, if a patient's RBCs contains these three antigens, then its RH field phenotyping would be capital C, capital E, small e and KL negative. In my study, total 26 thalassemia patients were taken, out of which 58% were male, 42% were female. The most common blood group was O type and the least was the AB type. The most common antigen found was small e antigen and the least common was the KL antigen. The most common phenotype which we discovered was the capital C, small e, KL negative, and the least was the small e, KL negative. In our study, we reported about 0% allogenization rate in our study. Major risk involved in patients requiring regular transfusion is the development of the alloantibodies. Pre-transfusion testing in form of screening and identifications of unexpected red cell antibodies and issuing of suitable phenomatched blood units that are negative for the present antigen is essential for proper management and safety of the allogenized patients. To conclude, providing blood units that are phenomatched and cross-match compatible with the patient reduces the risk of allogenization. Moreover, identification cards should be provided to all multiple transfused patients so that they can get safe blood at any healthcare center they are going for transfusion. The implementation of such policy would enable accurate and systematic follow-up of the patients and ultimately a better quality of life for them. Thank you.
Good, Peter. So you are saying like if you do all those things, you can protect all these antibodies from developing. Was there any study before and after, like what was before and what was after it? What changes does it make?
Yes, sir. Before phenomatched bloods were given and after, we talk about the rate of allogenization. The rate of allogenization when phenomatched blood was not given was about 4 to 5%. The patients develop irregular antibodies. So after when they get transfusion in the next time, they develop reactions. And when we are giving phenomatched blood to the thalassemic patients, it's the rate of allogenization in our study was absolute 0%. So there were no reactions after we are giving the phenomatched blood to the patient.
Thank you, ma'am.
Today, I will be presenting my research titled Prognostic Value of Serum Ferritin on Morbidity and Mortality in Thalassemic Patients Undergoing Allogeneic Stem Cell Transplantation and Ambidextrous Study. Let me begin with a simple question. Is serum ferritin in thalassemia patients a predictor, problem, or both? Serum ferritin is an acute phase reactant that rises in response to infections and GVHD. In transplantation, pre-transplant ferritin levels are often a cause of delay. There is scarcity of literature evaluating the association between ferritin and clinical outcomes, particularly in northwestern India. The aim of the study was to investigate the association between ferritin and morbidity and mortality in thalassemia patients. The primary objective was to explore the relationship between pre-transplant ferritin and overall survival. The secondary objective was to assess the impact of ferritin on post-transplant complications. This was an ambidextrous cohort study with a sample size of 69 patients. Patients who gave consent and had available laboratory data were included, while patients not consenting or with incomplete records were excluded. We analyzed data from 69 patients aged 2 to 16 years. Of these, 56 successfully engrafted, while 14 experienced graft rejection. Using binary logistic regression, we found that pre-transplant serum ferritin had no significant association with transplant outcomes, with a p-value of more than 0.05 and an odds ratio of 0.996. This implies that for every 1 nanogram per ml rise in ferritin, the odds of an unfavorable outcome increased by 0.04%. Mortality was significantly lower in patients with HLA fully matched related donors, only 2%, compared to 21% in those with partially matched donors. 65% of patients were HLA-FMRD and 35% were HLA-FMRD. While 45 had no complications, the most common morbidities included sepsis, autoimmune hemolytic anemia, CMV reactivation, acute GVHD. Our findings differ from the studies conducted in France, Germany, Russia, and the US. For instance, a 2020 study from Germany found that elevated ferritin prior to transplantation is associated with mortality and severe clinical outcomes. To conclude, serum ferritin proves to be an unreliable marker for transplant fitness. Clinicians should avoid relying solely on ferritin when assessing transplant readiness. These are the references we used. Thank you.
How will you justify your result that it differs from other centers out of India?
Sir, sorry?
How will you justify your results that are different from rest of world? Why?
So because high serum ferritin.
Hey, there is also the high serum ferritin occurring out of India. Then they are associated with a high chance of morbidity and mortality. And your study doesn't show any correlation. There are no p-value is less than 0.005. Can you explain the reason?
So because serum ferritin is an iron, like liver, it depicts the liver iron storage more compared to bone marrow. So iron overload, it does not depict the iron overload of bone marrow particularly.
Our next participant is Rakshit, and his title is Comparison of Short-Term Outcomes in Thalassemia Major ABO Mismatch versus ABO Compatible Allogenic Hematopoietic Stem Cell Transplantation.
Excellencies, this is Rakshit from Final MBBS presenting Comparison of Short-Term Outcomes in Thalassemia Major ABO Mismatch versus ABO Compatible Allogenic Hematopoietic Stem Cell Transplantation. I do not have any disclosures. Thalassemia major is an inherited hemoglobinopathy, and allogenic hematopoietic stem cell transplantation remains the only curative therapy. A critical determinant of transplant success is matching the human leukocyte antigen located on short arm of chromosome 6, whereas the ABO gene, which is located on the long arm of chromosome 9, and both are inherited independently. That's why it was believed that ABO compatibility is not essential for stem cell transplant. There is a scarcity of literature of the region-specific data and lack of literature assessing the impact of ABO incompatibility and HSCT in thalassemics. This study was designed aiming to compare the short-term outcome in ABO mismatch versus ABO compatible HSCT transplant in thalassemia majors. It was an retrospective cohort study carried out on thalassemia patients undergoing hematopoietic stem cell transplant. A sample size was 102 patients, in which half underwent ABO compatible transplant, while other half underwent incompatible transplant. We included thalassemic patients aged 2 to 16 years undergoing HSCT and having a fully matched HLA. Patients with other blood disorders and comorbidities were excluded. The results showed that the 12 adverse events were occurred in ABO compatible, while 93 adverse events were occurred in ABO mismatched transplants. Among observed complications, contribution of acute GVHD was 38%, chronic GVHD was 26%, autoimmune hemolytic anemia was 28%, post-transplant lymphoproliferative activation was 2%, and veno-occlusive disease was 6%. If we compare the both groups, there is a significant association of ABO mismatch and acute GVHD, AIHA and VOD with p-value less than 0.05. Mortality after allogenic stem cell transplant was significantly higher in ABO mismatch group with p-value of 0.031. Coming down to discussion, the results showed that there is a significant association of ABO mismatch with complications, adverse events and mortality. Various studies across the globe reported varying results. One reason could be the difference in the genetic makeup of the indigenous population, and the extended phenotype matching was not done to account for that. It can be concluded that ABO incompatibility does seem to have a significant effect on primary outcomes like mortality rate following the allogenic HSCT, though HLA matching and donor availability continue to be the most important clinical selection criteria for donor in allogenic HSCT. More focus should be done on conducting ABO compatible transplants. Thank you.
Very good study. Just a quick question like what Dr. Jitendra asked last time. There was a big difference from the studies from the other countries versus ours. Is it possible there are other biases which can cause these things?
There could be presence of various confounding variables. The sample size could be one of the reasons in various studies. As we saw, there were in some studies the sample size was less than 50, but we had more than 100. And also, none of those studies accounted for the extended phenotype matching for the red blood cells. So that could be also a big reason for varying results.
Good morning, one and all. I, Jayant Yadav, will be presenting a study titled Epidemiological Etiological Profile of Anemia in Children aged 5 to 16 years attending a tertiary care center. Anemia is a clinical sign characterized by a drop in hemoglobin levels to more than 2 standard deviations below the mean for a given age in cells. This condition reduces the blood's oxygen carrying capacity, which in turn triggers compensating physiological adaptations to maintain adequate oxygen supply. The aims of a study were threefold. First, to assess the status of anemia among rural and urban children. Second, to compare its prevalence between these two populations. And third, to evaluate the underlying etiology of anemia in these children. Moving on to the methodology, the study was conducted here at Mahatma Gandhi Medical College and Hospital. A total of 101 children were included in the study in the age group of 5 to 16 years, all with informed consent. The data on epidemiology and clinical characteristics was obtained through medical records, and dietary history was obtained along with menstrual history wherever applicable. Moving on to the results, the age distribution of subjects was as such, with approximately 34% of the children lying in the age group of 5 to 11 years, the younger age group, and 66% of the children lying in the age group of 12 to 16 years. Table 1 here shows the high prevalence of non-nutritional anemia in both the younger and the older age groups, with approximately 85% of the total subjects falling under this category. Importantly, a statistically significant association was observed between the severity of anemia and age groups as shown in Table 2. Moderate anemia was more prevalent in the younger age group, while severe anemia was more prevalent in the older age group. A total of 101 cases were studied, out of which 46 were female and 55 were male. Distributing gender according to the locality, 46 females, 14 were from rural areas and 32 were from urban areas. Out of the 55 males, 27 were from rural areas and 28 were from urban areas. We used WHO standards for defining severity of anemia, and a noticeable increase in proportion of severe anemia was observed from the younger age group at 34% to the older age group at about 59%. To conclude, our findings highlight the urgent need to address non-nutritional causes of anemia such as thalassemia. This includes tackling environmental, genetic and chronic disease factors, establishing a comprehensive and screening diagnostic services in our healthcare system, educating parents, teachers and children about the non-nutritional causes of anemia, and developing policies to address the same. Here are my references. Thank you.
My topic is clinical and demographic profile of children with thalassemia measure. Thalassemia are inherited disorders of hemoglobin synthesis leading to chronic anemia. Beta thalassemia measure presents in early childhood and requires lifelong blood transfusions. This study was conducted to evaluate the clinical and demographic profile of affected children in Rajasthan. The aim of the study was to study the clinical profile and demographic pattern of patients with thalassemia measure presenting to SMS Medical College, Jaipur, Rajasthan. The study was conducted in SMS Medical College, Jaipur. The study type was hospital-based prospective observational study, and the sample size was 120 cases. The data collected was detailed demographic history, general and systemic examination, anthropometric and lab tests. The observation and results are as follows. The sample size was 120, and the data we collected was about geographical distribution, clinical history, chief complaints, anthropometric measurements, and laboratory parameters. The summary of these tables will be in the upcoming slides. The mean age was 7.38 plus minus 4.34 years. A significant portion of the cases were in the 1 to 5 years of age group. Male predominance was observed. 57% cases were male, and almost 77% cases were Hindu and 22% cases were Muslims. In our study, most patients belong to lower middle and upper lower socio-economic status according to modified Kutusami classification. In our study, almost 90% cases were from non-consanguineous marriages. The chief complaints, the complaints patient presented with most common complaints were fever and pallor were the most common symptoms and signs. Almost 7.5% were patients were underweight, 4.2% patients were stented, and 1.7% patients were wasted. The mean hemoglobin was 5.45 gram per cent, and mean RBC count was 2.74 million per cubic millimeter. Mean ferritin level in our study was 568 plus minus 424 nanogram per milliliter, and most patients, almost 31% cases, received their first transfusion between 1 to 2 years of age. In these studies, in our results, only ferritin levels was the only case where we were differentiated from other comparative studies, which must be due to inconsistent chelation therapy. The conclusion is, in Rajasthan, thalassemia is a common disease. However, these children still face delay in diagnosis. This study was done to emphasize on the need for strong suspicion, screening services and early diagnosis that will help and improve quality of care to the patients by increasing specialist care, proper monitoring, adequate education and further management. The references are as follows. Thank you.
It is my privilege to welcome you all to today's continuing medical education program on Thalcon 2025, organized by Mahatma Gandhi Medical College and Hospital, Jaipur, in the beautiful city of Jaipur, our very own Gulabi Nagri. We are honored to have with us distinguished experts who will enlighten us with their knowledge and experience. I am Dr. Prapta Goyal, Assistant Professor in Department of Paediatrics, Mahatma Gandhi Medical College and Hospital, Jaipur. I am honored to guide you through the morning sessions. Today, we aim to explore not just the medical challenges, but also the emotional, social, and economical impact of this genetic disorder. It gives me immense pleasure to welcome all the chairpersons for the first session of this morning, Advancements in Thalassemia Diagnosis. I request Dr. Swati Garg ma'am, Professor and Unit Head, Obstetrics and Gynecology, Director of Medical Mother and Child Care Center, Mahatma Gandhi Medical College. Dr. Pratibha Vyas ma'am, Professor and Unit Head, Department of ENT, Mahatma Gandhi Medical College. And Dr. Roop Sharma sir, Associate Professor, Department of Pediatrics, Director of the Paediatric Intensive Care Unit, Mahatma Gandhi Medical College, on the stage to kindly grace us with their presence on the stage and be the judges for the upcoming debate session. Into one of the most dynamic segment, a debate that promises insight, intellect, and passionate perspectives. The topic for today's debate is: should genetic screening for thalassemia be mandatory for all individuals before marriage or starting a family? We have two teams for the motion and against the motion, each representing their ideas backed by facts, research, and real-world implications. Each speaker will get 3 minutes to present their arguments. Now, introducing the team supporting the motion. Samarth Singh, student of MBBS, 3rd, Professional Part 1, Mahatma Gandhi Medical College. Swasti Singh, studying in MBBS 2nd year, Professional Part, Mahatma Gandhi Medical College. The team opposing the motion, Dr. Ananya Tank, student of MBBS 3rd year, Professional Part 2, Mahatma Gandhi Medical College. Aditya Singh Besla, studying in MBBS 3rd year, Professional Part 1, Mahatma Gandhi Medical College.
The topic for today's debate is: should genetic screening for thalassemia be mandatory for all individuals before marriage or starting a family? And I'll be speaking for the motion. To introduce, thalassemia is a genetic blood disorder that is autosomal recessive in nature. Its complications, however, are not just anemic, but can also include facial deformities, iron toxicity, hypothyroidism, osteoporosis, thrombosis, pulmonary hypertension, increased cancer risk, and much more. It affects 4% population as carriers with a 25% conversion rate. However, I'd like to inform the audience that in the pandemic till 2023, it resulted in deaths of just 0.038% of the Indian population. Opposing Stalin, a million deaths is more than just a statistic. Especially when instead of just 1 million, we're talking about 40 to 50 million carriers. Genetic testing before marriage can prevent 80% of new cases, when already 50% of thalassemia major patients die in India before the age of 25. The burden is real, so is its need for testing. A person cannot make an informed denial to a non-invasive test when they are not even informed about it. Like it or not, genetics and non-communicable diseases are the future of burden of medicine. We need genetic testing and early screening if we ever want to move from curative to preventative medicine. We are in early stages. Act now and we can have a bank of genetic data that will turn the face of Indian medicine forever. Not to mention the amount of job opportunities this would create and actually save several lives and people's money in the long run. Even financially, this is not a completely new idea. A single test can tell more than just thalassemia, but a major variety of diseases with just a drop of blood or swab. There are already schemes such as Indigen Initiative, ICMR proposed, which already offer free genetic testing for several diseases. India is fortunate enough to value health over greed. Funnily enough, for family adoption visits, me and my opposition are going to spend the next month collecting data, including blood samples, for sugar testing anyway. When a country can spend months matching horoscopes, then a simple swab should not be a deal breaker, especially when it can save a life. It is a very possible demand. I want to conclude by saying it is our fundamental duty as people in medicine to always better the health of the community, regardless of how small it may seem. Effort to save a life is always worth it. Thank you so much.
Speaker for the day, Swasti Singh.
Good morning, everyone. I am honored to be speaking on a matter that is not only medical but deeply ethical and social. Whether genetic screening for thalassemia should be made mandatory before marriage or planning a family, I firmly believe the answer is yes, and here is why. First, thalassemia is a preventable disorder where if both parents are carriers of the thalassemia gene, which often goes unnoticed since it is asymptomatic, there is a 25% chance with every pregnancy that the child will have thalassemia major, a life-threatening condition. Through early and mandatory screening, we can identify such at-risk couples and help them avoid passing on this suffering. Second, the emotional and financial burden of thalassemia major is profound. These patients require regular blood transfusion every 2 to 4 weeks for survival, and over time, they develop complications such as iron overload, which needs constant and costly cheration therapy. Families are often drained of their resources and children are of a normal childhood. Third, screening should be viewed as a public health priority. Just as we screen for infectious diseases like HIV and hepatitis B before surgeries or blood donation, we must consider genetic screening a responsible public health measure, especially in countries like India where the prevalence of such carriers is so high. Fourth, the carrier frequency is alarmingly high in our population, about 3 to 4%, and in some communities like Punjabis and Sindhis, almost as high as 10%. With such high carrier rates, the likelihood of two carriers marrying without knowing is very significant. Screening empowers people. It allows couples to make informed reproductive choices. Carrier couples can consider options like prenatal diagnosis, IVF with donor gametes, or even deciding not to have biological children. Denying them this knowledge means denying them this autonomy. Public health policies routinely balance personal choice with social responsibility. For example, vaccine mandates. The goal isn't coercion, but informed consent through structured policy. Prevention of a lifelong disease justifies this minor intrusion. As future doctors, we have an ethical obligation to prevent avoidable diseases. We are taught primum non nocere. First, do no harm. Letting preventable cases of thalassemia occur is in effect harm by omission. And finally, from a systemic point of view, prevention is far more cost effective. Treating a thalassemia major patient over a lifetime can cost lakhs of rupees annually, not including indirect costs like school dropouts, psychological distress, etc. A simple blood test done once costs far less and can prevent all of this. In conclusion, mandatory genetic screening for thalassemia is not just a medical recommendation. It is a social, ethical and economical practice which is imperative. It saves lives, prevents suffering and empowers families. As medical students and future healthcare providers, we must advocate for policies that promote responsible reproduction and public well-being. Let us take a stand for treatment and not just prevention.
Good morning, everyone. Today I rise in strong opposition to the motion that genetic screening for thalassemia should be made mandatory before marriage or starting a family. Thalassemia is a serious condition, but mandatory genetic testing crosses a line. Health policy should protect, not pressure. Forcing tests can infringe on personal freedom and recall the dangerous echoes of eugenics. Prevention must be based on education and informed choice, not coercion. The foundation of ethical medicine is informed consent. That means individuals have the right to make voluntary, educated decisions about their own health. The moment we make screening compulsory, we dismantle that principle. We reduce people to carriers, risks, and statistics. We strip them of their autonomy in the most personal areas of their lives, namely marriage, family, and identity. Proponents might cite examples from Cyprus or Greece, but what they fail to mention is that these programs are built on deeply trusted institutions and strong healthcare infrastructure, something we cannot pretend exists everywhere. In a country like ours, where access to healthcare is unequal, overburdened, and fragmented, this policy would discriminate by default. Rural families, the poor, the uneducated, these are the people who will suffer the most. And let's not pretend this will just raise awareness. Awareness that is forced is not awareness at all. It is surveillance. It will amplify social stigma, especially in a society where genetic literacy is low and superstition is high. A healthy carrier could be branded as undesirable, damaging their reputation, marriage prospects, and emotional well-being, all because of a gene that they cannot control. And even if you ignore the ethics, does our healthcare infrastructure even have the capacity to handle this? Trained professionals, secure labs, data protection laws, or are we about to build a system that is ripe for misuse, corruption, and inequality? Let's be very clear. This policy will not eliminate thalassemia. It will create a new underclass of genetic outcasts. It will weaponize medical data. It will turn families against each other and drive decisions based on fear, not facts. In conclusion, I reject this motion not because I don't care about thalassemia, but because I care deeply about dignity, ethics, and justice. Mandatory genetic screening is not healthcare, it is control. It is not awareness, it is coercion. It is not progress, it is a step backwards into the shadows of eugenics. Let us choose education over enforcement, compassion over control, and public health rooted in trust over tyranny. Thank you.
Good morning, everyone. Those who ignore history are doomed to repeat it. If we take a glance back at any of the recent programs that have mandated any health programs, they have always been involved with eugenics. I don't want to commit the logical fallacy of ad Hitlerum, but if we examine the Nazis' policies, Hitler's main eugenics policy involved forced sterilizations along with mass surveillance of genetic diseases. Mandatory screening takes away the choice of individual, and I feel like that is very unfair, especially in states like India, where there are already so many fractures along so many different lines: caste, religion, socio-economic factors, right? It is evident if you look at the data that thalassemia itself is quite linked to some certain castes as well. If you look at the data right now, in Gujarat, 10 to 15% of the individuals are thalassemia carriers. If we have already broken down our society into so many different divisions and we already claim to follow in this archaic system of caste, then would we not be justifying this pseudo-scientific system with some actual science of forcing screening and bringing more and more data to the fold? Also, the government, which has the road administration service, Mr. Nitin Kakkar, has gone on record saying that the government has sold all the data belonging to the driving license and the driving licenses to companies. So how can we expect them to keep our medical history safe as well? Finally, I would just like to iterate that choice is fundamental, and informed consent, as we learn about in forensics, as we learn in AdCom, is paramount. We cannot force our decisions onto anybody else. And while I do agree that thalassemia is a major condition and screening should be made available at every single stage, it cannot be mandated. Because to mandate it is to, like my colleague said, it does not become awareness, it becomes surveillance. Thank you so much.
Thalassemia, once considered a lifelong burden, is today witnessing rays of hope through advances in therapies with multidisciplinary approach. With this note, moving further towards the next session of the day-to-day management in thalassemia. I would request the chairpersons for this session to kindly grace their presence on the stage. Dr. Ashwini Kamdar, sir, Senior Consultant Pediatrician, Kamdar Children's Hospital, Jaipur. Dr. S.P. Sethi, sir, Senior Consultant Pediatrician and Director, Sethi Hospital, Jaipur. Dr. Anurag Tomar, sir, Professor, Department of Paediatrics, Director, NIMS University, Jaipur, Executive Member, Central IAP. And Dr. Bushra Fiza Ma'am, Professor, Department of Biochemistry, Mahatma Gandhi Medical College. Brings us a keynote address by none other than Dr. Rajiv Kumar Bansal, Senior Consultant Pediatrician, Santopa Dullabji Memorial Hospital, Jaipur, who will speak on how I manage thalassemia. Please join us in welcoming Dr. Rajiv Kumar Bansal, sir, on the stage.
Good morning, everyone, and indeed it's a pleasure to be here this morning, and I'm extremely thankful to the organizers, especially Dr. Priya, for giving me an opportunity to talk about how I manage thalassemia, which I've been managing for the last almost 35-40 years. And I've seen sea changes in the treatment of thalassemia over my journey of thalassemia for the last almost 35-40 years. I can vouch for it. I can say with pride and pleasure that modern treatment of thalassemia is for most part a success story. And the aim of today's talk is to emphasize thalassemics are normal individuals with just the need for optimization of the transfusion, iron chelation, and if possible, can be cured by bone marrow transplant. And over a period of time, this slide is pretty long back, taken from Italian cohort, which even in 2009 showed that the survivals of thalassemics is plateauing at a higher rate. So almost 95% of the children with thalassemia are expected to be normal or behave as a normal individual. But the most important thing is, for that, the basic treatment has to be undertaken. And I would just love and talk to you about the basics today, because what I have found out in the last 35 years is that basic works. Basic is fundamentally important, because once you do the basics, then only you can advance into a better proper management of thalassemia. So we need to know how to initiate the transfusion, and any child who presents to you with severe anemia and has been diagnosed with thalassemia before 1.5 years of age need to be given blood transfusions. So we need to make a proper diagnosis. If we don't make a proper diagnosis at the initial stages, that will be detrimental to the child's health, and we might not be doing the right kind of treatment for him. So we might miss certain treatments or certain conditions which are actually mimicking thalassemia. So we need to have a proper HPLC on the child and to the parents and a molecular diagnosis before we say this patient is suffering from thalassemia and is probably booked for a lifelong blood transfusion. Of any onset after 18 months, 2 years of age could be thought of as intermediate presentation, and if these children are able to maintain a hemoglobin of more than 7 grams per deciliter, one may consider not to give transfusion to these children. However, in the present era, terms and condition and thought process is changing. We want to keep them well transfused because of the more safer bloods that are available. The evaluation prior to transfusion includes a hepatitis B, hepatitis A and C virus status along with HIV, liver function test and immunization has to be done for both the family and the patient for hepatitis B and A. For blood transfusion has to be very careful with, we need to do extended blood group matching right from the day beginning. So we do extended phenotyping matches of our patients. Almost all our patients who are now on a regular transfusion regimen in our hospital setting do get an extended phenotype matched blood. Before transfusion, it's also a necessity to perform full cross-match and screen for newer antibodies. Transfusion from first degree relatives is an absolute no. It's nothing like avoiding it. It's an absolute no, because in the era of bone marrow transplant, all these patients can have got a chance to transplant, should not be given first degree relative blood transfusion to avoid HLA immunization. Net tested blood is available in my hospital and it decreases the window for period for HIV, HBV and NCV infection. And we need to use WBC filters in all patients. If it's available, in fact it's available free of cost from the government setting also. In all our patients we use WBC filters, and this is extremely useful for CMV point of view and from HLA immunization. This is what we do, this is a machine, and this is how the HLA blood group phenotyping looks like. What is the hemoglobin target? I normally try and keep it around 10 grams per deciliter, somewhere within range of 9.5 to 10.5. If you keep hemoglobin up, there are less chances of iron being absorbed from the intestines, and that's because high iron overload is a very detrimental factor in thalassemia treatment. The frequency is about 3 to 4 weeks, maybe earlier in adults. It is preferable to change the volume of blood instead of interval to maintain a target hemoglobin. The volume is 4 ml per kg per gram of increase in hemoglobin desired, and 2 units can be given in adults. The easiest gauge for an appropriate transfusion, I can tell you very confidently, is the enlargement of liver spleen. So any time and every time a patient comes to me, the first thing which I notice is what is the spleen size of this patient and what's the liver size. In fact, one of the Lucrellis criteria is the liver size, and the enlargement of the liver more than 2 centimeters is not a good sign of a proper treatment. Appropriate growth is another factor, and splenic enlargement should need to be aggressively addressed with. Any difficulty in maintaining targeted pre-transfusion hemoglobin should be aggressively managed and addressed too. 1 unit of iron of blood contains approximately 200 milligrams of iron, and each year almost 4 to 10 grams of iron is accumulated by an individual of thalassemia. So we need to be careful about it, and we have to be very carefully understanding that adequacy of chelation, which is important to be done with once you have a regular transfusion. Any increase in non-transferrin bound iodine or labile pool of iron increase over a period of time leads to generation of tissue reactive iron species with DNA damage, protein damage, lipid peroxidation, or mitochondrial damage, and this is detrimental to the health of the child. So we have to be careful with. So when to start iron chelation, I think there will be a detailed talk by my subsequent speakers on this. I'll just go through the basics. So after 10 to 12 transfusion with a ferritin of greater than 1000 nanogram per ml, with the age of greater than 2 years, one need to give iron chelation. If facilities are available, MRI assessment with T2 star 1.5 Tesla. If the ferritin is above 800 grams, so LIC is greater than 5 milligram per gram of dry weight should be given. From my side, the recommendation of serum ferritin is 500 nanogram per ml. So I normally keep my patients And I'm telling you from my own practice, I normally try and maintain them around between 500 to 1,000, not 1,000, not above 1,000, but try and maintain them below 1,000. And I've got excellent results when patients are maintained at around 500 mg per ml. So the goal is average serum ferritin is between 1,000 plus minus 500 with liver iron of 3 to 7 milligram per gram of dry weight, which can be done by T2 star MRI, Munish for a biopsy, and a cardiac T2 star of greater than 220 milliseconds. In higher iron overloaded patients, these parameters can only be attained after several years of consistent chelation. So the aims of iron chelation are preventive therapy. That's what the aim should be. That's the ideal aim. We should not let the iron accumulate in the body, and we should have a balancing act with the drug which we use, as compared to the amount of iron which is accumulated in the body. The second treatment is rescue therapy. Once the iron overload has occurred, one can go and take out the iron. Once the iron has deposited in some tissues, damage is often irreversible. We need to identify that and we need to address that so that we do appropriate treatment right from the beginning, and an emergency therapy if heart failure develops. I just had a patient from Ganganagar who was with me for almost 1 month, and we gave him an intensive emergency therapy with IV desferal, desferasirox and deferriprone, so that we could bring down some amount of extra iron overload in all his tissues. But that's not a very good thing to do. One should start treatment right from the beginning. We've got 3 iron chelators with us, and we're talking about L1 or Calford or deferriprone, deferasirox with the name of Desirox or Asunra, and Desferal or Desferrioxamine. Desferal is one of the first identified drug, more than 35 years of age, or more than 40 years now. Its first live drug for iron chelation, strong and specific iron, removes iron from various parts and now absorbed orally. Its iron-bound complexes, ferrioxamine is excreted in the urine and in the feces, but urine is a major part, and that's the reason for urine being red, and it has to be given by a pump. If that pump is not available, I did an indigenous method. We used to have a syringe with our patients, and I did in lots of patients. We put it in a 10 ml syringe, and we used to train the child to give it subcutaneously over a period of time. They can pump with their hand every half an hour. That's a poor man's thing to do. And continuous IV infusion of deferrioxamine can be given heavily iron overloaded patient when we need a PICC line or other methods of putting in IV lines into the body and can work on a continuous infusion. I did it with this patient about 15 days back. We did it, not rather 1 month back, and we did it for almost a month's time. We gave him intensive chelation so that we can at least bring him out of the woods and he doesn't go into the cardiac failure. So this is basically needed for cardiomyopathy. I can share with you 2 or 3 patients of mine. I distinctly remember those patients are now 25 years alive. 25 years back they had pericarditis, myocarditis, and into heart failure. We gave them intensive chelation therapy, IV, almost for 2 to 3 months, and we could bring them out of the woods, and they're still alive. So maintain low levels of iron, non-transferrin bound iron is recommended in patients with serious cardiomyopathies. All those patients who have inability to use subcutaneous desferrioxamine, they are non-compliant, especially when you're planning pregnancy in these patients. It's important that DFO is not stored for a long period of time. Vitamin C should only be given once you've started with desferrioxamine for some time. Like in this patient, we started with vitamin C after about 5-6 days of intensive chelation, and then we started with very small dosages. If you give a large dose of vitamin C, they may go into cardiac failure. Don't do DFO solutions as canicle or turban. Do not use it in febrile conditions. And now coming to Kakkar, it has got a plasma half-life of 135 minutes. A low molecular compound. It's very important. It's because it's a small molecule, you can transfer it into any part of the body. You can go into the brain even. And there have been reports of deferriprone being used for chelation in certain brain conditions. And iron-bound L1 excreted in the urine gives red color to the urine. Food doesn't change the chelation, and vitamin C is not recommended along with L1. The long-term therapy shows a decline of stabilization ferritin levels in LIC in patients who are using L1, and more rapid decline occurs in patients with more severe L1. It's an excellent drug for cardiac iron overload. And T2 star MRI shows that L1 is to be a better chelation as compared to desferal and deferriprone for cardiac patients. The toxicity is a significant part of it: neutropenia, glutinocytosis, lipidemia, arthralgias, and muscular pains, and will have to be very careful, and you need to monitor them very frequently. And these especially problems like neutropenia, glycolysis, can even occur even after 2 or 3 years of chelation. You think that this patient is responding very well, doesn't have any problem with this drug. No, it's not the case. I've seen patients who had granulocytosis and neutropenia even after 2 or 3 years. So you have to be on your toes every time. So one need to monitor the ferritin in these patients when they are getting L1, zinc, DLC, and anytime the TLC is less than 3,000 or an ANC of less than 1,000, platelet less than 1 lakh. You have to be very careful treating it. With experience, you know where to stop and where not to stop. But any child who gets fever and neutropenia or granulocytosis has to be taken care of and need to be addressed immediately. As far as this deferasirox is concerned, it's highly selective for iron. It's a new drug, removes iron from myocardial cells. It's exchanging iron with DFO, and it also is responsible for removal of iron from parenchymal and endothelial cells. It is excreted mainly in the feces, not in the urine, so the urine color is not red. Skin rashes occur in 70% of patients. GI disturbance is a major problem. And mild, non-progressive rise in creatinine levels within the normal range of about 34% can occur, and it can disease to transplant. So you have to be very cautious while using this drug. You need to monitor the creatinine levels and a urine examination. I've seen patients with Fanconi syndrome with deferasirox. So it has to be stirred into a glass, in a non-metallic glass, and 200 ml of water can be used before it's swallowed. It should be swallowed as a tablet. We have got now tablets of deferasirox available, and the dosages are different in these patients. We will talk to me by my subsequent speakers. So it's a still in 24 hours drug, but I find L1 is a better drug as compared to deferasirox. If I am given a choice of all the 3 drugs, I would still prefer L1 in my patients, except for the fact that I have to be very cautious with the neutropenia, granulocytosis, and arthropathy. All those patients who have had, who are on to preventive therapy or are not on rescue or emergency therapy, behaves very well with L1, and they tolerate the drugs very well, except for the fact that it has to be given more frequently. The drug works wonders. Iron chelators should be present in the body all the time, and ferritin should be maintained between 500 to 1,000, and you will get an excellent child response. If your blood transfusion is adequate, your spleens are not away, palpable, the liver is just palpable, the ferritins are around 500 to 1,000. This child is a normal child. Take from me, all of my patients who are sticking to my advice, until unless they are very unfortunate for some reason or other, they are just normal individuals. If you see my cohort of patients, you will realize, and you will say, oh, is it thalassemia? No, they are not suffering from thalassemia. So for God's sake, don't use chelators as parachutes, and iron chelators work slowly but steadily. They can be given in adequate doses to get the best of the results. And we need to be very sure and emphasize to the patient they need to take their medicine at a regular fixed time, especially when you are using L1. Does 2 chelators give a better results? Yes, combination therapy works wonders, and they can be used simultaneously or sequentially. If they use 2 drugs together like DFO and deferriprone, you see that the LPI is much lower in these patients. So combination can be used. DFO, DFP can be administered simultaneously. The second speaker will tell you more about it. There is access to different pools, prevention of antibiotic accumulation, decreased toxicity, decreased cost, and better compliance. The combination can be either deferasirox, deferriprone, or desferrioxamine. I've used 3 together, I've used 2 together, I've used as a monotherapy, and the combination in the form of maybe twice a day, two times per week combination, or 2 to 6 days per week, or maybe lesser than that. In a various combination of these studies extensively by various investigators, and they have found excellent results. So we can use monotherapy, alternating therapy, or combined therapy with the treatment of thalassemia. So optimization of iron chelation is increasing the daily dose of chelation can be one way, increasing the frequency of the chelator could be another, switching chelator regimens could be third, and rotating the chelators can be the fourth way of doing it. So this is a combination therapy protocol. One can use DFO DFX, DFO DFP and DFX DFP to give excellent results in these patients. One has to identify with T2 star MRI where the cirrhosis lies in. Is it hepatic cirrhosis or a cardiac cirrhosis? If it's exclusively a hepatic cirrhosis, one can use DFO 50 mg per kg per day, or if it's DFX of 30 mg per kg per day, or a DFP of 75 to 100, or a combination of DFO DFX or a DFX DFP. Approach to cardiac cirrhosis has to be a very pragmatic one. It has to be very cautiously treated with. If it depends upon the amount of iron overload, DFO, DFP and DFX monotherapy can be effective in mild cases. However, in moderate to severe cases, continuous IV infusion of DFO or a combination of DFO, DFP or DFO, DFX can be done. I have used extensively all the three drugs together to bring our patients from the boards, and then maybe continue with 2 drugs or 2 oral medications to give results in these patients. So these are the UK guidelines, and this is a Canadian guideline. Somebody wants to have details of it, they can come and approach me and I can share. I'm very totally happy to share these guidelines with them. So monitoring of compliance for use of chelators is very important, and free iron circulating in the body is very harmful, and one has to find the simplest way of finding out is the patient iron overload north. So the very easiest way is, every time a patient comes to me, and because I know that they are my regular patient, hard dikha. And then I know that this patient is not taking his medication regularly. Other ways are doing iron studies, ferritin study, labile poor iron, liver biopsy, squid, and MRI. Serial measurements of serum ferritins are very important, should be done 3 to 6 monthly. The trend is most important as compared to an absolute value. One can do a T2 star MRI of the liver and the heart, and LIC can be assessed with the help of an MRI. The cardiac MRI is a very important tool, and cardiac MRI T2 star is every 2 years. If your T2 star value is greater than 20 milliseconds, every year if T2 star is 10 to 20 milliseconds in 6 monthly, if the T2 star is less than 10 milliseconds. 3 monthly, the T2 star is 10 milliseconds, and an evidence of cardiac impairment is there. So we have did a study in our, and we generated a very simplistic protocol on T2 star 1.5 Tesla machine, and we have found out that it's an excellent tool to investigate these patients. Pregnancy is a very important subject, and I have my own patient who had been pregnant with thalassemia. One of them who was on a regular iron chelation and has now got a child. Another patient who had been bone marrow transplant and has got a child. So one has to be very careful when planning pregnancy. One can use DFO, DFP and DFX before a pregnancy is planned and can give them intensive chelation. However, during pregnancy, chelation is not recommended. The compliance and survival of thalassemia depends upon how much you treat aggressively these patients, and preventive therapy is the best treatment rather than rescue or emergency treatment. The advantages of initiating regular iron chelation is a reversal of skin discoloration, no significant iron deposition in the heart, liver, or any significant organ, proper growth and development, normal development of secondary sexual characters. I can tell you with confidence now that all those patients who are into my cohort for the last almost 25 years, we have been very aggressive with our chelation and blood transfusion. All our children, not an exception, no exception. All our children are entering into puberty at the right time and are continuing with normal sexual changes. No endocrinopathies or even reversal. We don't have any endocrinopathies or almost any patients in the present cohort of almost 20-25 years, and normal, uneventful, healthy life. I tell my patients, you will live longer than what I will live. I'm pretty sure about that. They will be alive even when I'm not here. Adequacy of intensive regular iron chelation in bone marrow transplant results are excellent. I had almost 60 patients of mine who had bone marrow transplant, except for 4 or 5 whom I told them not to go transplant. All are alive. So almost 90 to 95% patients of my cohort are alive just because they had an intensive chelation, they had excellent blood, they had excellent quality of blood, they were all properly phenotyped and they were giving filters right from the beginning and had adequate hemoglobin maintained. So adequacy of chelation clearly means consistent and sufficient suppression of tissue reactive iron. Increased production of reactive oxygen species results under iron overload condition could impair the stem cells colonity capacity, proliferation and maturation, and microenvironment cells could be affected. Iron overload is becoming an important issue also in the engraftment period of post-transplant. And I had met 2 or 3 transplanters, rather 3 or 4 of them, and all says, if your result, your patient's results, we don't care for anything if you send us a patient to transplant, because we know that this patient will pass out without a problem. So iron overload increases the risk of infections and graft versus host disease. We had almost 80 patients regularly transplanted at this point of time in our unit. Risperdal alone is used in 5, deferriprone alone is used in 32, defracidox in 18, and a combination of 25. It keeps on changing depending upon the severity of the problem. Almost 90 to 100 patients come every month for follow-up or consultation, 60% are beyond 10 years of age, 25% are coming regularly for last more than 30, this is an old slide, more than 35 years. Oldest is now about 40 years plus, 45 patients have detailed blood group. It's now almost 60 of them have got blood group and antibody test, all extended blood group and antibody testing. All patients are taking chelation regularly and we use all the drugs. Our BMT patients' outcome is excellent, and the take-home message is they need to take their drugs regularly. What's new in thalassemia? There have been various approaches on thalassemia. Newer drugs are being generated. New thought processes are coming. There are so many new drugs which are in the pipeline. Research is going on. Very unfortunately, only one drug has seen the light of the day today. That is luspatercept. This is a new drug to decrease blood transfusion requirement. I have used it in one patient. Unfortunately, we had to stop. It's an extremely expensive drug, almost $1 lakh per month. So the dosages are 1 milligram per kg, once every 3 weeks by subcutaneous injection. Blood pressure is another, hypertension and other problems are there, and one have to be very cautious and we monitor them very closely. So I don't have much experience. I've used it only one. I have to stop it after 2 to 3 months, and hopefully if we are able to recruit some other, we'll be recruiting other patients to find. But looking to the expense, the benefits are not too many. So it's a reasonably effective drug. It's not out of the box. The other drug is thalidomide. So there's a lot of talk about thalidomide, but one of the literature editor in Paediatric shows that many of these, quite a few patients have had a second malignancy. So they had leukemias post thalidomide. So people are taking thalidomide and they say that they had remission out of it. But the moment you stop thalidomide, patient will go back to it. So there is no cure with thalidomide, and there are multiple problems with thalidomide. And it's not at this point of time recommended as standard of care. So I advise you to be very cautious while using thalidomide. The other drug is hydroxyurea. I use especially for my anti-TD patients. I've used it for thalassemia major patients, but not much of effect. Amlodipine is can be used especially for cardiac iron overload. And gene therapy is much talked about, but no concrete thing. But at this point, today is there, maybe another 5 years, we have got multiple things to come up. So we have many well-managed patients now with thalassemia. They have children. Almost 4 patients have had children. So basically, thalassemia is multidisciplinary approach. Doctors, nurses, physiotherapists, psychologists, and philanthropists are needed to give you an appropriate treatment. You need outside doctors and people who can guide us and maybe have projects with us to give us an answer to the problem. I acknowledge for helping for this talk my patients and parents, my dedicated thalassemia nursing unit at SDMH, the blood bank of SDMH, and trustees of SDMH. And also my dear friend whom I lost last year, late Shri Naresh Bhatia, who was one constant pillar in getting the proper treatment for my thalassemics at SDMH, not only at SDMH, but in Jaipur, and not only in Jaipur, but in Rajasthan. He was such a kind-hearted, good fellow. I pray to God to give peace to his departed soul. Thank you very much.
By Dr. Ali Bansal sir, and he has covered my part also in detail. I would like to emphasize upon the importance upon this long-term iron overloading and the consequences related with this iron overloading and how to monitor it, how to manage it. So let's go through this topic. So we have two parts of the thalassemia patients. One is transfusion-dependent thalassemics. There we are primarily we are getting this excessive iron overload through this excessive blood transfusions. So the primary source of getting extra iron to these transfusion-dependent thalassemic patients is from the excessive transfusion which we have to give very frequently, regularly to these patients for their survival. But in non-transfusion-dependent thalassemic patients, this excess iron is primarily from the excessive absorption from the gut. The absorption of the iron from the gut increases 2 to 3 folds higher, and that causes this iron overload into the anti-DT patients. As we know that 200 ml of whole blood provides average 100 mg of iron, and this is then excess amount of the iron is really difficult to lose. So the problem is with our human bodies that once we get iron inside, it's really difficult to lose it. So whatever the iron we took inside, losing the iron is difficult. So we have to keep multiple checkpoints so that iron cannot get absorbed through the gut if there is high or excess iron inside, or we have to take care of the things by the few drugs also. So what happens if the iron gets accumulated into the human body or tissues? So the problem is with the labile iron, the iron which is not transferrin bound or which is not completely protected by the ferritin and transferrin, that free non-transferrin binding iron is the problem. That is also known as the name of the labile iron. It comes to the circulation through the blood transfusions and high iron absorption through GIT. It causes production of the reactive oxygen species, and these reactive oxygen species can activate caspase and DNA damages, organelle damages by the lipid oxidation, increased tissue growth factor beta 1 causes excessive collagen synthesis, which all leads to cell death, fibrosis, excessive susceptibility to the infections, and sometimes neoplasia like hepatocellular carcinomas. So getting excess iron inside the body is really a significant problem for the patients with the thalassemia who are dependent for the blood transfusions regularly for their survival. So the main route of the iron turnover and uptake are primarily through this blood. The macrophage is the primary cell which is responsible for the getting this iron into the circulation, and once we get the free iron from the macrophages getting it from the transfusions or from the rapid cell breakdown of the electrons. The transferrin has to take care. If the transferrin is completely saturated, then there is non-transferrin binding iron which can get deposited into the various organs which are having the transferrin binding receptors, which are the heart, liver and endocrine glands. So we have the pituitary glands which can lead to hypogonadotrophic hypogonadism, thyroid glands can lead to the hypothyroidism, parathyroid gland which lead to hypoparathyroidism, and pancreatic gland lead to the diabetes mellitus. Now come to the topic then how we have to monitor these things. So we have few monitoring things like serum ferritin level. Serum ferritin level is very cheap. It can be easily repeated. It is easily available. It doesn't require significant skillful techniques, and repeatability of the test is very easy for us. But the problem is with this serum ferritin level is that it is having non-linear relationship with the chelating agents as well as the liver iron concentrations and myocardial iron concentrations. And if the ferritin level is above 4000, again the accuracy of the serum ferritin and total body iron stores are not going in the hand to hand. So serum ferritin is an easy and approachable thing, but its loss of significance and specificity to ask the accurate measurement of the iron ore storage inside the body. For that we have another test, that is liver iron concentration. It is most accurate gold standard test for detecting the iron stores into the body, and for that we have liver biopsy. One of the tools is liver biopsy, where we are getting the dry weight of the liver with the iron deposition. We can also do the same thing with MRI also. So liver biopsy is an invasive procedure and MRI is non-invasive but costlier. Both of the tests are costlier because significant skills and large infrastructure to do this thing. So this is the disadvantage of the LIC. We can also do myocardial iron estimation by the T2 star MRI and cardiac function monitoring by the T2 star MRI as well as 2D echo with the left ejection ventricular function fractions. The other organs should also be monitored with the various endocrinopathies with the functioning detecting tests for the thyroid and pancreas and parathyroid and growth hormones. We can also do 24 hours urinary iron estimation. Primarily it is done to check the effectivity of the chelating agents, especially for deferoxamine, where the primary part of the chelating iron excretion is from the urine, and also we can use it for the deferriprone, where 80% of the total chelated iron is excreted through the urine. It is not actually useful for the deferoxamine, where the primary part of the chelated iron is excreted through the feces. So for the treatment purposes, the primary therapy is iron chelating agents, and the aims of the iron chelating agents are the preventive therapy, where we have to prevent this labile or non-transferring binding iron to be deposited into the tissues. So we can have one aim is to prevent to deposit this iron molecules into the tissues. If it is already has been deposited, then we can use as a rescue therapy. And if it is causing significant dysfunction of the organs like cardiomyopathy or cardiac failure, we have to do emergency therapy. And along with we have to ensure the proper adherence to the therapy. That is the most important aim of the iron chelating therapy. The sources of chelatable iron is primarily the macrophages, which actually eats up these RBCs and make the hemoglobin degraded and free this hemoglobin iron from these RBCs. So macrophages is the primary source where we get this free iron, and this iron chelating agents has to act upon this available iron from this macrophages. The second part is the stored ferritin into the cells, which is get catabolized, and the released iron has to be taken care of by the chelatable iron. Hepatocytes are primarily the cells which stores this ferritin inside it. Now come to management of iron overload. So iron chelators are the mainstay of the therapy. We have three primary iron chelating agents. One is from IV or subcutaneous route, that is parenteral therapy, deferoxamine, DFO. It is having very short half-life, around 30 minutes, and that's why we have to give a continuous IV infusion, as it requires continuous IV infusion. It needs a skillful technical IV access or subcutaneous access of to give this therapy. The primary excretion is from the urine, around 60%, and the 40% of the total chelatable iron is excreted through the feces. The other two molecules which are available are oral molecules. One is diaphragm DFP. This is having the half-life around 4 hours and has to be given 3 times a day. And the dosage for this is around 75 to 100 milligram per kilogram per day. The deferoxamine is the molecule which has a significant good half-life, which allows us to give it once a daily regimen. So the indications, dosing and contraindications and interactions for the iron chelating agents. So for the diferoxamine, all the three molecules should be used about 2 years of age as per the US FDA guidelines. And the diferoxamine has to be administered parenteral. The dose is 20 to 60 mg per kilogram. It has to be given 5 days a week, and various other combinations like 2 days and 3 days and 5. But the standard regimen is 5 days a week. And it's also having the contraindication related with the pregnancy, breastfeeding, and hypersensitivity, severe renal diseases, and anemia are the important contraindications for diferoxamine. The diferoxamine is having oral tablets or solutions. If the dose is 75 to 100 mg per kilogram to be given in 3 divided doses. And the problem is with the excess susceptibility to the infections because of the agranulocytosis caused by diferoxamine. So we have to be very much careful regarding when we are using this drug, and we have to do serial CBC counts for the total absolute neutrophil counts. If the patient develops fever, we should stop the drug. The diferoxam is again oral, and sometimes film-coated tablets and sprinkled granules are also available. The doses are once in a day, and the important monitoring or important side effect of the drug is renal dysfunctions. Now come to the diferoxamine. The site of the infusion for the subcutaneous route is primarily the abdominal sites, and we can also use this deltoid and the thigh part for the subcutaneous infusions. For the IV infusions, we have to use 10% solutions of diferoxamine given to peripheral veins with them and infused in at least 200 to 500 ml of the saline. The important side effects of the diferoxamine are the retinopathy, bilateral sensory hearing loss, few musculoskeletal abnormalities, skin rashes. This makes prone for the infections and zinc deficiencies. The diaphragm having done a good effect on the tissue iron overloading, especially for the myocardial, and it's a good drug for the cardiac iron overload. It's also having very good effect for the liver iron overload, and the complications, the primary issues related with the diaphragm are the bone marrow suppression causing agranulocytosis and increased susceptibility to the tissues, as well as having significant problem. It may have the problem with the joint health, the arthralgia and arthritis, pain in the joints, and again a problem with the diaphragm. It can be used as monotherapy, primarily for the higher level of the serum ferritin levels above 2500, and it also used as in combination therapies. The doses of diaphragm are 75 to 100 mg per kilogram per day in 3 divided doses. The important side effects of diaphragm are GI intolerance, hematological conditions, joint damages. It makes liver toxicities, infections, and zinc deficiencies. The molecule diferoxam is nowadays used much widely for the easier compliance with the patients and the good effect on the serum ferritin levels, and as well as the liver and cardiac iron overloading. The importance of this drug is that it has to be taken once in a day. That's why the impact on the quality of life is really good. The patient's life is comparatively comfortable because of once a daily treatment and very easy tolerance to the drug. And there are few preparations which are film-coated tablets and sprinklers also, which has given better tolerance to the drugs and requires lesser amount of the doses. So the dose can be reduced by 30% if we are using sprinklers. That gives better viability to the patients. It is used as a standard therapy as well as the rescue therapy and in combination with other iron chelating therapies. The important side effects are the nephrotoxicities, so we have to monitor and we have to keep an eye upon this renal functions, especially serum creatinine levels. So if it is on the higher side, we have to stop the drug. Apart from that, few patients may feel the liver dysfunctions, liver enzyme, the transaminitis goes higher in approximately 2 to 5% patients. The GI intolerance is having some nauseating feeling and GI disturbances, for that we have to dilute the drug into the non-metallic glass with the water, approximately 200 ml of water should be dissolved into. There are some skin rashes and other related issues also seen with the dafirosyrops. Regarding this combination chemotherapy, we are having very good results with combining two drugs. Like the gold standard is the dafiroxamine with dapiricrom. As we know that dapiricrom is having good effectivity against the tissue-bound iron, so it's having good activity to remove the ferritin, to remove this NTBI from the tissues to the circulation, and by the using of the dafiroxamine, it is easier to remove the drug, iron from the circulation through the urine. So combining dafiroxamine with the dapiricrom is a great combination to take care of the cardiac iron overload as well as other conditions where the serum ferritin level is difficult to control. The various regimens like 5 days in a week dafiroxamine with 7 days dapiricrom, or 3 days dafiroxamine with 4 days dapiricrom, or 2 days dafiroxamine with 5 days dapiricrom has been studied, and they all are found to be effective. We can also combine dafiroxamine with dapirasyrox. This also gives good results and having a good efficacy against significantly higher iron serum ferritin level. Dapiricrom and dapirasyrox can also be combined and is useful for the purposes of the rapid lowering of the doses. Now the important part is which chelating regimen, when and how much should be used. So for the standard therapy purposes, the standard treatment purposes, the carry home message is that initially for the after first few transfusions, say around 10 transfusions, we can start the standard chelating agents with the dapirasyrox. The serum ferritin level should be above 1000, and we can continue with the initial doses of 20 mg per kilogram per day to maximum around 40 mg per kilogram per day. If we are getting serum ferritin level above 2500, we can first increase the doses of the dapirasyrox to the maximum level, and then we can add on dapiricrom that works well upon the higher level of the serum ferritin levels. We can also use dafiroxamine as an IV therapy, but it requires the patients for the IV and subcutaneous access. The most important part of these therapies are the continuation of the therapy, adherence to the therapy, and the maximum time of the chelating agents. The more the time chelating agents is available for this to chelate this iron, we have to give the therapy for longer duration with the proper dose regimens, with the proper frequency and a fixed time regimen. So we have to counsel the patients that the therapy has to be continued, it should be strictly adhered with and that gives a long-term response and the normal life of the patients. You can also use rescue therapy. We have to use these molecules for the rescue therapy also. So we can, for the rescue purposes and cardiac iron overload and other severe cardiac iron overload, we can use the monotherapy with the higher doses of the dafiroxamine, dapiricrom and dapirasyrox, or we can combine the doses accordingly. Dose de-escalation is primarily for, we have the target level of dose de-escalation is around 500 of serum ferritin level. So if we are getting the doses less than 500, then we can reduce the doses to maintain the level around the range of the 500 to 1000. So this is how we have to monitor and manage this excessive iron overload in thalassemia patients. Thank you.
Good morning, everybody. Honorable Chairpersons, and fellow colleagues. Thank you very much. I thank Dr. Priya and organizing team for inviting me over here. And friends, my journey to thalassemia is from 1881, when I was in Jaipur hospital and I had 100 patients of thalassemia with me. And it was very difficult to manage how the blood transfusion at that time. Blood donation was not that much, public awareness was very less. And we have to manage how the NGC candidates would come and donate. And meanwhile, for a few months, I joined in NCC because the officer said that if you want to motivate these, you should join. And I used to request them to join. And then, 1992, we had the first Thalassemia Society of Rajasthan at Kota. And then I went to Mumbai with Dr. M.B. Agarwal, the eminent the hemato-oncologist who invited Concho Georgis, who invented this calvin at that time in Mumbai. And that was the popular drug so far as. So, many of our issues have been discussed by the previous speakers, but to be very brief, what is thalassemia? You all know is a syndrome or group of preventable genetic disorders and affecting hemoglobin due to absent or reduced production of globin chains. The overall prevalence of beta thalassemia care in the state is around 3 to 4%, 40 million carriers and over 1 to 1.5 lakhs of thalassemia measured in India. But in certain ethnic groups like Sindhi, Punjabis and others, Lingayas, Gowda and all said that 5 to 17% have been reported. The conventional management has been discussed in detail by Dr. Rajiv and Dr. Pavanji. And the blood transfusion, the standard, 10 ka dam jise hum kehte hain, liquid reputed blood, net test rate, pre-transfusion hemoglobin around 10, every 3 to 4 weeks, 10 to 15 ml per kg over 3 to 4 hours, the standard. All three drugs have been discussed over here, so we go ahead. The comprehensive management of child with transfusion-dependent thalassemia needs ideally multidisciplinary approach. Previously, the only pediatrician would do management of thalassemia, but nowadays, involvement of various organs of the body, including liver, heart, and bones, and endocrines, multidisciplinary approach is a must for the intact survival of the child. So this is a concept. We must follow that we are not the pediatricians, cannot manage all the things because the growth retardation, the bone disease, the liver, the heart, all. So it should be a multidisciplinary approach in present time. Number two, if the question is thalassemia curable? I say it is yes. And the only curative treatment previously was the hematopoietic stem cell transplantation at the CT, but now the gene therapy also has come, but it is in the fray. It is available in the other European countries and US, but not in India, but it is a curative option with us. Now, if we want to talk about HSCT, there is a differentiation over here, but for choosing the patient, we have to follow the Pesaro's classification, which includes 3 points: the adequacy of chelation, the liver size, and amount of fibrosis in the liver biopsy. Allogeneic bone marrow transplants results have been best achieved with match-related or match-unrelated donor transplants, but haploidentical or co-donor transplants are now being studied due to the low probability of fully matched donors, because fully matched donors are less available. So haploidentical means slightly genetic matching, and co-donor transplants are also being considered at the present time. The standard recommendations are that you can perform HSCT at any age, but the preferred age is 2 to 7 years of age. However, older age from 8 years and above can lead to difficult situations with us. The liver size over 5 cm results in a high morbidity and morbidity. The splenomegaly indicates the quality of transfusion, but if the patient is splenectomy, it is not a contraindication to HSCT. Now, one word about genetic counseling. If you want to manage thalassemia in our country, all over the world, the thalassemia measure is autosomal recessive disorder, you all know, but the genetic counseling must be done at the time of diagnosis. So, two things at the time of diagnosis, HSCT and the genetic counseling, because it is need of the hour, because if we want to achieve thalassemia-free India, we'll have to do genetic counseling. And if you must know that India is the capital of thalassemia in the world. Every patient, out of 8 patients in the world, is an Indian. And if we are not controlling the situation through genetic counseling, pre-marital screening, antenatal screening, the amount around 2026 and 2030, there will be more than 2.5 lakhs of thalassemia children in India, and that will be a very difficult situation for us. Now, what are the neurotherapies in the thalassemia which we are talking about, new horizons? The ideal comprehensive management of thalassemia increase the lifespan of the children around 50 years with thalassemia of the transfusion dependent thalassemia. There was a need for novel therapies in thalassemia which will circumvent the problem associated with the repeated and frequent blood transfusion and the iron overload. So these were the two things, that the repeated blood transfusion, iron overload, the chelation. Now we needed some novel therapy. Present science is evolving in last 30 to 40 years, and we have various newer drugs which are available. They are under studies. Few have been tried in the adult group, and few are coming in the market. They are potential drugs which will manage the thalassemia in a different way. So there are 3 ways they are acting. The mechanism of action and reducing anemia through the fetal hemoglobin induction. The thalidomide is one of the drugs. It is an immunomodulating drug which increases fetal hemoglobin production by promoting the expression of the globin genes. 2 to 3 milligram per kg is the dose. It has the potential to decrease the need for repeated and frequent blood transfusions. So if we are transfusing 15 days, 3 weeks, this can increase the transfusion gap to 3 to 4 months. The recent clinical trials have shown very encouraging results, but due to insufficient data on long-term safety, thalidomide is not recommended at present routinely in thalassemia. But off the label, if I talk to my colleagues in UP and I talk to my colleagues in Delhi and South, they are using off the label thalidomide because practically it's a good drug. But if Therapeutic University is well known, so Drug Control of India has not given the clear cut, clearance to this drug, and another few months or year may take when this drug will come in the market, a potential drug for managing thalassemia now. The benzodiazepine is another induced drug which is very potential drug, inducing the fetal hemoglobin, and it has been used in Europe for more than 50 years, and it is a potential drug for use in hemoglobinopathy in near future. Then another phosphodiesterase inhibitor, IMR 687, the potential drug for thalassemia, the transfusion-dependent thalassemia and non-transfusion, has been used with sickle cell disease with successful results. But the trial in thalassemia, the transfusion thalassemia is under trial, phase 2 trial is going on. Now another group of drug which acts by erythroid, the combating ineffective erythropoiesis is erythroid maturation agent. They help in the maturation of the hemoglobin, the RBC, and thus reduce the anemia. And luspatercept and sotatercept, which has been told by Rajiv, they are the potential drug. These are the recombinant fusion proteins and cause an increase in maturation of erythroid cells and thereby improving the anemia and beta thalassemia. The dose is 1 milligram per kg once in every 3 weeks subcutaneously. It is available in India but not used in children. It is used above 18 years of age. That was the painful thing with us because we want to treat our younger children and infants with the drugs. Due to the higher cost not being used in larger group of patients, the luspatercept has been the first novel approved therapy that may reduce the transfusion requirements and represents an exhaustive new therapeutic option beyond the standard of care in transfusion dependent thalassemia. The various side effects are there: arthralgia, dizziness, hypertension, hyperuricemia, thromboembolic phenomena. So this drug is used in above 18 years of age and not in the younger children. Sotatercept, this is another drug, but this has not been admitted for the phase 3 trial in India because of the less specificity in TTT. Now, ruxolitinib and mitapivat, they are the another 2 drugs which are potential drugs when encouraging results in phase 3 trials. They improve the ineffective erythropoiesis, there is a reversal of splenomegaly too, and they reduce the iron overload in urine. So they are good quality of drugs, but they are under trial, phase 3 trial in India. The iron dysregulation and overload. Then another group of drugs which are acting the different way, and many hepcidin, TMP, RSF6 inhibitor, paroportin inhibitor, they are the drugs reducing ineffective erythropoiesis and splenomegaly. They also have capacity to reduce the transfer requirements and the iron overload. But there is paucity of published literature data on these drugs, and so they are not being used, and there are clinical trials going on. Now the globin gene imbalance, here comes the gene therapy, and this is known as the gene addition. The US FDA has approved it for TDT patients and now commercially available above 12 years of age children, not below that, and above who are eligible for HSCT but do not have a match-related donor. Many times you don't find a match-related donor with us, and then you can use the gene therapy. It is very expensive and not available in India. You know, the another thing is the gene editing, which is being a part of the gene therapy, and gene edit located on chromosome number 2 is a promising target for gene editing. Deletion in this age gene leads to the unhindered production of globin gene, but these two things will be, India is looking for these things in coming time, but they are not available because of the cost of therapy and the infrastructure. We are fortunate that the institution may start this therapy under the guidance of Madam Narayana. We are very hopeful, and my good wishes to them. What is the advantage of gene therapy? Transfusion independence. Once you are doing gene therapy or आप जब ये process चालू होता है, the process of blood transfusion decreases, and another 2 to 3 months you become transfusion independent. Reduction in infective erythropoiesis, the changes in the chelation therapy. Once you are giving less amount of blood, you need less chelation, and reduction in the side effect due to the iron overload. And then after all, there is a quality improvement in the life, but there are various disadvantages of the gene therapy also, and oncogenic potential, myelodysplastic syndrome and acute myeloid leukemia, and the high cost, which comes around $2 to $3 billion, which comes in crores in India, which is not feasible and affordable by many of us. There are another potential drugs, macrophage manipulation, apotransference, heat shock syndrome, but they are under trial. In conclusion, we can say it is very important to note that both the transfusion-dependent thalassemia and non-transfusion-dependent thalassemia might see a sea change in the management near future. Gene therapy and luspatercept are already in the fray, and India is looking forward to the advancement in near future. Thalidomide might prove to be a boom and a substitute for expensive chelating drug and treatment. The trials are still going on for its long-term use and tolerable doses for a long time. Overall, transfusion-dependent thalassemia and non-transfusion-dependent thalassemia are awaiting exciting time ahead, with many potential options in the pipeline, many drugs and useful therapies in the near future. We wish our thalassemic children a very happy and healthy life. Thank you very much. Jai Hind.
The theme for this year, World Thalassemia Day, is Together for Thalassemia, uniting communities and prioritizing patients. It emphasizes a collaborative patient-centered approach to manage thalassemia globally with holistic care, addressing medical, emotional and social needs. Now that we have gained insights from our previous sessions, it's time to deepen the conversation with our upcoming panel discussion on Navigating the Future of Thalassemia, Advances in Treatment, Diagnosis and Patient Care. To be moderated by Dr. Priya Marwa Ma'am, Professor and Unit Head, Department of Paediatrics, Bone Marrow Transplant Physician, Mahatma Gandhi Hospital, Jaipur. We are honored to have with us a panel of highly respected faculty members and speakers. Their clinical acumen and academic contributions are a source of guidance for many. Kindly give a warm welcome to all the panelists. Dr. Shweta Sharma Ma'am, Professor and Quality Manager, Department IHBT, Mahatma Gandhi Hospital. Dr. Mohit Vora Sir, Senior Consultant Pediatrician, Gastroenterologist and Hepatology, and Honorary Secretary, IAP Jaipur. Dr. Sanjay Khatri Sir, Consultant Pediatric Cardiologist, Mahatma Gandhi Medical Hospital with more than 20 years experience in field of pediatric cardiology and intervention. Dr. Kiran Pabri, Consultant Pediatric Endocrinologist and Diabetologist, Hope Hospital, Jaipur. Dr. Vanita Bansal Ma'am, Associate Professor and Head, PhD in Clinical Nutrition and Dietetics, Mahatma Gandhi Hospital. Dr. Sneha Nathawat, Assistant Professor, Clinical Psychology, Mahatma Gandhi Hospital, Jaipur.
Thank you, Dr. Trapta, and I think it is now good afternoon, everyone. So, and welcome to today's panel discussion. Just one small announcement before we start the panel discussion. We will be circulating the attendance sheet as per instructions of RMC. So please write down your attendance. Thank you. So welcome to today's panel discussion on navigating the future of thalassemia, advances in treatment, diagnosis and patient care. As we all know, thalassemia is a complex inherited blood disorder that affects millions worldwide, requiring lifelong medical attention, early diagnosis and comprehensive care strategies. As advancements in treatment evolve and awareness grows, it becomes increasingly important to understand not just the medical aspects, but also the social, psychological, and policy-related dimensions of managing this condition. Today, we are joined by a distinguished panel of experts who will share insights on best practices, emerging therapies, and the challenges patients and families face in navigating care. We hope this discussion will inspire meaningful dialogue and actionable steps towards improving the lives of all those affected by thalassemia. So a warm welcome to all the panelists. So since a lot of things have already been discussed, so we'll just come down to the nitty-gritty of what is actually the typical management of thalassemia. So we all know that the first and foremost is blood transfusion. So I would like to start my discussion with Dr. Shweta Sharma. Dr. Shweta, what are the current best practices in managing chronic blood transfusions in thalassemia patients?
A very good afternoon to all. As ma'am rightly said that thalassemia major patients are chronically dependent on the transfusions. So we need a comprehensive quality care by providing a good quality product to the patients. As per the standards, in our institute, we are providing the net tested and the leukodepleted products to the patients, as well as when the patients get diagnosed with the thalassemia once, what we are maintaining is, we are just doing first the blood group and we are maintaining the registry of the antigen match of all these patients, and we are providing the pheno match products to these patients. So what happens in the pheno match product is that when the transfusion is required 2 to 3 weeks with the normal blood, but when we are providing the pheno match and the net tested blood, the transfusion days extends from 3 to 4 weeks, and it really helps the patients in reducing the alloimmunization.
And as you rightly said, Dr. Shweta, leukodepletion also takes care of a potential graft versus host disease.
And the most important another thing is that along with the leukodepleted, it's recommended to provide the irradiated products to these patients.
Right. So thank you so much. Dr. Mohit, we all know that multiple organs are affected, but I think the worst onslaught is on the liver. Right. Unfortunately, both because of the disease and because of the treatment modalities available. So how does iron overload affect the liver function in children with thalassemia?
At the outset, I would like to thank you for giving me this opportunity, and a very good afternoon to all of you. I think this is a very relevant question, that how iron overload is affecting the liver. Basically, the first thing which occurs in the liver, normally if you look at the turnover of iron in form of a hemocytin and ferritin, 33% normally is stored in the liver. In this, 98% are in the hepatocytes, 2% are in the bile duct epithelium and reticular epithelial cells. Now when there is iron overload, the Kupffer cells in the liver, they are exhausted, and there is a spill of this iron in the parenchyma. So there is cellular injury or the cellular toxicity which occurs. So the first point which is to be remembered is an inflammation. So after the inflammation, the stellate cells get activated, which leads to scarring, means fibrosis. Fibrosis proceeds from grade 1, 2, 3, 4, and then comes cirrhosis and in the long term HCC, that is hepatocellular carcinoma. So these are the long term, starting from initially the inflammation going to hepatocellular carcinoma. Now what functions if you are talking about? Because what is the function of the liver? Metabolism, detoxification goes away. So there is no detoxification. Chances of getting ammonia accumulated inside the body. Portal hypertension is another feature which comes. Propensity towards infections, acute and chronic. And synthesis of albumin goes down along with the clotting factors. So this is how it major impact on the liver of iron overload occurs in the children.
Right. And that is why we sometimes see in the later stages, children are not just pale, but they are severely jaundiced.
Absolutely.
And you would agree, I think, unfortunately, sometimes ferritin does not actually reflect the true picture of the damage that has occurred in the liver. So, what are the early signs of liver damage that we should look for as far as guiding the patients or guiding us general pediatricians is concerned?
Early signs, like any other disease in liver, what happens? If liver gets affected, suppose in hepatitis, what happens? Initially, when liver gets affected, what is compromised? The nutrition is compromised. The toxins starts accumulating. So because of this, there is early fatigue and loss of appetite. So when the patient is having early fatigue and loss of appetite, this is alarming. You should take into account now this is the beginning of inflammation which is happening inside the liver. Followed by comes the symptoms of portal hypertension. They may be bleed, esophageal varices, followed by chronic liver disease, going into ascites and other signs of liver failure may come. So these are the, and jaundice definitely, yes, hepatomegaly, splenomegaly, jaundice in the early feature besides your loss of appetite and fatigue. So these are the early signs you need to look at, and when you get labs done, you will find that there is transaminitis, there is bilirubin which is increased, INR may go haywire, your ammonia starts increasing, and then you come to know the content of iron, you may go for your T2 star MRI or liver biopsy, etc., many things are there.
And unfortunately, once these changes of scarring and cirrhosis have occurred, they are all irreversible.
Right.
In spite of the best
F3, fibrosis, F3 and beyond, they are irreversible.
They are irreversible. So thank you, Dr. Mohit. Of course, we'll open the questions for audiences once we discuss a few aspects with the panelists here. After the liver, I think the worst to be affected is the heart. So we have Dr. Sanjay Khatri here. Dr. Khatri, what are the cardiac risks associated with thalassemia, particularly, I would say, due to the iron overload?
Yes, madam. Iron is the basic culprit in the thalassemia patient. The overload leads to deposit iron in the various organs, and the heart is also involved, which is the most common cause of mortality and morbidity later life in the thalassemia. The cardiac damage is mainly due to iron overload and free radical injury. It manifests with cardiomyopathy, in which the cardiac myocyte get necrosed. It a gradual process occurs slowly. Cardiomyopathy occurs two types. LV dilated and restrictive cardiomyopathy, in which filling is restrictive. Restrictive means diastolic dysfunctions appear early, then systolic dysfunction. And this cardiac involvement is generally not proportionate with ferritin level. Sometimes if the ferritin level is 600, 700 and you are finding that patient is disproportionately tachypneic or dyspneic or having other complaint, get a proper cardiac evaluation to be done to see the restrictive or dilated pattern in the heart. So these two are the commonest thing in the cardiomyopathy by which the heart is involved. Other thing, sometimes with the right side heart is more involved, patient presented severe pulmonary hypertension. If we pick this thing early, that can be a game changer in that thing, the treatment, because if pulmonary hypertension established due to chronic pulmonary vascular disease, then it's difficult to treat. If we take it early and we start proper medication, it can be treated. And sometimes in the late manifestation of cardiomyopathy, patient presented with various arrhythmia, which we can easily diagnose with the help of ECG. So thalassemia patient, after certain level of ferritin, if symptoms are there, it's mandatory to go for a cardiac examination in the form of echo and ECG.
So, Dr. Khatri, you mentioned dyspnea is something we have to look for. So what we are actually talking about is how do we general pediatricians decide when to send to you? Because you are the experts, and obviously I can't send a child who has just started on transfusions for an evaluation. Or would you actually recommend that we have a baseline once the child is diagnosed? Obviously some are diagnosed quite early in life, but would you recommend a certain age to have a baseline imaging, and then maybe we can go further from there?
Just when the thalassemia diagnosed, one baseline echo is must to see the LV dysfunction, which is not there. It will be the normal. We have a baseline echo, and then when the therapy starts, the blood transfusion starts, based on the chelation therapy or the serum ferritin level or symptoms, one echo once in a yearly child will be sent for a pediatric cardiologist for the echo assessment. If no symptoms, then also 1 yearly. If symptoms start which is not explained by anything, then it can be earlier.
So you've actually half addressed the next question I was going to ask you. What are the modalities of investigations that we should recommend on a regular basis as far as cardiac status is concerned?
As I listened to the previous talk, all of you know the gold standard to assess the iron is the MRI, in which the T2 imaging is must. It can be done with the various guidelines in the beginning of chelation therapy or serum ferritin versus the 1000. So it's the best thing to assess the iron deposition in MRI. But it's not feasible most of the time. But it can be done with a good echo, with a good hand. In echo, we calculate so much indexes like myocardial perfusion index, tie index, by which we can calculate if this heart is suffering from something else, we need to do something. And if pressures are high, we put the patient on other than therapy, anticoagulant. But just basic things, that all things are happening in the heart just because of iron overload. So whatever the cardiac medicine they are supplement, the best thing is the chelation. So if I tell you, yeah, this tie index is coming in this, and this patient having some diastolic and systolic dysfunction, patient is on chelation therapy, increase the chelation dose or shift the patient from 1 to 2 chelation and combination therapy. This echo and MRI finding will guide you to correlate the level. Ideally, it should be combined with ferritin level and good echo with a good hand. If both are there, suggestive of, you can build up on the chelation therapy.
Yeah, but sometimes, Dr. Khatri, it so happens that we have a ferritin level of just about 1200 nanograms per ml, but a T2 star MRI will reveal severe iron deposition in the liver and even in the heart. So in such cases, sometimes it becomes really difficult to convince the patients. So that is where I think, as you recommended, that it's very important that we do a sequential assessment as far as cardiac imaging is also concerned.
So now that we have so many software in our echo machine, so we have no need for go for the MRI which take long time and cost. I agree, it's a gold standard. You can't replace MRI. But whatever information we need in the initial stage is very well given by the echo.
At least that can be a threshold to decide whether we need to go in for a T2 star MRI. Right, thank you so much, Dr. Khatri. Thalassemias per se are, sometimes synonymous with poor growth, I would say. Because of the disease, because of the way they are poorly managed, and sometimes even because of the chelation therapy that we use. So we have our endocrinologist here, Dr. Kiran Pabri. Dr. Kiran, what endocrine disorders are commonly seen just because of the disease thalassemia? Not because of the management or because of anything else. Just because of thalassemia, what endocrine problems are we likely to see?
Thank you very much, ma'am, for inviting me. Growth is often a neglected part, especially when we are dealing with a chronic disorder and especially like thalassemia. So talking about the endocrine problems occurring because of the disease itself, the disease is causing chronic anemia, it is causing chronic hypoxia, increasing the oxidative stress. Thus, there is a poor appetite in these children. So their total calorie intake is less. So they are undernourished for their age, right? So they will be underweight just because of the disease itself at the initial phases. Apart from that, because this iron metabolism is disturbed there, the endocrine organs, especially the anterior pituitary, is very sensitive to the iron overload, which is occurring because of the disease itself. And the anterior pituitary hormones, talking about them, the somatotropes, which constitute the major part of the anterior pituitary, and the gonadotropes, which basically are responsible for the puberty and gonadism, they are most sensitive because of the maximum transferrin receptors on them. So eventually they will be having growth failures and pubertal delays, may or may not be hypogonadism in their later lives.
So, as a general pediatrician, if I am like the primary caregiver for a thalassemic child, at what age would you recommend that I start an endocrine consultation? Sorry.
Thank you, ma'am. It's because we don't have the data that how will these children grow? What are their IGF, BP3 levels actually? So the best is to send them or have their thorough growth evaluation at the beginning, at the enrollment, when they have been diagnosed. Because it's good to trace them according to their own growth centiles.
Exactly.
So, and the deviation from their own growth centiles will be the first thing which will tell a growth specialist when to intervene. Because again, IGF and IGF-BP3 axis, because of multiple reasons, is distorted. We cannot rely on the growth hormone stimulation test or the IGF-1 levels. So, your key point is that monitor them for as per their own growth potentials.
Exactly.
And subsequently, because of the pubertal issues, again, these children have delayed puberty because of the disease itself, and definitely because of the iron overload subsequently. Because of this delay in the puberty, the growth is delayed. There is an interplay of the growth hormone and the sex steroid at the time of the puberty. Apart from that, sex steroids play a vital role in the bone health, and the interplay of these three things result in poor growth, pubertal delay, which are the most common issues we have to address. So, summarizing it, that they have to be started and sent to us at the beginning, at the enrollment of the disease.
Exactly. Diabetes is a very common problem with thalassemics. So, is it just because of the disease itself, or are we actually looking at the iron overload, which is the causative thing in this?
I'm a pediatric endocrinologist, and in the whatever little experience we have, the development of the diabetes occurs in the later years, mostly in the second decade actually. So I have no experience per se in that regard, but yes, this diabetes is multifactorial because of the liver disease, disruption of the beta cells and the alpha cells also, and then iron deposition, and because we don't have much data. So, and most of we cannot label them what kind of diabetes whether it is insulin, technically it is insulin dependent, but whether the child will develop antibodies or whether it is because of the endocrine insufficiency, we still have very limited data in that regard.
Exactly. And things have changed, and the primary caregivers are now more aware of how to take care of the thalassemics. So we actually see the typical thalassemic faces less. And hopefully we'll continue to, see it this way only. Once the child is in the pre-pubertal stage, is there a cut-off age where you recommend that we go in for a full profile, whether this child, because of thalassemia, or if the child has been treated by bone marrow transplant, would achieve puberty at a normal age? So is there a cut-off age that we are looking at where we should recommend that the child should go in for a full profile of sex hormones and growth hormones or anything?
Ma'am, as whatever the guidelines I went through while going through the literature, they are telling that by the 10th birthday, most of these children will have some or other growth or pubertal problem. And definitely that is the time when the puberty sets in, and even if the puberty is not there, there will be pre-pubertal growth spurt which is supposed to be happening. Yes. So maybe around the 10th birthday is the best time that they must be sent.
Right, exactly. So thank you, Dr. Pabri. Nutrition is a very dicey topic in thalassemia because most of the patients, first they will consult the neighbors where they are advised, rich iron-containing diet and iron supplements, and when they come to the primary caregiver, it becomes a huge problem to convince them otherwise. Dadi ki or padosi ki baat, it always carries a lot of weight, but not so much as the pediatrician's words. So we have the chief dietitian of Mahatma Gandhi Medical College here, Dr. Vinita Bansal. Dr. Vinita, how can diet play a role in managing iron levels in thalassemia patients?
Yes, definitely diet has very important role in management of iron overload in thalassemia patients, as especially in those patients who are receiving repeated blood transfusions without chelation therapy. They are more prone to have deposition of iron in vital organs like liver and heart. So it may cause fatty free radical oxidation and further damage to different body functions. So for these type of patients, we recommend a diet that is low in iron and vitamin C, as vitamin C helps in enhances the absorption of iron in our body,
and we need to provide them a high energy, high calcium and vitamin D rich diet to maintain a proper growth and bone health.
Is there anything specific that you would recommend that they should either avoid, which you have said, of course, iron rich, or include in the diet that would prevent absorption of iron? Because obviously even our roti has a little bit content of iron.
Yes. Yes, there is a long list of foods that need to be included and that need to be avoided. Like we need to avoid iron fortified foods and consumption of red meat, which is very high in iron content. Simultaneously, multi-mineral and multivitamin supplements that contain iron and vitamin C in above RDA levels should be avoided. Besides this, we need to avoid iron-rich foodstuffs like green leafy vegetables, pearl millet, pulses, and beetroot, pomegranate, raisins, dates, jaggery. And we also need to avoid vitamin C-rich foodstuffs like lemon, citrus fruits, and amla in our diet. Besides this, we need to counsel our patients to avoid cooking and storage of food in iron-cast utensils. We counsel them to consume a diet that hinders iron absorption, especially tea, coffee, and especially dairy products. Because most of them are children, so rather than encouragement of consumption of tea and coffee, we encourage them to consume dairy products because they will provide calcium and vitamin D as well. And apart from that, we can give them supplements of folic acid, vitamin A, vitamin D, vitamin E, and omega-3 fatty acids if their requirements are not fulfilled by diet, as these may help in RBC production and reducing inflammation and addressing oxidation damage.
Thank you, Dr. Vinita. Dr. Sneha, the psychologist here, when a child comes into the OPD, a pediatric OPD, and has been diagnosed as thalassemia, we pediatricians tend to see, a very broad spectrum of their behavior. There are some who have accepted it even, and we are surprised that this kid is just about 3 years old and has accepted the disease so beautifully. And then we have a 13-year-old walking in. The moment the child comes to know that they have come for a transfusion, so the child starts howling. So what are actually the typical behavioral issues or psychological challenges faced by children and adolescents suffering from thalassemia?
Thank you very much for inviting me. So there we see a spectrum of psychological issues. Rather, I would say it's a complicated mesh of issues which is very individualized. We can see a lot of anxiety. We can see a lot of anxiety related to the treatment, anxiety related to the hospital itself. Sometimes we see low mood, fatigability, loss of interest in activities, which might lead to depressive episodes. We also notice a lot of body image issues, especially in adolescents. Then we have low confidence level, low self-esteem, which might be one of the factors leading to other psychological issues. A lot of cognitive impairments like impaired memory or attention difficulties. We may also notice that there's a lot of intrapersonal stresses, family stresses. Talking about low self-esteem, it might lead to social isolation and even exclusion by the society as a whole. Exactly. So it's a very intricate issue, so that should be dealt accordingly. And from the caregiver perspective, like you said, that sometimes a 3-year-old understands the illness. So that's a role that has to be played by the caregivers, whether from the medical fraternity or from the family domain, that they need to tell about the illness if they have the understanding and in the age-appropriate terms. And let them know and let them take a little bit of a part in decision making, so that they have a sense of autonomy and they feel a little motivated in handling themselves.
So how do you think the caregivers and the school authorities can help in supporting children suffering from thalassemia as far as mental health is concerned?
Definitely family members, caregivers and school authorities have a major role to play in it. Talking about the family members, there are a lot of emotional turmoil what they go through, so they can be an active listener. And even there are a lot of expressed emotions that we sometimes see in the caregivers because of the chronic state of the illness, so they might express it in a very rude manner, so that should be something that should be taken care of. Then normalizing it, like making them do daily chores of the household activities, not making them feel that you're ill or something like that. According to their capability and according to the whatever they can do. and making them always thinking about not giving them unrealistic hopes, but talking them to about realistically what is possible and how to stay motivated. Then definitely dispelling the myths and stigma which is in the society, which is in the community, or maybe the extended family as well. Talking about the school authorities, according to RBWD Act of 2016 and according to NEP of 2020, we have a very inclusive education system and we have a very flexible curriculum. So schools will definitely consider the patients or maybe the children who are suffering from this. They can have a flexible attendance system. They can definitely encourage them to participate in various activities and definitely celebrate their achievements, which will give them again a sense of motivation and autonomy. Again, we have a lot of school counselors which are there, which have a regular check-ins on the child, so that if they think that there is something off about it, they can have a regular sessions with the child. So this is how a child, school and the caregivers can definitely, and sensitization and awareness programs are so much. Something like this conference is such a, through a layman person also, it gives a lot of insight what actually it is about. So that would be really helpful.
Right, thank you so much, Dr. Sneha. So any questions for the panelists here from the audience?
Panelists for such an enriching panel discussion that gave us an insight to the future of thalassemics and has left us all more aware and knowledgeable to handle these kids. Moving on to our next session, thalassemia and the role of multidisciplinary trans patient care. I would like to invite our chairpersons for the same. Dr. Hemant Tiwari, pulmonologist and senior consultant physician on SMS Medical College. Dr. Ramesh Chaudhary, professor in Department of Paediatrics, SMS Medical College, with focus on neonatology and human milk banking. Dr. Anjana Mittal, professor, Department of Pathology at Mahatma Gandhi Medical College and Hospital, to please come and take the seat on the dais. Speaker, Dr. Atili Suresh, is a renowned consultant and medical oncologist and hematologist at Continental Institute of Cancer, Hyderabad, with over 15 years of experience and expertise in his field. I would like to welcome you.
So, the topic which was given to me is very close to my heart. First of all, thanks the organizers for giving me an opportunity to share what we went through and then what is the situation. So this was the topic which was given to us, this community-based hemoglobinopathy care in the last mile, where instead of people coming to the hospitals, can we do in the community and then reach out to them. So we know that we have been hearing for the last couple of days about hemoglobinopathies. There is a lot of issues regarding the accessibility of the care, delay in the diagnosis. Today morning we heard about the screening, genetic, what we call as a counseling. Everything is in fragmented system. It is not, continuation of the care is not there. And the role starts with diagnosing from the pathologist, explaining with the help of ASHA workers, basic pediatricians, and one of the things that is very important, what I realize is, there is lack of medicines and they are not stored appropriately. So you feel that you are giving the medicine and it doesn't work. So if we start enumerating the list, it is endless. So how to do this? So we need to empower them. We need to just teach them that genetics is not everything, it's not the holy grail. A lot of things have to be improved upon. You need to adopt things like using a card test. So if I start going in depth, things are so many. But coming back on to what level to educate these things, we'll start with the first people who face in the who are the what we call as a last mile workers, I think ASHA workers. How to educate them is what we initially focus upon, and what we learn is entirely different. So they immediately refer the patient to the physician or a pediatrician, and then we thought, okay, let's try to shift our focus on those things. But what we realized is, we finally landed upon the patient themselves. They advise something and patient don't do. So then we went back to the whiteboard, started thinking what went wrong. In last 18-20 years, So why are we not able to achieve our goal of not having the last mile care delivered in the most appropriate way? We felt that the people who are educating and then just delivering these lectures are either physicians like us or social workers. And there is a fixed mindset for the both parents as well as the patients. And this is because of the strong belief system that they were in. Thalassemias typically happen in the tribal societies. They felt they were exploited or marginalized, and there is always a barrier of reception. They don't trust whatever we speak. So we went back and then started thinking, can we do something using the kids as the messengers? So we mobilized 50 corporate or we could say schools in the Hyderabad and gave them age-appropriate counseling on what is thalassemia, which is beyond textbooks, right? It is not about what is the structure of the hemoglobin and the genetic, how it spreads and other things. And then we started speaking to them. Okay, this is how the people in the rural are suffering. Are you willing to do a small camp and then just see how they are going to perform and then learn from them and then teach what you know? Because the kids have a very open mindset, and if you can just really tap upon them and their performance is going to be worth seeing it. So how we did is, the first part is education and empathy. So we created a curriculum, just taught them over a period of 3 months on Saturdays and Sundays for 2 hours each, and we actively engaged them. So the moment you read, you understand, but the moment you practice, it will be embedded into your muscle memory. And over a period of time, if you interact with the actual, what we call as a last mile people, then empathy will develop in you. And the second part is, we continue the connection. So that means using a WhatsApp group or virtual reality or repeated small fairs sort of thing, we continued it, and to our surprise, the people in the urban area started leaving their junk foods. So which we never expected. It's like the way the emotions and the mindset change is phenomenal, and the information exchange is much faster than what we thought. And then after 6 months of all these efforts, then we made all of them sit together and then say, hey, look, what is the action that you are going to take, and how are you going to just make the change happen in the last mile. And they themselves came up with the concept of fundraising, blood donation drives, how to ensure that these people are insured, including the pre-existing conditions. Because classically thalassemia is excluded, and one of the parents' father, so one of the kids' father was in the IRDA, and now the law says that even thalassemia can be insured, right? Thanks to him. So it happened a couple of years ago, right? So these are the things that we did it. Is it something that I'm telling without any evidence because we are in a scientific form? No. So our paper was accepted in the BMJ, and the longitudinal study was published, and we were selected as a finalist in the best primary care concept in the BMJ finalist this year, I think a couple of months ago. That's how we got disconnected, right? And so how can I replicate it all across the places, starting from Kashmir to Kanyakumari or from US to Africa sort of thing, right? So we split into 4 phases, classically what I described. Phase 1 is knowledge foundation. So we have translations into 4 languages so far. We are expanding it with the help of the local people. And experience exchange have to be monitored in the beginning, facilitated. There is a lot of cultural gap that we need to understand, and then someone has to ensure that it is seamless, and then you need to continue the connectivity. Otherwise, it starts and ends. I don't want a half-day camp or a full-day camp. I want it to be perennial, which is running through and through. And then you don't leave there. You start nurturing it. Okay, so when we measure, there is 78% increase in the understanding of the hemoglobinopathies, both at the kid level and at the adult level, compared to 23% of a sporadic times. There is a 156% increase in the blood donation rate because kids are forcing the parents to actively engage and then participate, and then 62% increase in the genetic counseling. They told me, I'm okay, daddy, I'm willing to get myself tested, and then I will ask my friend to get it tested. So it's like a regular health checks have improved, the counseling part is much more seamless, and the social acceptance, because these people are living there and they started inviting them to the Hyderabad, and then just so we have a beautiful small society that we created, a small, I can say, instance. And this is how we could break the cognitive resistance in the adults on accepting the kids as they are, and then just enhancing the voluntary donation in terms of blood or money or anything else. Finally, we could just make a cultural shift happen by just bridging the geographical as well as the traditional aspects of those things. So we strongly feel that kids, if they are trained and chosen as the change agents, will have a strong impact in bridging the gap, both geographical as well as cultural. It is scalable and adaptable, not very difficult. You are not spending anything, except for a small camp for an urban kid is like a picnic or excursion for them. And ultimately, you are going to create a beautiful community in the future. So we always request you, if anyone is interested, to join us in this movement. And these are a few of the glimpses of where we conducted, and actually we took them to those hospitals and then just showed what is happening, all those things. Right? I think I'm just in 15 minutes time. Thank you very much for the opportunity once again. I also learned a lot of things during this conference, and over to you now.
Good afternoon, everyone. I'm Dr. Priyanka Goyal. Thank you so much, Dr. Priya Mahaba, for giving me opportunity for this lecture. So we'll be talking about the various challenges faced during pregnancy if a person is suffering from thalassemia. As we all know, we have been discussing since I think yesterday thalassemia. It's a Greek word thalassa, which means the sea, and emia means related to blood. It's a genetic disorder of hemoglobin synthesis characterized by a lack or decreased synthesis of one or more of the 4 globin genes, causing excessive breakdown of RBCs. So over 70,000 babies are born with thalassemia annually, and over 100 million are asymptomatic carriers. So there are major 2 types of thalassemia. Thalassemia major, which is generally homozygous beta thalassemia, and there is an inheritance of a defective beta globin gene from each parent, resulting in transfusion dependent thalassemia. And another is thalassemia minor, that's the heterozygote beta thalassemia trait, resulting in mild to moderate microcytic anemia, resulting in non-transfusion dependent thalassemia, and there is generally no significant detrimental effect on overall health. There is another entity called thalassemia intermedia, whose disease severity varies. At the severe end, they are diagnosed between 2 to 6 years, and they survive without regular blood transfusions, but growth and development are impaired. At the other end, they are completely asymptomatic until adulthood. They present with mild anemia and splenomegaly, and often found by chance during hematological examinations. As we all know, multiple transfusions causes iron overload, resulting in hepatic, cardiac and endocrine dysfunction. Most of these women are subfertile due to hypogonadotropic hypogonadism, as pituitary is very sensitive, and it can result in various puberty disorders, and therefore leading to infertility, and the patients might require ovulation induction to achieve a pregnancy. Cardiac failure is the primary cause of death in over 50% of cases, but now the development of MRI for cardiac and hepatic iron overload has significantly improved and reduced the mortality from iron overload. Now, what are the aims and objectives? First of all, the major aim should be to reduce thalassemia carrier status before pregnancy or at conception, and to reduce the incidence of thalassemia by genetic counseling. Next, to prevent the birth of a thalassemia major baby by prenatal diagnosis, and to set up the centers for prevention, diagnosis and management. So for this, we should identify the carrier. The carrier should not marry a carrier. There should be a medical Kundli Milan instead of Janam Kundli Milan. Now, what is the importance of genetic screening and what procedures are involved for women with thalassemia? If a partner is a carrier of hemoglobinopathy, genetic counseling should be offered. IVF and ICSI, that is in vitro fertilization or intracytoplasmic sperm injection with a pre-implantation genetic diagnosis, which is very important, should be considered in the presence of hemoglobinopathies in both partners so that a homozygous or a compound heterozygous pregnancy can be avoided. We can also consider egg and sperm donors considering IVF. They should be screened for the hemoglobinopathies. In this, when the IVF is done, the biopsy should be done on day 3 and they are screened for the genetic analysis, and then the transfer of unaffected embryo is done, which results in normal baby. Now, how do we do the prenatal diagnosis? If both patients are, both husband and wife are carrier, there are 2 methods. One is invasive and another is non-invasive. So, invasive method includes CVS and amniocentesis. CVS is generally done at 9 to 11 weeks of gestation. In this, a chorionic villus tissue is taken either transabdominally or transvaginally, and then it is tested for any hemoglobinopathy. Another is amniocentesis. It is usually done after 14 weeks of gestation, and in which the amniotic fluid, which is the fluid around the baby, is taken. It is a USG guided procedure, and then it is tested for any hemoglobinopathy. There is another non-invasive method which is very common nowadays, in which we do free fetal DNA in maternal blood. So maternal blood is collected for isolation of fetal DNA. The fetal DNA is then tested for paternal mutant gene. So if the paternal mutant gene is absent, it means the fetus is normal or carrier and we can continue the pregnancy. If the paternal mutant gene is present, it means a fetus has 50% chance of being thalassemia major. So now there is massive parallel DNA sequencing needs to be done. Now, how should we optimize the patient pre-conception? So thalassemia is associated with an increased risk to both mother as well as the fetus. In mother, particularly cardiomyopathy due to iron overload, and there is increased risk of fetal growth retardation in the baby due to chronic anemia. In addition, with around 9 months of chelation, little or no chelation, women with thalassemia major may develop endocrinopathies like diabetes mellitus, hypothyroidism and hypoparathyroidism due to increasing iron burden. So there should be a screening for end organ damage and the optimization of complications should be done. There should be a multidisciplinary approach to manage the high-risk pregnancies along with a hematologist. Contraception should be advised despite reduced fertility with thalassemia, and always folic acid at a higher dose, that is 5 mg, should be recommended 3 months pre-conceptional to prevent the neural tube defects. In transfusion-dependent patients, there should be a detailed discussion of fertility preservation, and the importance of optimizing chelation should be an integral part of discussions from starting the adolescence, emphasizing the fact that good chelation can prevent infertility. Regular MRI should be done for iron overload, and if planning pregnancy, a baseline scan should be undertaken if not undertaken in the prior 12 months. Well-chelated patients have equivalent pregnancy outcomes to patients without thalassemia. So, termination of pregnancy is not mandated. However, chelation should be stopped as soon as pregnancy is confirmed. Now, what are the chelation regimes? The chelation regimes used outside pregnancy include desferrioxamine, deferriprone and defracirox. But DFO is the only agent safe prior to conception and in the 2nd and 3rd trimesters of pregnancy. DFP and DFX should be switched to DFO, ideally 6 to 12 weeks prior to planned conception. Risks of pregnancy include cardiac decompensation, new onset arrhythmias, complications of diabetes, new endocrinopathies, worsening bone health and liver decompensation. So, diabetes in pregnancy can lead to a 4-fold risk of fetal anomaly and a 3-fold risk in perinatal mortality, and can also impact adversely on cardiac function, so it needs to be really monitored well. In non-transfusion dependent patients, the patients are generally fertile and have no thalassemia related complications impacting the conception. In pregnant patients, although careful consideration should be given for RBC transfusion, red cell genotype and phenotype should be documented and reviewed to avoid the risk of transfusion related complications during pregnancy. In pregnancy in patients following allogeneic stem cell transplant, the patients being considered for ASCT should be informed about the potential fertility risks and referred to fertility specialists for preservation options. In these patients, oocyte preservation and embryo cryopreservation can be considered, and in male semen preservation or in pre-puberty the testicular tissue preservation can also be offered. After ASCT, patients should receive genetic counseling to understand they can still pass on the thalassemia gene. The incidence of hypogonadism, delayed puberty and infertility post-ASCT varies widely in the literature, but it tends to be higher in females. Now, how do we manage the pregnancy? Pregnancy outcomes have improved a lot with advances in transfusion, ion chelation therapy and transplantation. But still, a multidisciplinary team should be involved, including a high-risk obstetrician, hematologist, a cardiologist or a diabetologist should be available. Patients should be reviewed monthly until 28 weeks and then fortnightly. An early scan should be done at 7 to 9 weeks, followed by a routine first trimester at 11 to 14 weeks, as we all do for all the patients, and an anomaly scan at 18 to 20 weeks, with serial fetal biometry every 4 weeks from 24 weeks onwards. High-dose folic acid, as I told prior, 5 mg daily should be started 3 months before and continued throughout pregnancy. Women with thalassemia major need specialist cardiac assessment at 28 weeks and as needed afterwards. Arrhythmias may be seen in reversed myocardial ion overload. Splenectomized patients require penicillin prophylaxis due to increased susceptibility to encapsulated bacteria. It also increases the risk of gestational hypertension and preeclampsia, so aspirin at around a dose of 75 to 150 mg daily should be recommended from 12 to 36 weeks. Severe maternal anemia increases the risk of fetal growth impairment, fetal growth restriction due to impaired placental nutrient transfer. So the fetal growth should be monitored by fetal scans, that is the serial biometry and the various Dopplers, so that adequate timely intervention can be taken. Now, what are the transfusion guidelines? If maternal anemia worsens or FGR is present, transfusion should aim for pre-transfusion hemoglobin above 10 grams per deciliter. We should start with 2 to 3 units with an additional top-up the following week if needed to reach 12 grams per deciliter. Monitor hemoglobin every 2 to 3 weeks and then give 2 units if it falls below 10 grams per deciliter. If hemoglobin is above 8 grams per deciliter at 36 weeks, transfusion can usually be avoided during pregnancy, before delivery. If it's below 8 grams per deciliter, give a 2-unit top-up at 37 to 38 weeks. Now, what is the need of thromboprophylaxis? The splenectomized patients or those with a platelet count above 6 lakhs should be offered low molecular weight heparin and low-dose aspirin 75 to 150 mg daily. If additional risk factors are present, consider LMWH from 28 weeks of gestation to 6 weeks postpartum or throughout pregnancy. All pregnant patients with thalassemia require LMWH during hospital admissions. The chelation therapy, it should be individualized, managed by an experienced hematologist during pregnancy. Women with myocardial ion loading need regular cardiology review with close monitoring of ejection fraction, as cardiac decompensation is the main indication for chelation. Chelation is required if cardiac T2 is less than 10 ms or LVEF is less than 56%. High-risk patients should start low-dose subcutaneous desferrioxamine at dose of 20 mg per kg per day, 4 to 5 days every week from 20 to 24 weeks. Women with severe hepatic iron overloading should also be reviewed for possible low-dose desferrioxamine from 20 weeks onwards. Now, what should we do during intrapartum? The timing of delivery should be according to the NICE guidelines. There is no exceptional indication for the delivery for these patients, but yeah, senior obstetrician, anesthetist and hematologist should be informed. There should be an adequate cross-matched blood should be arranged early. In thalassemia major, IV desferrioxamine at a dose of 2 grams over 24 hours should be given during labor. There should be a continuous CTG monitoring, that is cardiotopographic monitoring is recommended, and thalassemia alone is not an indication for cesarean section. Active management of third stage is advised to minimize blood loss. Timing of delivery again should be in line with the national guidance. There is no indication of doing it at preterm or delaying it. Again, the senior obstetrician anesthetist, I'm sorry I have repeated this. Postpartum care, the routine postnatal care should follow national guidelines from NICE. Breastfeeding should be encouraged as DFO is not orally absorbed. Thalassemia patients are at high risk of venous thromboembolism, particularly splenectomized patients with non-transfusion dependent thalassemia. So, splenectomized patients should receive LMWS for 6 weeks after delivery. And then we should assess the iron burden at 3 months postpartum unless myocardial iron overload necessitates earlier assessment. The routine postnatal care. Now, the contraception. The full range of contraceptive options are feasible. The choice is individualized to maximize the compliance and efficacy. So now further to conclude, over last few decades, there has been a great progress in understanding the pathophysiology and treatment of fertility and pregnancy problems in patients with thalassemia syndromes. But the ability to have a family should be an achievable goal for most patients, but it requires a multidisciplinary approach. Close monitoring, timely iron chelation in the second and third trimesters, optimized transfusion protocols, prophylactic medications are key to a successful pregnancy outcome. So the solution is prevention. Preventing the birth of a thalassemia child is the only answer to this worldwide problem. Thank you.
जीवन में दीप बनकर अंधकार में आलोक भर दिया, पग पग पर पथ प्रदर्शक होकर हर संकट को सहज कर दिया। तुम्हारे विचारों की ज्योति अभी भी हृदय में प्रकाशित है, तुम्हारी स्मृतियों की सुगंध मन के उपवन में विराजित है। We rarely come across some great personalities in our lives who leave a lasting impact on every life they touch. Today, I am humbled to share Dr. Munish Kakkar Memorial Lecture to commemorate our love and regard for our dearest late Dr. Munish Kakkar sir, who left us untimely a few months back. I would now request our Honorable Chief Guest Emeritus Chairperson, Mahatma Gandhi University Medical Sciences and Technology, respected Dr. L Swarankar sir, to please grace us on the stage with his presence. Next, I would like to call respected Pro VC, Mahatma Gandhi University Medical Sciences of Technology, Dr. V.K. Kapoor sir, and Principal and Dean, Mahatma Gandhi University Medical Science and Technology, Dr. N.D. Soni sir, to please come on the stage. Lastly, Dr. Rajna Narayan ma'am and Dr. Vikash Masan sir, organizing chairpersons to Thalcon 2025. So please take the chairs on the stage. Every occasion begins with light, a symbol of knowledge, wisdom and hope. To begin our event with the symbolic lighting of lamp and a floral tribute to late Dr. Munish Kakkar sir, I would like to welcome all the dignitaries on the stage to please proceed for lamp lighting.
Dr. L Swarankar sir, our Emeritus Chairperson, हमारे प्रेरणा, मेरे C8 के patron, Dr. Kapoor, Dr. Rupesh, Dr. Soni, it gives me immense pleasure today to welcome you all, but I am sad at heart. This is a time we are remembering
Dr. Munish. We all know he was so dear, he was so friendly to each one of us sitting here in the hall. His students, his patients, all were touched by him. But as we all know, we will love him forever. Today, I would like to emphasize just a few points about our mission. He was a guide and mentor to us whenever we were in distress. Southeast Asia Institute for Thalassemia in Mahatma Gandhi, we have done till date 211 bone marrow transplant cases with support, with guidance and zeal of the staff and the doctors in the unit. This conference is for collective commitment, collaboration, research and compassion. Either you are a social worker helping me out or a lawyer giving us tips. We need your blessings at every nation corner to move and take it forward. The next step in this journey is to get a newer modality of treatment by the name of gene editing, God willing, in Mahatma Gandhi in a near future as early as possible. On behalf of organizing committee, I extend a warm welcome to each one of you to enlighten, be productive and inspiring to all of us. Thank you so much.
Respected dignitaries on the dais, Chairman Emeritus Dr. L Swarankar sir, Pro Vice Chancellor Dr. Kakkar sir, Principal Mahatma Gandhi Medical College Dr. N.D. Soni, respected dignitaries of the dais, dear faculty members and delegates. Good afternoon. Today I have been entrusted upon this onerous responsibility to speak about our beloved late Dr. Munish Kakkar, MD, MRC, CPCH, Additional Principal and ex-HOD, Department of Paediatrics, MG Medical College and Hospital, Jaipur. Dr. Munish Kakkar completed his graduation from R&D Medical College in 1988, followed by post-graduation in Pediatrics from Sir Padmapada Institute of Neonatal and Child Health, SMS Medical College, better known as Thalcon Hospital, in the year 1992. He went on to achieve the highest qualification in pediatrics, that is, an MRCPCH degree from the Royal College of Pediatrics and Child Health in London in 2002, a rare fiat in those days and age. After serving for a few years for the Ministry of Health in Saudi Arabia, Dr. Kakkar returned to India to join Mahatma Gandhi Medical College, Jaipur in 2005 as an assistant professor. His hard work, grit and deep commitment to the well-being of children with the sole purpose of providing quality medical services reflected in his persona. He was promoted to the post of professor in 2014 and subsequently continued as the head of Department of Pediatrics till 2023. Meanwhile, he was entrusted with the responsibility of additional principal of MG Medical College in 2019, which reflected his administrative acumen at the higher level as well. Besides being a clinician, pediatric cardiology was his forte. He had several research publications to his credit in leading national and international pediatric journals. He was the recipient of the prestigious IAP Fellowship Award in 2019. Dr. Kakkar's untimely passing away is a profound loss to the medical fraternity, who remembers him not only for his remarkable academic achievements, but also for him being a sports enthusiast. Yes, he was an avid tennis player. The thread that held the Department of Pediatrics at MG Hospital together, Dr. Kakkar, shall always be remembered for his camaraderie, ever smiling, ever helping nature, and his ability to weave magic with words. May his memory guide all of us to uphold the department to the level he had envisaged. On a personal note, we were friends since we met. Please allow me to recite two lines that I have penned for him. In our hearts, you will always stay, loved and remembered every day. No matter you are away from us, your guidance and care continues to light up.
much, sir, for your humble words. This indeed was so overwhelming for all of us present here. I would like to invite Dr. V.K. Kapoor, sir, Pro VC Mahatma Gandhi, University of Medical Sciences, for introduction and citation of Dr. Frederic Beranard, Consultant and Head, Paediatrics and Palliative Care and Pain, Member of Committee for Advanced Therapies, Montpellier, France.
It is with mixed feelings that I stand here to perform this duty and responsibility of introducing and reading the citation of the lecturer for Dr. Munish Kakkar Memorial Lecture. We all loved and will continue to love and remember Dr. Munish. I remember him as the heart and soul of the prime academic activity of the university, of the hospital, of the medical college, which is the clinical combined rounds. He was the heart and soul behind it. Dr. Frederic Beranard is a pediatrician with expertise in hematology, oncology, immunology and palliative care. Dr. Beranard serves as the head of Pediatric Palliative Care and Pain Unit at the Leperoni Hospital, Montpellier, and is a lecturer at the University of Montpellier in France. Dr. Beranard is a former member of the European Medicines Agency's Committee for Advance of Therapies, and he has been a long-time inspector for the Joint Accreditation Committee of the International Society for Cell and Gene Therapy and the European Society for Blood and Marrow Transplantation. He has led the pediatric stem cells transplant programs not only in France but in Kuwait also. Dr. Beranard's clinical and research expertise spans immunogenetics, bone marrow transplantation and pediatric pain management. Dr. Beranard has received many distinctions, including the National Research Award of INSERM, which is the French National Institute of Health and Medical Research, and A. Mayer's Clinical Research Prize, and he is credited with the appointments to various scientific advisory boards and national committees in pediatric oncology and immunology. Ladies and gentlemen, I have the pleasure and honor to present Dr. Frederic Beranard as Dr. Munish Kakkar Memorial Lecture during Thalcon 2025. Thank you.
Thank you so much, sir. Due to some unfavorable circumstances, we couldn't have Dr. Frederic Beranard in person with us. He would be joining us online for Dr. Munish Kakkar Memorial Lecture on the topic Thalassemia from Seaside to Gene Editing.
So first of all, good afternoon, and I would like first to thank you and thank the organizers to invite me to this meeting and to give me the opportunity to speak today with you and to share your work. Of course, I will thank Dr. Priya Marwa to invite me. And I was also, before starting my presentation, to apologize because I'm not with you physically today. And indeed, for the first time in my life, I didn't get a visa, and so I could not travel. Anyway, I'm very sincerely very happy to be virtually with you. Hopefully, we don't need a visa to work virtually. And to share with you my lecture about thalassemia from the sea to the gene therapy. I will invite you to a global overview, a journey through time, in the company of an old lady, which name is Thalassemia, from past to future, from the sea to the gene therapy, but also between reality and hopes. Next slide, please. You know everything about thalassemia. You already know that thalassemia is a genetic disease, so I will not tell about this. And I will focus my presentation on transfusion-dependent thalassemia. And of course, you know that the main therapeutic option is blood transfusion. You know about exacerbation of iron overload. And you know that allohematopoietic stem cell transplant is, until now, the only curative measure. But I will try to show you important advances in the understanding of the disease, so you could see what could be, what will be, what are the new therapeutic modalities, and some of them are already available. Next, please. So a little history and geography. I told you that thalassemia is the old lady. In 1936, it was named for the first time thalassemia, but it was first described in 1925. And you know that thalassemia may be come from two Greek words, haima, blood, and thalassa, the sea. It is the most common monogenic disorders worldwide. Everyone told this during the meeting, so of course I will not tell you again. It's a chronic disease with a prolonged life expectancy, but we will see with substantial disease burden and organ damage. And it's an old disease. We know that more than 90% of patients live across what we call tropical bears, what we call also thalassemia bears. And for this reason, now thalassemia is a global health issue. Next slide. This is the thalassemia bears initially from the Mediterranean Sea, Middle East, Southern Asia, of course, but because of population migration, it transfers so now to Western Europe, North America, not on this slide, but North America and Australia. And we estimate, it is estimated now that up to 7% of the world population has one form of this blood disorder. Next, please. I will focus about the pathophysiology of thalassemia major because many things occurs and we have now a better understanding. We know that the thalassemia major is not the anemia per se the problem. The problem is a globin chain imbalance which resulted in ineffective erythropoiesis. And of course, with all the consequences, you know, in clinical issues, but you know that better than me. So what could we say about unbalanced globin chain production? This unbalanced globin chain production has three consequences, and so you will see three potential targets to be controlled. First consequence is ineffective erythropoiesis. This erythropoiesis with increased erythropoietin, chronic anemia, extramedullary hematopoiesis, and so on, splenomegaly. Second part is dysregulated iron homeostasis with, of course, iron overload, iron toxicity with impact to major organs, liver, cardiac dysfunction, endocrinopathies, and so on. And the third one is an oxidative stress, ATP depletion, endothelial damage, and with a consequence in increased hemolysis, anemia, platelet activation, and thrombotic events. Next slide, please. And another essential element of the pathophysiology is the central role played by hepcidin. Hepcidin, we will talk about it later, is a key element for regulation of iron absorption and distribution. It's a hormone produced by the liver, and hepcidin reduces the release of iron into the bloodstream by reduction iron absorption, by recycling iron, and you can see on these slides, of course, this is the main role of hepcidin, but increased erythropoietic demand can slow down hepcidin production, and so with rather major consequences. Next slide. I tell you that evolution of pathophysiology and some very recent data about pathophysiology are very important because they gave us some important targets for very useful for treatment. Here are some of them. First of them, we find molecular alteration in genes involved in the switching process. The best known is BCL11A, and with consequence on unbalanced globin chain production. And you will see that BCL11A is one major target of gene therapy. You will see that later. We have also discovered altered signal pathway with upregulation of JAK kinase, mTOR, and also altered concentration of ligands, especially TGF-beta superfamily and other stabilization molecules, and this point will lead to ineffective erythropoiesis and dyserythropoiesis. And we can observe also low exceeding concentration, we can lead also to dysregulated iron homeostasis. And once again, and of course, pathophysiology involves oxidative stress and endothelial damage as better knowledge about PK activator chain. And all these points are very important because this is the first step to the future, and we will see that some treatment already exists targeting this potential pathophysiology elements. Next slide. So here are the new therapeutic approaches that will be seen, and these new therapeutic, we can distinguish, non-curative therapeutic approaches, for example, improve iron overload, improvement of safety, improvement of dyserythropoiesis, and we also distinguish curative therapeutic approaches as gene therapy, use of specific technology which is CRISPR, and improvement safety scope of allo stem cell transplant. And of course, we will also focus on the improvements of usual and current therapies and support measures. These different approaches have led to a dramatic improvement in overall survival, as you can see on this slide, with a drastic reduction of number of deaths and a redefinition of the causes of death. Next. As we said already, most patients now are conservatively treated with transfusion and iron chelation. And few, very few, undergoes curative therapies. So these conservative treatments are here on this general slide, but you already discussed about that, so I will be quick. First, the treatment of anemia with blood transfusion, regular way, targeting transfusion concentration, and so on. Hemoglobin-induced agents to induce fetal hemoglobin, you know that better than me, hydroxyurea, thalidomide, butyrate, and so on. Treatment iron overload, iron chelation. You spoke about this a few minutes before with serum ferritin, measurements, target level, and of course use of iron chelation with molecules, you know, deferoxamine, deferriprone, deferasirox. And of course, in this conservative treatment, you have treatment-induced or disease-related, to treat disease-related complication, renal, cardiac, pulmonary, hypertension, endocrinopathies, and so on, infection, cancer, alloimmunization, and so on. And of course, conservative treatment involves hypersplenism with treatment with antibiotics, immunization, management of complication. Next, please. Even if transfusion and iron chelation therapy are the mainstay treatment, several challenges still exist. Here are some of them. An unavailability of blood products, especially in low-income countries with insufficient voluntary donation, high cost, discard of donated blood for many reasons. Lack of compliance to therapy, especially in adolescents, you know that better than me. And of course, because of medical constraints. And in these medical constraints for families, for example, we can include financial and economic burden, of course, of the treatment for patient and his family. Adverse effects also is a challenge: alloimmunization, transfusion-related reaction, infection, iron overload, and of course, limited availability to iron chelators in some countries, and it's not the less important, lack of specialists, lack of multidisciplinary teams. Next, please. Nevertheless, there are some improvements in this conservative treatment, especially related to treatment iron overload and iron chelation. Of course, there are some new techniques, but not exactly treatment. You discussed about that a few minutes ago, for liver MRI, cardiac iron estimation, and so on. This is very important. When we discuss about chelator, the new advancements are monotherapy or combination treatment. You can start oral chelation sometimes very early, younger than age of 2 years. You have new formulation, and sometimes you can add some molecules to increase the efficacy of chelators. And the new agent is epsidin. Remember, I discussed about epsidin a few minutes ago. And we can manipulate iron metabolism with a synthetic human epsidin, with epsidin mimetics, with induction of hepatic epsidin production, and so on, to decrease the overload of iron. Next, please. But of course, still remaining issues. Even we have new improvements, we have still very important issues with only transfusion and chelation. First of all, not so many children receive adequate transfusion or iron chelation. Only 12% of children with transfusion-dependent thalassemia globally receive adequate transfusion therapy. Less than 40% of those transfused receive adequate iron chelation. Of course, we have to underline the cost of the different techniques, the different regimes of treatment, and of course, we have to point the irregular continuity of delivering of these treatments all over the world. Next, please. In addition to conservative treatments, progress has been made on curative approaches. And these advances concern first and foremost treatment of anemia, erythropoiesis modulators, and they are partner of preclinical and early clinical studies. The one you know maybe is the use of hemoglobin-inducing agents, name is luspatercept, and luspatercept, it was called the ligand trap. Remember we discussed about TGF-beta ligands, and this molecule, this fusion protein, prevents the binding of some ligands to some activating signaling molecules. So the result, anyway, is to inhibit signaling. And so, of course, in inhibiting signaling, this molecule can sustain reduction in transfusion burden and more effective iron overload management. This is one of the first applications of the pathophysiology. But we have other new curative approaches. First of all, remember, we can act on inhibition of JAK, just another kinase, JAK pathway, using, for example, some blockage of this pathway. We can also use ruxolitinib with a JAK inhibitor, and we can also reduce the oxidative stress using rapamycin, using sometimes erythropoietin, and very recently we can decrease hemolytic vulnerability of thalassemia red blood cells using a pyruvate kinase activator which increases cell ATP, and the name is mitapivat, is under phase 2 and phase 3 trials. Next one. Next, please. And I will just a little bit focus on luspatercept status, because it's some positive initial results, effects. Even these effects are not so extraordinary. First of all, we have 2 phase 3 trials for this product. The first one for dependent transfusion patients, and the second one is Beyond, the name of the phase, which is for non-transfusion dependent patients. Both of them, Believe and Beyond, are addressing have been approved by the European Medicine Agency. So clearly they could be useful. But once again, results are not so extraordinary, but in some cases it can lead to transfusion independence, it can lead to reduction in transfusion burden, and it can lead in iron overload management. So this is quite a start. Next, please. We move now on to curative therapies. Of course, some of them are almost classical for you now. It's of course hematopoietic stem cell transplant, and others are still investigational. Some forms of hematopoietic stem cell transplant, and of course gene therapy. Next slide. And the gold standard of the curative treatment is hematopoietic stem cell transplant, and the first transplant started not so far. It was in 1982 was the first transplant for thalassemia. And now the gold standard of hematopoietic stem cell transplant is a matched sibling donation. And with time, there is an improvement in stem cell transplant monitoring, and there is improvement of experience and outcome of this treatment, especially from children to adults. Adults is a huge problem, and also in developing unrelated donors and using now increasing experience with haplo-identical transplants. Next, please. So, when we focus on hematopoietic stem cell transplant, I tell you that, of course, the gold standard is the HLMH-related donor with an excellent curative therapy with overall survival estimated to 91%, event-free survival 83%, and the TRM, transplanted-related mortality, less than 5% in children. But these excellent results are observed only in young children, and when the child is getting older, the results are a little bit less optimistic, as you can see on the slide. So sometimes we don't have a donor in the family, and so we move to match unrelated donor transplant, and this match unrelated donor transplant now an acceptable option for young children with complications, but I don't have time to develop this right now. And of course, because we don't have a donor, we move to haplo-identical related donor, especially with bone marrow and stem cells from parents or siblings, but of course with a higher risk of GVHD, graft versus host disease. And sometimes we still use umbilical cord blood, but a decreasing of this indication. So, we of course now have improvement in this classical treatment, improvement in conditioning regimen, use of triosulfan is an improvement. Improvement in T-cell depletion techniques with selection of CD34, in vivo depletion, T depletion using cyclophosphamide, T depletion, and so on. And we also improvement in desensitization strategies, example in case of anti-HLA donor antibodies using some molecules, and of course improvement in supportive care in GVHD prophylaxis, CMV infection management, opportunist infection, aseptic techniques, better HLA taping, and systematic antibiotic therapy. Next, please. And finally, gene therapy appeared. And roughly, we can describe two types of gene therapy. Either gene addition, which is the first one described and used, this is gene insertion, or we can have gene editing, which is a gene modification approach. So gene therapy is a curative treatment option for transfusion-dependent beta thalassemia. It is clear. And we use in gene therapy, I will show you, autologous hematopoietic stem cells. So as is autologous cells, of course, we overcome the obstacles of donor availability, of consequences as graft rejection or GVHD. But phenotypic correction, we will see, might be incomplete, and long-term data are still scarce. Even this treatment is clearly the future. Next, please. So, first, gene addition therapy. Everything started in 1990s, and with laboratory work and the choice of the best vectors, we moved from retroviral vectors to lentiviral vectors. And first, we created some humanized murine models. In the years 2000, it was the first cure of mouse models of beta thalassemia, and the first beta thalassemia patient has been successfully transplanted in 2008 with the opening of clinical trials. Next, please. This is the objective of the gene addition therapy. The objective, of course, is to obtain a transfusion independence of the patient, and we do that by the gene transfer of beta globin gene in stem cells. Oh, previous one, please. Can you go back? Okay, thank you. And the gene transfer of beta globin in stem cells to reduce the imbalance of erythropoietic cells, and of course to reduce the ineffective erythropoiesis, and of course to lead to transfusion independence. Next, please. Here is the practical way to do a gene therapy. First, we do from the patient, there is a mobilization and apheresis, so we can obtain cells, stem cells. We do a CD34 cell purification, and then we co-cultivate these cells with a vector, the viral vector, to achieve the gene transfer, and after that there is the infusion to the patient. So we have a large part of the process which is done outside the patient, and what we can say is that treatment still needs myeloablative conditioning regimens. You need, of course, chemotherapy before reinfusing the cells to the patient. So, of course, if you need myeloablative conditioning regimens, you could have some complication linked to this regimen. Next, please. And this is the result of the first patient which has been treated by gene addition therapy. Of course, the goal is no need for transfusion. The goal is improved quality of life. For this patient, we obtain no need for transfusion, and we obtain an improved quality of life. But to be clear, what we observe mostly is a reduction in transfusion requirements, and this is already a good result. But so you'll see that in gene therapy, the goal is no need for transfusion, but sometimes the result is not so perfect, but we obtain most of the time reduction in transfusion burden. Next, please. So there are potential risks for gene addition, and maybe you read that before for other models in leukemia patient, but it was with retroviral vectors. And now we use lentivirus vectors, and so the problem of the potential risk to activate an oncogene is lower because the lentivirus gene is randomly integrated in transcription genes and not in promoter regions. So the risk to activate oncogene is not so high for this kind of virus. Next, please. And I told you there is a second way to do gene therapy, is to do gene editing therapy. In this case, we are trying to correct the abnormal or missing genes in hematopoietic stem cell. And remember, I told you about this molecule, BCL11A, and this is very important molecule in the reversal of hemoglobin switching and reactivation of the gamma globulin genes. So with gene editing techniques, we can modulate, we can correct these genes in order to increase hemoglobin switching and to reactivate the gamma globulin gene. Also, we can use this technique also, for example, in a direct correction of the mutated beta globin genes and so on. And we can do that because of a wonderful tool, but I'm sure you already heard about it, is CRISPR-Cas9 techniques. And in these techniques, of course, we specifically designated a guide molecule and associated with a DNA enzyme. This is what we call an enzyme complex, and this enzyme complex is linked to the DNA target. And after that, the abnormal DNA and the DNA strain repairs itself. It's a wonderful tool, and this is one of the tools, first tool, but we have many others. I have no time to discuss about this, but because of this tool, we can do now correction of the gene which is mutated, and we can correct it directly to correct the disease. Next slide, please. Of course, some difficulties are encountered in gene therapy. First of all, of course, is the complexity of the regulation of the globin genes, and not it's so simple. Of course, I discussed about it. The vector, the viral vector, is very important, and for gene transfer, and we have to choose the optimal vector to obtain optimal transduction. Third point. We need for gene therapy a huge manipulation, and we need expansion of cells in vivo and vitro, and we need, I told you, myeloablative regimen, same as stem cell as hematopoietic stem cell transplant. Other point, we have over long-term risk, and this risk remains still unclear, and of course we have some queries about long-term efficacy of this technique, so we need more time. And last but not least, of course, the cost of the techniques, and of course the availability of these sophisticated and expensive approaches, once again, in low and middle income countries, where you find most of the thalassemic patients. So finally, with all these new treatments, what is the long-term outcome of patients? For sure, there is a markedly improved life expectancy for all the patients. But this life expectancy is still inferior to the normal population, and is still, as a consequence, is still heavily medicated daily life. Of course, even we have improvement, this improvement is significantly shorter in low-income and middle countries, and this is a huge problem. You can see on the slides the different OS of the patients. And the ultimate predictor of long-term mobility mortality remains, for sure, appropriate control of iron overload. Next slide. I've quite finished. So what are the current and future challenges beside all these techniques? First of all, and you discussed about this a few hours ago, development of prevention and management programs is essential. Of course, education of patients, education of family, education of medical staff, education of students, and so on. And you have also to prevent the birth of newborns with the disease, genetic counseling, but also screening programs with prenatal diagnosis and with the new techniques of pre-implantation genetic diagnosis. Management programs include optimal blood transfusion and iron chelation practice. Includes also management and supportive care. Nutrition, psychosocial challenges are essential, and sometimes we don't think enough to the psychological consequences of this disease, and management in the context of multidisciplinary care. Management still include international collaborative projects, economic support, and so on, because once again, the therapies have no sense if they don't benefit to the large proportion of patients, once again, including low-income and middle-income countries. Next, please. So, at the end of this trip, in the time, it's time for conclusion. So, the field of thalassemia has substantially evolved over the past few decades, this is sure. Now, there is because of conservative, because of curative therapies, there is a clear improvement of OS, overall survival of patients. But thalassemia is a chronic disease and still a high disease burden, and this is the most important, a large proportion of patients worldwide treated inadequately. And because of current therapies, monitoring modalities, access to care remains a problem, especially once again for low-income and middle-income countries, and we should work on this, and this is a very, very important issue. Thank you so much, and I'm ready for questions if you are. Thank you so much for your attention.
I would now request our Honorable Chief Guest, respected Dr. L Swarankar, sir, Professor of Obstetrics and Gynecology, Specialist in Reproductive Medicine and IVF Technology, Emeritus Chairperson of Mahatma Gandhi University of Medical Sciences, for a few words.
Good afternoon, friends. First of all, I would like to pay my respect and homage to our beloved Dr. Munish Kakkar, a very dear friend, very lovely person, associated with our institution since the beginning, and his wife, Dr. Shadu, is sitting here. She has also have been associated with me as a gynecologist at Jaipur Fertility Center for a few years. A very dear friend and always smiling. And the sudden loss was unbelievable. And to commemorate his contribution and his memory and in this institution, and the asset by Dr. Kapoor, as he was heart and soul of clinical combined around our name, one of the main activity of university, CCR, every week on Wednesday. He was pioneer for the last 10-15 years. So, as a mark of respect, I have already requested Dr. Kapoor, our Vice Chancellor, as well as Dr. Achal Gulati, Vice Chancellor, to make it an annual event that he should be remembered every year, and some distinguished person in the medicine, in the field of pediatrics or genetics or likewise subject should deliver guest lecture or oration in his memory. I congratulate all those who have been awarded this prize for their distinguished paper presentation, poster presentation in Thalcon 25, as well as the wonderful lecture on thalassemia from C level to gene therapy. In his introduction, you have seen that meaning of thalassemia. It is a Greek word, thalan means sea. Anemia is anemia. It started from Mediterranean Sea, the anemia, so it was detected there. So that is how the name came. But nevertheless, it is not only common in Mediterranean Sea or in African country, South Asian country, in our own country, we have a lot of thalassemia patients in our department. And Southeast Asia Center, we have done more than 200 stem cell transplant, bone marrow transplant for thalassemia children, free of cost. And many of our communities, especially Sindhis, Punjabis, Baniyas, other communities, they have an incidence of almost 7 to 8%, 9%, 10%. It's autosomal recessive disorders. So, rightly said that rather than matching the kundalis, जो अपन कुंडली मिलाते हैं कि मंगल दोष तो नहीं, मांगलिक तो नहीं, लड़का या लड़की या और कोई दोष तो नहीं, उसके बजाय we should go for the this testing, screening for the thalassemia trait. And very simple. I have already told my gynae department and department of reproductive medicine that any antenatal patient coming to our hospital at OPD, they must be screened for the thalassemia. And I think they have started doing it already. And these are very simple, hardly costing like this capillary electrophoresis costs around 1100 rupees. And if you go for the NGS sequencing, next genome sequencing, another 4,000 or 5,000. It's not very costly. We have already 3 gene sequence NGS machines also here. And if the mother is positive, then they can go for the test. They have to go for the test of screening of the father, of the husband. And if the patient is pregnant and both are positive, then we have facilities for the chronic villus sampling. I being an IVF specialist, I know that you can do CBS, you can do amniocentesis, and then you can detect the thalassemia patients. And depending on it, 25% of the patient, the child is going to have, in each pregnancy, the child is going to have thalassemia major. But if it's not affected, they can continue. If they're affected, they have option to get the abortion or termination of the pregnancy. Now the blood transfusion facilities are there, but how many times you will give blood transfusion? It has all its complications also, availability also. You can prolong for few years, but very difficult. Complications are there of the blood transfusion. Every 2 to 4 weeks as the child grows, more requirement of the bloods are there, and then you get infections, HIV, other things, and overload, iron toxicity, deposition of the iron in the spleen, the liver, in the renal glands, everywhere, and failures are there. So many complications. But now, the gene therapy is a new introduction. Dr. Rachna is already working on it, and we are in touch with the few of the institutions for this gene therapy, especially CRISPR, CS9 therapy, with some with Government of India also, institution of the Government of India, biotechnology institutions, and private also, as well as to further extend it for the CAR T-cell therapy for the lymphoma and blood cancer patients. So the revolutions are going to come, and the volume of the thalassemia patient is very, very high. Almost 10 to 15,000 of the patients are delivered in our country every year. Even we are doing all patients free of cost, which costs around 10 to 12 or 11 lakhs per patient, and then stay here. So, but that is nothing. If you see the amount of quantity of these patients, number of these patients, resources are very less in spite of the contention from the different companies, CSR facilities which they give under CSR heading. So further resources are required. I thank Dr. G.N. Saxena, Dr. Rachna and their team. They are doing wonderful job, and government of Rajasthan also they are paying. Our university is also contributing. But I have given the target of at least 1,000 stem cell transplant we should perform every year, which we have not achieved. I am telling you for the last 2-3 years. Dr. Isla and Dr. JSS, they are trying their best. It's difficult, but difficult means that it is doable. It's not impossible. It is doable. We have to have the well-known approach different organizations. We have a wonderful team. Dr. Priya is there, Dr. Rachna is there, and other doctors are there, Department of Paediatrics. Then, if we develop gene therapy here, we have all facilities, and hopefully we should be able to develop in the near future. And we are coming up with the Advanced Paediatric Center, a separate building. We are running in the Silver Jubilee year, and separate building is coming with the 250 beds exclusively reserved for pediatric, advanced pediatric patients. So we have everything, infrastructure, equipments, manpower, and MOUs or collaboration with the different organizations. There's full support from the university, and I wish that we should be able to. We have seen the patient, we have seen the patient who get cured, how much happiness we feel. छोटे बच्चे के चेहरा फूला हुआ है because of the extra hemoptysis or fractures and stitches showed. After blood transfusion or stem cell transplant, their growth is very good. They are doing good work, doing good job. कल जो बच्चा आया था वो इंजीनियरिंग कॉलेज में पढ़ रहा था, वेटनरी कॉलेज में पढ़ रहा था, हैं? एक ने PhD कर रखी है। तो ये बहुत खुशी होती है इस बच्चों को देख के कि वास्तव में एक तरह से ये सेवा है, भगवान की सेवा है, पूजा है। इससे अच्छी कोई ईश्वर की सेवा नहीं सकती कि आप उनको फ्री ट्रीटमेंट दे रहे हो, अपने को उसमें एफर्ट्स करने चाहिए जितना अपन कर सकते हैं। मुझे नहीं लगता कि जो मानव जीवन मिला है उसका कोई दूसरा सेवा के अलावा कोई उद्देश्य हो सकता है। बाकी तो हम सब प्राणी हैं, पशुवत हैं, आहार विहार भय मैथुन सभी करते हैं। मनुष्य को एक सेपरेट जो मिला है वो है जो है पुरुषार्थ, अर्थ, धर्म, काम, मोक्ष। तो धर्म के सहित अर्थ और काम, मोक्ष तो थोड़ा आगे की बात है। वो अगर हम कर सकते हैं, उसका जीवन का उद्देश्य है कि जो संसार में है तो सेवा के लिए है। अगर आप मेडिकल फील्ड में हो तो इससे अच्छी क्या आपको, एक तो आप मनुष्य जीवन मिला, उसमें भी आप डॉक्टर, नर्स हो, पैरामेडिकल में हो, डायरेक्ट पेशेंट्स की सेवा करने का मौका मिला। तो इस चीज़ को तो आप चूंकि मत आप चाहे मंदिर नहीं जाए पर ये काम चिकित्सा का काम करें। इस समय देश संकट में, वॉर में, जितना जैसे हमने कोविड के टाइम में अपने आप को समर्पित किया था पूरे हॉस्पिटल को, 1000 बेड, 150 वेंटिलेटर, 5 ECMO मशीन, सब कुछ गाँव पे लगा दिया था, गवर्नमेंट बैंड हो दिया था। डॉक्टर सुधीर वैश्य सर बैठे हमको मार मारे, और हम फिर गवर्नमेंट को लेटर देते हैं कि आप जितनी फैसिलिटी हमसे यूज़ करना चाहें, इफ़ नीडेड, ना करे भगवान ऐसा हो कि वॉर एस्केलेट हो, ये जो टेंशन चल रहा है वो एस्केलेट हो, पर यदि जरूर होप फॉर द बेस्ट एंड प्रिपेयर फॉर द बेस्ट, प्रिपेयर फॉर द वर्स्ट, दैट शुड बी द पॉलिसी एंड वी शुड स्टैंड बाय धीरज धर्म मित्र और नारी आपातकाल बढ़ती चलिए। धर्म है हमारा ज्ञान, हमारा धर्म चिकित्सा, our duty is the medical science, यही हमारा, बाकी कोई धर्म नहीं है। पेशेंट्स की सेवा करना, पेशेंट्स का चिकित्सा करना, स्टूडेंट्स को सिखाना, ट्रेनिंग देना, ये हमारा धर्म है। और इस तरह की क्राइसिस आ जाएगी, आपातकाल है, जैसे कोविड के टाइम में आया था, उस समय अपने समाज के साथ खड़े रहना, अपने देश के साथ खड़े रहना। कोई भी पेशेंट आता है, जिसको इंजर होती है, ब्लड बैंक वालों से मैंने रिक्वेस्ट किया है कि जितने भी अपने डोनर्स हैं, स्पेशली वो नेगेटिव और अदरवाइज 3-4 हज़ार जो डोनर्स स्टूडेंट्स की लिस्ट है आसपास के यूनियन कॉलेज के, हमारे कॉलेज की, वो लिस्ट हमेशा तैयार रखें। 300-400 यूनिट ब्लड, प्लाज्मा, components, everything should be ready. And I'm really happy that Dr. Rachna and Dr. Jaiswal, they have happily agreed that we will be around the clock working for it. We are writing to government also. So that was just out of this, but wonderful presentation by Dr. Frederic Beranard from France. He could not come, he could not get visa, but I think lecture was very simple, very informative. I think most of those were pediatrician. I am a gynecologist. I may not have been able to understand that much, but you must have followed that. And these things we can treat, and not only these, even sickle cell anemia and other hemoglobinopathies can also be treated. That is also autosomal recessive disorder. इसमें आपको ट्रांसफ्यूजन्स की जरूरत नहीं पड़ती और बाकी प्रॉब्लम बहुत होती है, हेमोरेजेस, स्ट्रोक्स एंड अदर थिंग्स हैं। तो इन पर सीरियसली डॉक्टर रचना काम कर रही हैं और हमारे डॉक्टर्स काम कर रहे हैं। मैनेजमेंट आपके लिए फुल सपोर्ट दे रहा है। डॉक्टर बिल्डिंग ऑलमोस्ट तैयार होने वाली है। अभी भी आपके लिए जगह की कोई शॉर्टेज नहीं है, पर फिर आप कितना ही एक्सपेंड कर सकते हैं और ईश्वर की कृपा तो होनी चाहिए। आपको देश अच्छा होना चाहिए। एक बार फिर मैं आपको बहुत बहुत धन्यवाद देता हूँ कि आपने मुझे बुलाया और इस काम के लिए बुलाया जिसमें मनीष मेरे को बहुत प्यारे थे। जब भी बुलाता था मेरी चारों ग्रैंड डॉटर्स का वैक्सीनेशन मनीष ने किया। मनीष मैंने कहा बच्चों को ये करो, पूरा सर में घर आ जाता, मैंने घर नहीं, अब ये मैं अस्पताल ले जाते, कभी घर भी आ जाते थे, बच्चों से खेलते रहते थे, बच्चे आराम से इंजेक्शन लगवा लेते थे। इस तरह से मतलब ही वॉज सो मच फ्रेंडली और उनकी मेमोरी में ये फंक्शन हो रहा है, तो बहुत ही खुशी की बात है। और हमारा पूरा दिल से उनके लिए रेवरेंस, रेस्पेक्ट हमेशा रहेगी, फैमिली के लिए रहेगी। शानू सिंह ने बाद में मिला, अभी भी मिलते हैं और बेटा जब भी कोई आपको जरूरत हो तो वी आर ऑलवेज विद यू। थैंक यू।
Thank you so much, sir, for these wise words and always being a source of guidance and motivation. I would now like to invite Dr. Mohit Vora, Senior Consultant Pediatrics and Gastroenterology and Honorary Secretary IP for the vote of thanks.
Good afternoon, all the dignitaries present on the dais. Chief guest Dr. L Swarankar sir, Dr. Kakkar sir, Rachna ma'am, ND Soni sir, and Dr. Vikash sir, dignitaries of the dais, and everybody present in the hall. It's my honor and privilege to deliver the vote of thanks on this occasion of Thalcon at MGM. First and foremost, I would like to extend my heartfelt gratitude to Swarankar sir, who is the Director and Emeritus Chairperson of MGM, for his unwavering support, gracious hospitality, and for providing us the excellent venue that sets the perfect stage for this academic event. A special thanks to the organizing chairperson, Dr. Vikash sir, and organizing secretary, Dr. Priya, who's a dynamic organizing secretary whose dedication, meticulous planning, and tireless efforts have brought Thalcon to the life and made this event possible. I also want sincerely thankful to all the delegates, participants, chairpersons, faculty members who have travelled from near and far to be with us today. Your presence add immense value to this conference and we are truly grateful for your active involvement. Before I conclude, I would like to make this opportunity to a brief announcement that a midterm Paediatric Infectious Disease Conference, National Conference, is going to occur in Jaipur in early July, that is on 5th and 6th, and the registrations are on. We have a desk outside and a special discount of ₹1,000 given to everybody in all the categories if done today. So, kindly do it. Once again, thank you all for your time, your energy and your contribution to Thalcon, and let's look forward to a successful and insightful conference ahead. Thank you so much.
He was a massive sibling donor. Unfortunately, the kid rejected the graft. So they derived the Pesaro group, derived the risk stratification in the HSCT. So mainly, it is very important, they observed that it is very important, not all thalassemia kids behave same because of the repeated blood transfusions, organ iron overload, all those. So they mainly based on the 3 risk factors of that time, hepatomegaly and portal fibrosis and inadequate iron chelation therapy. They divided into 3 class groups in the pre-transplant risk stratification. So we already discussed that one. So the class 1 doesn't have any risk factors, class 3 will have all 3 risk factors, and class 2 will have either 1 or 2 risk factors. And their thalassemia free estimate was in the class 1 at that time, so 85 to 90% was the outcome. When it comes to the class 3, it was hardly 65 to 70%. So because in the Western countries currently, so the most of the kids will be either class 1 and maybe some kids might be class 2. It is very rare to find class 3 patients in the Western countries, so that's why their outcomes are better. So is the same scenario in India? No, definitely not. Because we know that even though we have the access to blood transfusion and chelation, but still it's like a tip of iceberg. Many of our thalassemia kids, they are not getting the adequate transfusion and inadequate chelation. So most of in our transplant centers, when they come for the transplant, 50 to 60% of them will be in the class 3. So their outcomes will be very much compromised. So even, in fact, in the CMC Vellore had modified the class 3. So now they observed that not all class 3 will behave same. So they further divided the class 3 into high risk class 3 and low risk class 3 based on the age and liver. So those class 3 patients age less than 7 and liver size less than 5 centimeter, they divided as a class low risk, and more than 7 and liver more than 5 centimeter as a high risk. So they observed that in the class 3 low risk, the outcome was almost 65%, as we say in the Western Pesaro classification, 65%. When it comes to the class 3 high risk, the outcome was less than 40%. So the CMC Vellore had remodified the Pesaro classification according to the Indian context. So then coming to as I said, so the same Pesaro group from Professor Lucarelli had presented the 10-year data. So when they started from the 1981, which was unsuccessful, then from 1980 to 1992, they had done complete class 1, all Pesaro class 1 transplants, 89 patients. So in that 82 were matched sibling and 6 were matched related donor, and the conditioning used was the Bucay based conditioning. If you see their outcomes in fact in the 30 years back, the overall survival was almost 95% and event-free for survival was 85%, and the rejection rates were less than 10%. So it shows that the pre-transplant risk stratification is very important. Those with class 1 will have very good outcome compared to the other classes of the especially in the thalassemia transplant. So why it is, we know that the basic pathophysiology of the thalassemia, so unlike malignant conditions, so the malignant diseases would have received multiple chemotherapies, their marrow would have been suppressed. Whereas in thalassemia patients, because of the ineffective erythropoiesis, the marrow will be hypercellular marrow. So those who are not got inadequate transfusion, so the marrow will be very hypercellular, more chances of the rejection of the donor stem cells. And also, if they are iron overloaded heavily, the transplant related mortality mainly due to the conditioning regimens like busulfan, cyclophosphamide, which are more effect on the hepatotoxicity and can lead to sinusoidal obstruction syndrome, other transplant related mortality. So we have to prepare the patients very well before taking into the transplant. So because we know that the class 3 patients' outcomes will be low. So as I said, so the transplant, the factors that might be considered for the decision making, there are many. It's not only about the availability of the donor and the availability of the patient. So there are multifactorial factors mainly when we consider for the transplant. Already we had discussed in previous regarding the financial burden, the social impact, all those. So we have to see mainly the resource availability, the age of the patients, because we know that if the center is not equipped for advanced management of the transplants, we know that the older age group, they will have a lot of morbidity and mortality. And similarly, the capability and the compliance of the medical therapy, and because in the non-malignant conditions, we know that unlike in malignant conditions, we know that even little form of the GVL effect is required in the malignant conditions for the transplant. Whereas when it comes to non-malignant conditions, we don't need any GVL effect. In fact, the main disaster for the non-malignant diseases is they developing something called GVHD. So it's like we are treating the thalassemia and giving the GVHD. So they have to be lifelong. The quality of life will be compromised. So we have to be very much careful assessing the risk of the GVHD, because the compromise in the quality of life and also the lifelong treatment they need for especially the chronic GVHD. So we have to think about that. And we have, if assess for the gene therapy, all those, because we know that the gene therapy is evolving rapidly now, because it's like an autologous transplantation, there is no risk of GVHD, and the rejection rates are less, and the amount of the complications due to unlike in allogenic transplantation, the gene therapy is autologous, the transplant related mortality will be less. So if the accessibility to gene therapy is there, whether we should consider the gene therapy, and as I earlier said, risk evaluation, willingness of the family, and the donor availability, because we know that in HSCT, mainly the thalassemia context, allo HSCT, the matched sibling, the donor, the outcomes are superior when it's compared to the matched unrelated donor or haploidentical donor, but not all families have the chance of getting a matched sibling or matched related donors. So all these factors must be considered before taking to the transplants. We have to have a detailed discussion with the families, then we have to make the decision regarding to go for the transplantation. So as I was speaking regarding the conditioning regimens, so we know that, so because in India, especially in India, the most of the patients, 50 to 60% of the patients will be either in the late class 2 or class 3 high risk or low, class 3 patients. So the same outcomes we might not be with the use of because the traditional conditioning regimen, the busulfan and cyclophosphamide, when we use for the class 3 patients, we will have like 30 to 40% of transplant related mortality. So what is the ideal conditioning regimen? So I think we would have already discussed in the basics of transplant if we had. So the why conditioning regimen is needed in the transplant, it's a sort of preparative regimen before giving the donor cells. So either in malignantly, mainly to eradicate the malignancy, and also in the benign diseases we have to eradicate the host stem cells. So eradicating the expanded bone marrow in the context of thalassemia, but in context of malignancies, eradicating the disease producing marrow. And we have to adequately immunosuppress the host to sustain the engraftment, because if you don't give adequate immunosuppression, the host T cells might act on the donor stem cells and they might cause a rejection. So along with the eradication of the bone marrow, we have to adequately immunosuppress. But at the same time, we have to think it's not only about eradicating the marrow and immunosuppressing, we have to think of avoiding the excess toxicity for the already, we know that most of the thalassemia patients are chronically iron damaged, so they are very susceptible for the damage with the chemotherapy, so we have to be careful in that. So as I was speaking, traditionally until early 2000s, the predominant conditioning regimen was based on busulfan and cyclophosphamide based conditioning regimen. The busulfan being the myeloablative drug and cyclophosphamide being the immunosuppressive drug. So usually along with maybe some heavily transfused patients, they used to use the low dose of TBI. So this was the ideal, the traditional conditioning regimen. But as I said, unfortunately this conditioning regimen with the mainly with the class 3 Pesaro classification transplant patients, they had high incidence of the hepatic complications, especially the VOD, sinusoidal obstruction syndrome, and it was leading to the mortality. So then it came the advances in the conditioning regimen with the development of the triosulfan based conditioning regimen, mainly with the triosulfan combined with the thiotepa and fludarabine. So we know that triosulfan is an analog of the busulfan, but it is a less toxic drug, is a water soluble drug, and linear pharmacokinetics unlike busulfan. So this is the paper from the CMC fellow Vikram Matthew et al. So they had observed the improved clinical outcome in the high-risk beta thalassemia major patients undergoing HLA match-related transplant with the triosulfan-based conditioning regimen, and they used the PBS peripheral blood as a stem cell graft. So if you see here, they compared the retrospectively to the busulfan-based conditioning with the triosulfan. So the mortality was 28% in the high-risk patients when they used the busulfan-based conditioning. It drastically reduced to 12% in the use of the triosulfan conditioning. All patients were class 3. And if you see especially the incidence of VOD, it was 12%, it has reduced to 2%. And even the other transplant-related mortality was significantly less in the triosulfan group. So when you see the specific, so this is the overall class 3, the overall survival was 87%, and in the triosulfan group and the busulfan group it was in the 60s. When you see the class 3 high risk especially, the busulfan based conditioning, the outcomes were in the 40s, 40% overall survival and 35 to 40% event free survival. If you see the triosulfan based conditioning, even in the class 3 high risk, the outcomes were almost equal to the class 1 and class 2, those who had received the transplant. So it's like almost like 80 to 90% the overall survival. So this data suggests that even in the high-risk group of patients, when we use the reduced toxicity regimens like a triosulfan-based conditioning regimen, we can significantly improve the overall and even free survival. So that comes importance of the conditioning regimen. So there should not be an uniform approach. We have to patient-centric. We have to do the conditioning regimen based on the risks associated with the patient. We might have to alter the conditioning regimens to reduce the mortality. So similarly, this was one more paper from the Italy. So the allogenic transplantation in the thalassemia major, results of the reduced toxicity condition based use of the triosulfan. They had 60 patients. If you see in this, there were 4 of class 3, and in fact they had 12 patients, adult patients in this study, and they had done 48 matched unrelated donor and 12 for matched sibling. The outcome of the class 3 adult patients were comparable with that of class 1 and class 2. And they concluded that the triosulfan-based preparatory regimen is a suitable and appropriate option for the minimizing the risk of the life-threatening complications post-transplant patients. So the use of the triosulfan-based conditioning regimen is increasing now, mainly in the high-risk patients in the thalassemia. So when it comes to haploidentical transplant, we know that, as I was saying, there is only 25% of chances of getting the matched sibling or matched related donors in our Indian context, and especially if they have consanguineous marriages, there might be little high chances of getting the donors. But most of the families, 60 to 70% of the families will not have matched related donor, and many of the time we know that as we prolong the transplant, we will lose the patients mainly because of the organ iron overload. So even the advancements of the techniques, the feasibility of the haploidentical HSCT has been increasingly done in the Indian context now. So the advantage of the haploidentical transplant, we know that immediate donor availability, both parents will be haploidentical, both parents will be there. Even for older patients, there the chances that either siblings or either their children will be haploidentical. And even if some rejection, unlike in matched unrelated donors, even if some second transplant they need, readily available of the second graft is available. And even for in context of the mixed chimerism, if needed for the DLI or immunotherapy, donor will be available. And if you compare to the unrelated donor, so when we don't have matched sibling donor, most of the registries, they have to pay extra 8 to 10 lakhs for the unrelated donor procurement. And we know that the incidence of the chronic GVHD is almost like in both haploidentical donor and unrelated donor, it's almost equal. Even in fact, the incidence of the chronic GVHD is more in the context of the matched unrelated donor. So potentially it can be less expensive compared to the matched unrelated donor. But there are major obstacles in the haploidentical transplant. We are doing the transplant across HLA barrier. We know that if the HLA mismatch is there, more chances of rejection, more chances of the graft versus host disease. So the rejection, graft versus host disease. Sometimes mainly in the malignant condition, there is blunted GVL and increased relapse risk. Because we will be using intensive conditioning to prevent the rejection, and also more immunosuppression we will be using in the prevent the GVHD. The slower the immune recovery, more chances of the post-transplant viral infections that can lead to morbidity and mortality, and commonly increasing risk of the infections. So mainly when we talk of haploidentical transplants, it is the play between the donor lymphocytes and recipient lymphocytes. The donor lymphocytes helps in the engraftment, they help in the immune reconstitution, they prevent the relapse with the GVL effect. But the most adverse effect from the donor lymphocytes is the graft versus host disease. Whereas the recipient lymphocytes play a major role in the rejection. So if they are not very well immunosuppressed, the more chances of the rejection because the HLA mismatch. So there are different techniques we have for the haploidentical. So mainly we have to remove the T cells either from the donor to prevent the graft versus host disease. So we have two techniques, mainly on the in vivo T cell depletion, that is with the use of the anti-serum like the ATG Campar, and also the in vivo depletion with the post-transplant cyclophosphamide. The latest techniques with the ex vivo T cell depletion, we can remove the product from the stem cell product. So mainly in the TCR alpha beta depletion, the transplants are increasing with the T cell depletion. So these are the two techniques used for the T cell depletion. So mainly, as I was taking the Baltimore protocol, in vivo T cell depletion, we know that they had introduced cyclophosphamide on post-transplant day 3 and day 4, which selectively kill the alloreactive T cells and spare the regulatory T cells, and also with the use of the CNI and MA from day plus 5, so which they had proved that the feasibility in reducing the chances of the both acute and chronic GVHD, and also with adequate immune reconstitution because the Tregs will be spared. So when it comes to ex vivo depletion, we know that the product, the PBSC product, it consists stem cells and the T cells, B cells and the NK cells. So among these, mainly the NK cells and the gamma delta T cells, which are very important for the immune reconstitution. So earlier when the T cell depletion happened, only CD34 selection happened, every T cell was depleted. But then they saw that the immune reconstitution, immune recovery was very slow and more chances of rejection, more chances of post-transplant viral infection. Now with the advance of the techniques, the selective alpha-beta depletion done mainly from the clean Emax mission. So it is mainly based on the antibody beaded magnetic beads. So they remove the harmful T cells, and sometimes even the memory T cells we can reintroduce as the DLIs, so that we can avoid the viral post-transplant viral infection. So these are the two techniques. So when it comes to the PTCY, so the group from Thailand, another one. So as I was telling, haploidentical transplant, more chances of the graft rejection, because especially in the context of thalassemia patients, because the immunity, the marrow of the thalassemia patients will be robust and hypercellular. If you don't adequately immunosuppress them, then there are more chances of rejection. So the Thailand group devised a novel therapy, that is a pre-transplant immunosuppression. So what they did is, prior to 2 months prior to the transplant, they gave 2 cycles of fludarabine and dexamethasone, 5 days course, 3 weeks apart. So they had immunosuppression. Later they had with the fludarabine IV busulfan reduced based conditioning with the ATG and PTCY approach, that is in vivo T cell depletion. So their outcomes were almost like 90 to 95%. They had said that the outcomes were equal to the matched related donor transplants. So the key success factors in their study was mainly the pharmacologic pre-transplant immunosuppression, very important in the context of the haploidentical transplants. Even with the advancements now, more of the matched related donors, mainly in the specifically the same group had published one paper in the high risk groups in the matched related and matched sibling. They had given 2 cycles of pre-transplant immunosuppression, even in the context of matched sibling. They concluded that the risk of rejection is very significantly reduced by the introduction of the pre-transplant immunosuppression. But uniformly across all groups now, all haploidentical transplants, we give the 2 cycles of the pre-transplant immunosuppression mainly to reduce the rejection rates. And the reduced toxicity conditioning regimen, the outcomes are almost superior. So when we speak about the alpha-beta depletion, it is another different technique, ex vivo T cell depletion. So where we collect the PBSC product from the donor, outside only we remove the T cells and give back to the patients. So earlier, initially there were more rejections and more the post-transplant viral reactivations. So they observed that if you remove entire T cells, the immune reconstitution will be very delayed. So that's why the post-transplant complications. Then they selectively remove the alpha-beta depletion. So they are given the stem cell product, and usually we use the mega doses in the alpha-beta depletion context. So this is a paper from Katrina et al. They had 13 haplo-HSCT. The median age was 10 years. They had done from 2 to 23. Median follow-up there was almost like 40 months. And overall survival is 100% in their group, and event-free and disease-free survival was 92%. And the 5%, 5 patients had experienced the mild acute GVHD, grade 1 and grade 2. They didn't had any grade 3 and grade 4 GVHD, because most of the harmful T cells were removed in the ex vivo. So they concluded that alpha-beta T cell depleted haplo-HSCT is safe and effective in the transfusion-dependent thalassemia with outcomes compared to matched sibling. So, but we have to consider that it takes another 12 lakhs of extra for the kit for the ex vivo T cell depletion. So it might add to the extra compared to your in vivo with the PTCY. So from Indian study, so Dr. Sunil Bhatt from Narayana, they had recently submitted the abstract in the EBMT. So they had from 2016 to 2022 56 patients of thalassemia. They had received mega doses. They had given 18 million per kg. There in the amount 56 cohort, the grade 3, grade 4 GVHD was 5%, and there was no chronic GVHD with this follow-up. And CMV, we know that in the T-cell depleted group, more chances of CMV reactivation. They had CMV reactivation of 26%. So now with the advancement of supportive care, with the introduction of letonavir as a CMV prophylaxis, even that we can bring down. And the overall survival was 92% and disease-free survival was 91% in their study. So there is no head-to-head trial happened, but the retrospectively many have seen both are feasible, so both have similar outcomes, like even in the haplo, this was the abstract presented in the EBMT, where in vivo PTCY the outcomes are almost like in 83 patients they had thalassemia free survival was 96%, in ex vivo T cell depletion it's also like 94%. So mainly it's rather than the technique, it is the pre-transplant, preconditioning and desensitization, because when it comes to haploidentical transplant, mainly we have to look for the donor-specific antibodies in the patients. So if any, it is one of the major obstacle for the haploidentical transplant, more chances of rejection. So we have to do the desensitization, those with the DSA positive. So it is the pre-transplant immunosuppression, pre-transplant conditioning regimen, reduced toxicity with desensitization. These are the crucial for the success of the haplo-HSCT rather than the technique of the T-cell depletion. So then I will briefly tell about 3-4 slides. Mainly presented the data in the EBMT. The Italian group had presented the gene therapy. We all know that the gene therapy is rapidly upcoming. Even maybe in coming years, even Indian settings will have the gene therapy, because we all have all resources. Just need the finances or the burden for the gene therapy mainly. So there are two. One is gene addition and the gene editing, the Betty cell and the extra cell. So they are commercially available currently gene therapies. So they had presented that 18 patients they had gene addition with the Betty cell has done. So all are alive and available. And among them 89% achieved the transfusion independent, and the mean hemoglobin average was 10.5%. Same in the gene editing. So almost 97% were transfusion independent and they were maintaining more than 12 gram per DL. So the comprehensive head-to-head trial is not feasible in this gene therapy techniques, but it's that gene therapy is evolving. So maybe in coming 5-10 years, even we might see that more of the gene therapy happening in the context of the hemoglobinopathies and looking beyond the transplant therapy. So evolving perspectives, until now traditional approach was, because we didn't have the techniques for the haploidentical and advanced techniques, we were offering the hematopoietic stem cell transplantation as an alternative treatment when the classical, the non-curable therapies were inferior and not potential. Then we used to accept the complications due to limited alternatives, and the decisions perceived by the parents or patients are as a necessary, and we were using the protocol-driven set towards the cure earlier. And now the emerging paradigm is we know that with the broadened availability of the high effective curative options we have, like HSCT and gene therapy, and even with the support from the many of the CSR funds and the government schemes, even many of the affordability is not a big obstacle currently for the HSCT in India, and continuously improving life expectancy with the conventional treatment, even though, but the decision making is now strongly influenced by the patient and family perspective. So because this abstract was mainly from the Italian group, but even in the Indian context now, because now the standard of the supportive care, blood transfusion and chelation therapy are improving, so we have to give the option to the patients and families to make the choice for the transplant. We have to give the, especially when they don't have the matched sibling, so we have to explain the pros and cons, and we have to see into our context what is the feasibility of doing transplant, what are the advantages over the conventional therapies. And as I said, the shift from the protocol driven to the patient centric. So mainly because all patients are not same, they might have different iron load, different patients behave differently. So we have to modify the protocols according to the patients. So there is necessity for the genuine shared decision making, acknowledging the parents and patients' individual values and expectations when we consider for the transplant. So this is from one of the paper from the Lucatelli. So sorry for this busy slide. So what it says is any patient less than 14 years should be offered for the transplant, irrespective of whether matched sibling, matched unrelated, haploidentical. So we have to see, because we know that as they, even with the supportive care over the long period of time, they might succumb to the organ iron overload and other transfusion associated infections. So the first choice will be matched sibling, and matched unrelated still is second choice they say, but it all depends on the financial aspects and the center's preference, because many of the centers they prefer haplo-HSCT over the matched unrelated donor. One is financial toxicity and other thing is the, because even in context of easily availability of the donor, we can do haplo-HSCT, and we have the improved supportive care, mainly in the context of the GVHD prevention and GVHD management. We know that with the PTCY approach, the haplo-HSCT has been accessible to the many of the patients. So by concluding, so in the era of the disease modifying agents and gene therapy approaches, still allo-HSCT continues to represent the most consolidated and potential curative therapy to the thalassemia major. So we know that it should be offered at the young age before the development of significant iron overload and disease-specific complications. And with the modern treatment protocols, the thalassemia-free survivals are exceeding the 90% even in the context of the haplo also. So for those lacking matched sibling, now the matched unrelated donor and even the haplo-identical donor, they have the significant improvements in the outcomes. So we have to offer the upfront to the family, to the younger age group, both either haplo-identical or matched unrelated. So careful and dedicated post-transplant monitoring, so which I think next speaker will be dealing with the post-transplant. So we have increased the thalassemia-free survivors is crucial for the late effects and complications can be prevented, and whenever possible the late complications can be recognized at the earlier point of time, can be treated easily. So thank you. So I would like to take the opportunity to thank you my complete team, and thank you all.
Thank you so much, sir, for such an enlightening talk and presentation. Now let's dive into long-term outcomes of transplant and thalassemia with our next speaker, Dr. Vaibhav Shah from Ahmedabad. He is a consultant and transplant physician at CIMS Ahmedabad. Welcome you, sir, on the dais to share your valuable insights on the topic.
First of all, I would like to thank Dr. Priya ma'am for giving this opportunity, as well as the Thalcon organizing team for this wonderful execution of the Thalcon. Dr. Mohan has made little bit easy by laying the foundations of the transplant in thalassemia. So as a normal practicing person, what we feel is whenever we adapt to a newer modality or a newer drug in our system, our basic question is how much efficacy it is. Is it really working to the patients? Is it really getting benefited? So I will shortly discuss this about long-term outcomes, not for the short terms. So when we are discussing the outcomes of the HSCT in the thalassemia major, the outcomes is mainly determined by these 4 parameters. First and foremost is the pre-transplant status of the patient. That is what known as Pesaro's classification, or what mentioned as a Valor classification. So, which is accounting for the iron overload pre-transplant, liver spleen size pre-transplant, which is the very much determinant of the outcome following the transplant. Followed by the conditioning regime, what we are using, myeloablative versus reduced intensity conditioning regime, as well as we know, triosulfan based versus busulfan based conditioning regimes. So all these have a quite similar outcome, but there are still some difference amongst all. Donor source, when we are using the peripheral blood as a bone marrow stem cell source, or we are using a bone marrow itself as a stem cell source, then it affects the outcomes drastically. And the last is the comorbidities in the patient. So in pediatrics, we are having the lesser number of the comorbidities, so eventually the lesser number of the complications in respect to the adult populations. So these are the 4 determinants. And how we measure the outcomes. So outcomes are mainly measured in these 4 terms. Disease-free survival, that means the transfusion independent period post-transplant, how much years patient is independent from the any blood transfusion post-transplant. Event-free survival is any absence of any transplant-related complications in the patients, that is known as an event-free survival. Overall survival, just we look for the
survival of the patients, whether patient is transfusion dependent or independent, is a secondary subject. And lastly, we monitor the quality of the life of the patients, pre-transplant versus post-transplant, and again post-transplant amongst the different groups of the transplant patient. So coming to the disease-free survival and overall survival. So right now, what are the options we have for the thalassemia? So we have one part is the conventional therapy, where we give regular blood transfusions along with adequate chelation therapy. And when we compare that group of the patients with the transplants, thus transplant patients are doing better. So yes, this paper by Kaoki et al. Mentioned that they have clearly compared that overall survival between conventional treatment as well as in the transplant group. And as you can say, the conventional treatment overall survival in younger patients less than 16 years was around 85%, and even post-transplant the survival rate was around 83%. So there is no significant difference. So transplants were doing as good as conventional therapy with an advantage of being transfusion independent. And if we consider whether it was at the risk of mortality, but no, transplant-related mortality or overall mortality was same between both the arms, around 12% in transplant group versus 13% in the conventional group. So they mentioned that initial years, when initial 5 to 10 years, if you compare both the arms, you will find it is an equivalent. Conventional treatment and transplants are doing a parallel job. But after 5 or 10 years, if you compare, then longer term complications of thalassemia conventional treatments are more. So cardiac iron overload, sudden cardiac arrest, endocrinal complications will be long. So in long run, if you see that transplant much outweighs the conventional treatment in terms of the cure. Then this paper by Lucaratelli was mentioned that in younger patients less than 17 years, the class 1, class 2, class 3, what we say is doesn't matter. If you see the class 1, class 2 or class 3 patient, overall survival was 87%, as well as the thalassemia free survival was almost 85 to 80%, even on long run. But when you go from 17 years to above 17 years, so if you transplant an adult with the thalassemia, then your outcome significantly drops to the 60% or below. Maybe because of the multiple transplant-related, transfusion-related complications, alloimmunization, as well as comorbidities associated with adulthood. So that could be the possibility. And the same results were repeated by another study, Icegrow, Subloff. All they have mentioned that class 1, class 2, class 3, low risk versus high risk, it is not drastically different. There is a marginal improvement in class 1, class 2 patients, but if you modify the chemotherapy and if you do downstage well of the patients, then even class 3 high risk patients are doing good with 80 to 90% survival rates. Then coming to this paper from the Thailand, right? So there is a first haploidentical outcomes. So here they have enrolled around 83 patients and they have given myeloablative chemo along with pre-transplant immunosuppressions of Fludex 2 cycles followed by the myeloablative chemotherapy regimen followed by the post-transplant cyclophosphamide. Here also they have achieved 3-year projected overall survival and disease-free survival rate of almost 96%, and there was no secondary rejection. So whoever was going to reject, they have rejected upfront or within very early phase of the transplant they have rejected. But once they have successfully engrafted and they are doing good, there is a very little chance that they are going to reject later on in their life. That is the good thing with the benign hematology transplant. I can say that once they engraft well, they don't reject in the future so badly compared to the malignant transplant where they reject too soon when you try to wean off the immunosuppression and GVL effect goes away. So that is not the case of the thalassemia, what we can say. Coming to our own Indian data about the long-term outcomes. So this was the paper published by Raj et al. So she is doing a transplant in Apollo Chennai, where she has done match family donor, match related donor, as well as match unrelated donor. So if you see the disease-free survival of match sibling donor, it is 96%. Versus match familial donor being father or mother is 94 versus unrelated donor transplant of 84%. So it is clearly stating that the even if the list possible choice of the donor, unrelated donor, you do the transplant, then still outcomes are better than 80%. And younger the age of the patient, better the outcome. But even if you transplant little bit later in life, after 7 years, 10 years, still the outcomes are almost around 90% overall survival is there. So this paper clearly states that donor doesn't matter. Even if you have any availability of the donor, first preference will always be matched sibling donor, then second will be the matched familial donor, followed by haplo is equal to MUD. What we can say from this data, that even either you can go for the haplo transplant with the parent, or you can go for unrelated donor search, and they will have the equivalent outcome with very good overall survival. So it's not that much life-threatening or the scary treatment which we are offering to our patients who are doing good with blood transfusion. Now coming to the event-free survival. So events, which are the events which we commonly see in the transplants of the thalassemia. So early post-transplant phase gets complicated by veno-occlusive disease, sepsis, CMV reactivations, and acute GVHD. So these are very much fatal, especially VOD and sepsis. Very early in the post-transplant phase, it is a fatal. It can cost you around 5 to 10% of your prognosis. So out of 100, we can say yes, we may lose 5 or 10 kids to this type of the complications in the early transplant. But once remaining 90s, they are doing good. Even if they develop the CMV reactivations or acute GVHD with the newer modalities which are available, steroids, ruxolitinib, all this medicine, and for CMV reactivation we have gencyclovir, letermovir, we have foscarnet. With that they are doing good. And late complications are very small number of the secondary rejections and a very small number of the chronic GVHD. So chronic GVHD can affect any organ of the body. It can from the eyes to skin to musculoskeletal system to your hematological system to liver. Every organ can be affected by your chronic GVHD. But majority of the patients, what they say is a mild GVHD. So that is easily controlled with the local treatment or just supportive treatment, and they don't require any intensive treatment for the long. So again, this was the paper from the Revati ma'am only, so where they have mentioned the events between the matched familial donor versus matched unrelated donor. And if you can see, matched related donor, the complications are quite significantly low. Viral reactivation is just 2%, acute GVHD is around 20%, and chronic GVHDs are around 17%. Versus you compare it to the unrelated donor. So it is almost double the incidence of the events in the unrelated donor. So in MUD transplant, even if they are HLA fully matched, these complications are still more common because there are some unshared antigen related issues. Usually we look for 5x5, so 10x10 or 12x12 HLA complex. But certain antigens which we do not cross match, and they can be the source of the problems in the transplant of MUD. So that's why the people are now on the page that MUD versus haplo. So this was the same paper from the Thailand, and their events, if we look on the left, the GVHD activation, GVHD rate was almost around 40%. So it is still quite high, and even CMV reactivation was around 20-25%. If you see the bottom 4 lines of this table, that is the mortality. Out of 83 patients, only 4 mortality was there, and out of them 3 were lost because of the sepsis. 2 had a pneumocystis jirovecii pneumonia and 1 had bacterial infections. Only 1 patient had a GVHD and patient eventually succumbed. So if you see the complications list, whatever will enlist, but they are not life-threatening. Most threatening is the febrile neutropenia. So if with your good supportive care you are able to manage the febrile neutropenia well, your 90 to 95% of thalassemics should do good with your transplant, irrespective of the donor, irrespective of the conditioning regime what we are using. So coming to the quality of the life. So we all have seen the thalassemic kids day in, day out in our hospitals when they are coming for the transfusions. They are ashamed of their body size, body color, they are lagging behind in the scholastic performance because of the school absenteeism and all that. So many issues they are fighting upfront, along with their families are also doing that. So whether our transplant is offering any benefits to their quality of life. So this was the same Keoki et al. Paper which has shown that it is significantly improving the quality of the life post-transplant. So conventional treatment, there are 4 domains they have divided: physical functioning, emotional functioning, social functioning, and scholastic functioning. So if you see the scores of the conventional therapy versus transplant mean, there is a huge difference in the physical functioning and school functioning. So these are the 2 domains. Their exercise tolerance capacity gets better. They do engage in the sports activities. They do like to go to the schools. They get achievements in the academics, and they do very well in their life and career. So yes, it is definitely a changing concept for the whole family. They do very well quality of the life. So yes, after multiple failed attempts, it looks like we have reached closure to the near perfect therapy for the thalassemia, where we will achieve good cure for all our thalassemics, and gene therapy coming in near future. It may be the 100% cure. But still, if you see in a whole, we are somewhere lacking something. We are still not near to the center of the treatments. So still there are plenty of the unresolved issues we have to sort out before making it a norm. So still we are suffering, patients are suffering from chronic GVHD. Especially they get unrecognized because post-transplant 6 months, 1 year they are on immunosuppression. They come regularly to the hospitals, but once they are off immunosuppression, they don't bother. For smaller complaints, they go repeatedly to the local doctors. They treat them as an infections or something like that. Majority of the patients have a recurrent episodes of coughing, respiratory distress. They go to the local doctors and they were treated like a asthma or chronic lung disease, but actually it is a chronic lung GVHD which requires a prolonged steroid supplements. Same way, sometimes they develop the contractures or difficulty in the musculoskeletal system, difficulty in walking, difficulty in uplifting the heavy weights and all that things. But again, it gets unnoticed. It looks like they are fatigued because of the low hemoglobin. But these are the musculoskeletal GVHD, and if you see this kind of picture, they are excellent outcome with imatinib and other immunomodulatory agents, that all issues get rapidly resolved very nicely. The second complication still we have to achieve is the post-transplant growth. Even if with best of the outcome and best of the overall survival we are providing, the patient, if you see even after post-transplant, they all are short stature. They never achieve their pubertal height which they are supposed to achieve. Yes, pre-transplant transfusion and iron overload plays a major part in damaging that growth. And by the time they come to us for the transplant, they are already damaged endocrinal system, so that that growth cannot be ever achieved. But that's, as a whole community, we have to plan that we should optimally treat pre-transplant so that iron overload and endocrinal problems are less. And as a hematologist, we should find out the alternative chemotherapies which is minimally affecting their endocrine systems, so that post-transplant growth is no bigger challenge to them. Another, now with transplant, we are giving them the life. We are prolonging their life and they are doing good. So once they are doing good, they have good career. Obviously, everyone think about getting married and getting reproductive life as well as to have the child. But as we all discussed, because of the pre-transplant iron overload as well as the chemotherapy, cyclophosphamide and all chemotherapy, which is very myeloablative alkylating agents which we are used, it is completely causing infertility, especially in the girls. So currently what we are seeing is 40 to 50% of the females are infertile. They don't achieve the menarche which she was supposed to achieve at 14-15 years of the age. On the contrary part, males who underwent transplant at a younger age, they do achieve some of the secondary sexual characteristics. But again, we don't know how much the quality of the sperm and whether they will be able to reproduce in future is almost required. So again, the solution to this is, nowadays what we are doing is Transplant at the younger age when your ovas and your sperms are in the dormant stage, then chemotherapy is not that much harmful. So younger age transplant, lesser the fertility related issues. And even if you have to transplant any adolescent, then there are now the options of preservation of the ovum as well as the preservation of the sperm. So these are the issues nowadays we have to discuss with the family when especially adolescent thalassemics are coming to the transplant, that these are the potential toxicities and there are the ways you can have in future your own child. Post-transplant iron overload is also a reality, even if we say they are transfusion independent, but as Dr. Frederic mentioned in his presentation, the whole problem in thalassemia is related to the hepcidin also. Their hepcidin level goes down. So all over they have the tendency to absorb more and more iron from their gut, and that's why they are chronically having the high ferritin. Yes, there are certain other reasons also. We all know ferritin is being acute phase reactant, so some chronic mild GVHD, it is like a chronic inflammation, and any chronic inflammation will increase your ferritin. So it is not just the ferritin we have to look for. We have to look for the trend of the ferritin post-transplant, as well as we have to look for the transferrin saturation, because that is unbound ferritin, unbound iron, which is causing the problem. So if your iron saturations are less than 80% and ferritin is in reducing trend, that child will eventually do good without any treatment. But those with persistently high ferritin and persistently high iron saturation above 80 transferrin saturation, they do require phlebotomy and they do require iron chelation post-transplant also for the few months to few years. And the last is the risk of the secondary rejections. Yes, people do reject after 2 years, 5 years, 10 years of the transplant. Rejections will be more common with the haplos and mud transplant compared to the sibling transplant, but that is not the hurdle for the transplant, because the early rejections are worrisome because body has received so much chemotherapy, patient is neutropenic, immunocompromised, so risk of the sepsis and everything is more. The later rejections are not that much harmful, that not that much serious because it is not life-threatening. And patient will always have the second option of second transplant later on anywhere in their life. So early transplant is directly life-threatening, so we are doing all the ways to reduce the early rejections. But secondary rejections are there, but we are not that much worried, and so just on the doubt of secondary rejection, patient should not be refused the transplant. So if I want to summarize the thing, BMT is the only curative options in today's era at this point of time in our country with maximum benefits, and in that too in the cost effective way, not in generalized way. Donor source is not a big deal. Any donor can do well irrespective of the haplotransplant or matched sibling related transplant. Early post-mortem complications are life-threatening, and if you manage them well, it leads to the better outcome in the long run. It changes the quality of life of family together, so it's really a wonderful treatment. And as a hematologist, we should try to individualize all BMT and not take it as a generalized therapy, and modify on the patient-to-patient basis so that we achieve a maximum outcome with minimal long-term toxicities, and we should do a proper counseling pre-transplant as well as the post-transplant about all the potential complications. Thank you.
Hematopoietic stem cell transplant in thalassemia, match-related donor and match-unrelated donor. Let's extend a warm welcome to our next speaker, Dr. Anamika Bakriwal, Senior Consultant and Unit Head in Department of Hemato-Oncology and BMT at B.L. Kapoor Max Super Specialty Hospital, Delhi. Ma'am has a rich experience of more than 10 years in this field.
So hi, good evening everyone. Thank you Priya ma'am, Dr. Shraddha and Dr. Jaiswal for having me, and it's always good to come back to Mahatma matter. So yeah, well, Dr. Mohan and Dr. Vedha have already spoken in detail about the thalassemia and everything has been discussed very well. So I'm just going to give you an overview. We already know so much about thalassemia and the transplant, so this is just an overview of and few case scenarios of what we do at our center. So
Yeah, we all know MRD and so match-related donor transplants and match-unrelated donor transplants in thalassemia. Now, the issues that I'm going to discuss is the brief introduction about thalassemia, the disease burden, what does the ISBMD data say, and where do we stand as far as thalassemic transplants are concerned in India at this point of time. A little bit about the risk stratification for bone marrow transplant, the indications of transplant, the case scenarios, and post-transplant complications. We all know that hemoglobinopathies include all genetic diseases leading to abnormal hemoglobin production. Patients present to us within 6 to 9 months of life with severe anemia, and if not treated with regular blood transfusion, they die within the first 2 years. So, allogeneic stem cell transplant is the definitive cure for thalassemia major and should be considered early in the disease course. Now, allogeneic stem cell transplant have a cure rate of almost 85% to 90% for sibling matched donors with age less than 16 years. Now, myeloablative conditioning regimen is the most commonly used regimen, and it can result, though it can result in toxicities such as growth impairment, gonadal hyperfunction, and infertility issues. Well, we are also using RIT regimens which are associated with more favorable toxicity profile, but they can be associated with high rates of graft rejection. Now, what is a disease burden? As you can see, the beta thalassemia is the most common population surrounding the Mediterranean, the African, the South Asian ancestry, the tropical and the subtropical regions of the world, particularly where malaria is also endemic. So IDS15 mutation is the commonest mutation found in the Indian population, whereas 1619 DP deletion is common amongst the North Indian scenario. Now, what are the high-risk groups in India? Sindhis, Punjabis, Gujaratis, Bengalis, and Saurashtrians. But unfortunately, 10,000 newborn babies every year with thalassemia are still born in India. Now, not a very happy news, but India is still the thalassemia capital of the world with almost 40 million carriers and over 1 lakh thalassemia major under burden transfusion every month. So the world's thalassemia capital, as we call ourselves, 35 to 40 million carriers in India and 1 lakh thalassemia majors, of whom 50% will not survive beyond the age of 25, and 10,000 live births of thalassemia major every year. So, an annual cost of blood transfusion and deferoxamine treatment for one patient with thalassemia major has been reported to be $30,000 US, which comes out to be approximately 10 lakh per Indian if we think of in Indian currency. A lifetime healthcare cost of caring for a person of thalassemia born with this problem versus cost of national screening program is 4:1. Now in India, the cost of treatment of an average child, let's say a 4-year-old child, is around 90,000 to 1 lakh annually in a private setup. The government is doing a great job by helping them nowadays. Therefore, not more than 5 to 10% of thalassemic children born in India receive optimal treatment. And bone marrow transplantation as a curative treatment costs somewhere between 10 to 16 lakhs. And if we talk about matched unrelated donor transplants and haploidentical transplant, this can very well exceed up to 25 to 30 lakhs. So where do we stand as of now in terms of the BMTs being done in India? What does the Indian Society of Bone Marrow Transplant data over a period of last 20 years reflect? Now, so this is the ISBMD registry data, which is from 1983 to 2020, speaks about the last 20 years. So these are different disorders where matched sibling donor transplant has been indicated, and thalassemia major constitutes around 12% of that chunk, whereas indications for allogenic transplant is somewhere between 21%. Now in pediatric age group, we can see thal majors almost 36%, so they include a large chunk of this indication, which is indicated for allogenic transplant. Now this is a paper that we published at BLK Max. We did a retrospective study from our patients from Jan 2008 to September 2017. Well, the primary endpoints were overall survival and to look for thalassemia-free survival. So we did this was a data comprising of almost 203 transplants, and this data surely reconfirmed that allogenic transplant is feasible in developing world with the overall survival and thalassemia-free survival compared to that reported in Western literature, and should definitely be considered early in all thalassemia major patients with available matched sibling donors.
Now, risk stratification, I'm going to quickly run through it because we've already spoken about it in detail. So, how are thalassemic patients risk stratified for allogeneic stem cell transplant? The Pesaro group, we all know, developed a prognostic scheme to predict transplant outcomes in thalassemia major patients younger than 17 years. And this prognostic scheme basically included 3 variables, all related to iron burden, and the quality of chelation is important. So, the first, the quality of chelation received for the entire life before transplantation. Hepatomegaly greater than or less than 2 cm, and the presence or absence of liver fibrosis in pre-transplant liver biopsy. So it was the Ukrainian classification states that as class 1 where patients had no such risk factors, class 2 included patients those with 1 or 2 such risk factors, and class 3 those who have all 3 risk factors. So now this is a study by Dr. Vikram Matthews from CMC Vellore and their entire group. This is data from the South India part of the country, where a new stratification strategy that identified a subset of class 3 patient with adverse prognosis among children with beta thalassemia major, who were undergoing a match-related allogeneic stem cell transplant. So there were few new approaches for BMT in children, which we are anyways doing for all our haploidentical and match unrelated donor patients, where we do give them pre-transplant immunosuppressive therapy, usage of hydroxyurea, hypertransfusion, regular iron chelation for at least 6 to 12 months before the child has been taken up for transplant, and hydroxyurea in order to decrease the erythroid expansion. So I'm going to quickly take you through some case scenarios now. So these are the real case scenarios, just the few that we have done in our center. So this was a 5-year-old girl with transfusion-dependent thalassemia. She was referred to us, and she underwent a matched sibling donor transplant. Her brother, who was 8-year-old, was the donor, and so she underwent a full matched donor transplant. She was usually class 2 as per the risk classification, and in view of persistent transaminitis, she underwent a liver biopsy baseline, which was not suggestive of fibrosis. She received a Seaside-based myeloablative conditioning regimen prior to transplant. The stem cell dose was 3.34 to 10⁻6 kg. And on 15th of June, ironically, which was also my son's birthday, because immediately after this particular photo you see, I went into labor. So this was my last transplant just prior to the labor. So post-transplant, she developed BK virus hematuria, for which she was given supportive care and her immunosuppression was reduced. Her chimerism was 99.6% on day 67, and it was 99.8% on day plus 150. She's presently doing fine, and she's on, I wouldn't really call her a regular follow-up, but yeah, is following up. And she had lost her mother too early in her life, so she comes with her dad. But yeah. Then another case, and this is that sweet girl, of course, you can see. Then another child, this was a 4-year-old boy with thalassemia major since the age of 8 months. He was hepatitis C positive because of recurrent transfusion. He was usually class 2 as per the risk classification. He underwent liver biopsy, which was not suggestive of cirrhosis or any active hepatitis. He underwent Seaside-based matched sibling allogeneic transplant from his brother, who was 10 years old. He received a methotrexate cyclosporin-based GVHD prophylaxis, and he engrafted on day plus 90. Post-transplant, he developed seizures on day plus 23, and the MRI brain was suggestive of PRES. Later on, his GVHD prophylaxis was shifted from cyclosporin to tacrolimus. So on day plus 31, he also developed frank watery diarrhea and was suggestive of acute GVHD. He was started on Solumedrol, and for the same, he was kept in the hospital for a prolonged time because of these complications. The diarrhea stopped within 3 days, and the child's immunosuppression was also slowly tapered and then restarted again. The child is currently stable with 100% chimerism post almost 2 years of transplant, so he's pretty much doing well and is regular on follow-up. Now coming to another case. So she is an 8-year-old female, short stature, transfusion-dependent thalassemia with no matched sibling donor. She underwent a matched unrelated donor transplant. She was usually classification 3 as per the classification, And the conditioning regimen given to her was TTF plus ATG based conditioning regimen. The GVHD prophylaxis given to her was methotrexate and cyclosporin based, and she engrafted on day plus 70. She again developed acute gut GVHD, watery loose motions. A colonoscopy done was suggestive of the same. CMV PCR was negative and there were no intrusion bodies seen that time in the colonoscopy colon biopsy report. She was treated with Solumedrol and she responded well to the treatment. She had poor graft function as her counts did not improve considerably as expected. So we did keep a CD34 stem cell boost in mind, which was planned, but eventually and thankfully it was not required as the counts improved on its own and her donor chimerism always remained 100%. Now at present she is 2 years post-transplant and is undergoing phlebotomy for an increased iron stores. As Dr. Weber mentioned, this is an ongoing problem that we battle with most of the transplant patients with high ferritin levels requiring phlebotomy. So yeah, she was from Goa. And so the last case, she was a 7-year-old girl from Kota with thalassemia major. She underwent pre-transplant immunosuppression with Sudra and Dexa cycles. She was leukerally class 3 as per the classification. She was taken up initially for haploidentical stem cell transplant with her father. I like to mention that the father and the mother's DSA was negative. The conditioning regimen consisted of ATG, Flucide, EBI, and the GVHD prophylaxis given was cyclosporin based and methotrexate based. Now, DSA of both parents are negative. Patient did not graft after 30 days. So the mother was taken as the donor and she underwent a second transplant. So this time she was given a RIG conditioning regimen and the GVHD prophylaxis this time was cyclosporin, mycophenolate and tacrolimus based. Cyclophosphamide, MMF and tacrolimus based. On day plus 41 she developed CMV reactivation and was treated with injection ganciclovir and she responded well to it. Now she is post almost 2.5 years post-transplant and is doing well. Her chimerism is 100%. She doesn't very regularly follows up with us nowadays as she is already following up with a local pediatrician, is doing pretty well in terms of growth. Surprisingly, I was very happy to see the prescription that the pediatrician had given, very detailed pediatric endocrine analysis post her transplant, so that was really welcoming to see. Yeah, so now conditioning regimens in MSD and MUD, we've already discussed it. Preparatory or conditioning regimens for transplant for hemoglobinopathies, they are basically given to achieve two objectives: elimination of the affected marrow and prevention of rejection. This has been accomplished by myeloablative conditioning regimens. The rationale behind the success of RIG conditioning and non-myeloablative regimens with the observation that mixed chimerism, this is an important point that we must remember, especially when we are dealing with hemoglobinopathies, that mixed chimerism is sufficient for the abolition of diseased marrow and achieving cure. So that's where the usage of RIG and non-myeloablative conditioning regimens can play a fairly good role. Now, RIG in transplants have been used to mitigate the acute toxicity associated with MAX myeloablative conditioning regimens like hepatic sinusoidal obstructions, neurotoxicities, late effects such as growth failure, hypogonadism, infertility and secondary malignancies. It's not like that we don't deal with these sort of toxicities after RIG regimen, but they are definitely and considerably low as compared to what we have seen with MAC regimens. Now, stem cell transplant is a form of cell therapy that uses allogeneic donor stem cells to replace the gene of interest in patients suffering from thalassemia major or thalassemia transfusion dependent patients. A MAC regimen of BU 16 mg per kg, these days we are obviously giving IV, so an equivalent of that would be 12.8, and Psi of 200 mg per kg with ATG has been established as the standard regimen for thalassemia major. The BU-based MAC forms the basis for the currently used conditioning regimens, but it has been associated with increased toxicity in class 3 patients. Now, use of BU-Flu or Flu as myeloablative conditioning results in comparably higher cure rates. These are few, studies that have been performed on different conditioning regimens that have been used in unrelated, that is matched unrelated donor transplants. And with the use of Thalcon, Thyroidine and Fludrabin, there is definitely considerable reduction in the toxicity profile in what we see as compared to a MAC conditioning regimen. And these are again conditioning regimens are used in various transplants. The preferred source of transplant, we all know bone marrow is the most frequently used in the stem cell source. The risk of both acute and especially chronic GVHD is higher with PBFC than with bone marrow as a source of stem cells. The benefit of PBFC are easy donation, ability to harvest those, faster hematological high stem cell recovery. Talking about the drawbacks of cord blood, longer time to engraft with associated with high risk of infection, bleeding complications, and unavailability of donor cells in case of engraftment failure. Again, these are again few studies in match-related donor transplants for Thal patients. I'm going to please skip this because we've already spoken about this. Now, indications of transplant. So, all thalassemia major patients should undergo a transplant. The preferable age that we quote is definitely between 3 years to 7 years of age. Where we think this is a beautiful age number where one should consider taking these patients up for transplant as early as possible. Now, adult thalassemia and high-risk candidates for hematopoietic stem cell transplant. So, as the age increases, the iron overload and related organ damage also increases, such that adult patients are not able to tolerate myeloablative regimens and have high RRTs. These patients have more advanced diseases, mainly due to prolonged exposure to iron overload, damage to multiple organs, particularly the heart and liver. So, patients who are more than 7 years old and have a liver size of more than 5 cm constitute a very high-risk subset of a conventional high-risk class 3 group. Now, where are we heading with haploidentical transplants? As Dr. Mohan said, that we've had a considerable good reports post haploidentical transplants, and one should definitely, I think, incorporation of good novel therapies and conditioning regimens can really help us get haplotransplants even further ahead. So, what is the role of haploidentical transplant? The initial result of haploexceding hemoglobinopathies were marred by various complications, including high incidence of graft failure, GVHD, delayed immune reconstitution, life-threatening infections during periods of prolonged neutropenia. So, the two major advances which led to the successful implementation of haploexcedes were, as we've already spoken about it, either ex vivo T-cell depletion or in vivo T-cell depletion with PTCY. To further reduce the risk of graft failure, we need a need for PTIS in absence of DSA. A sibling is preferred and GVHD prophylaxis with PTCY. Now, how do you manage management of ex-thalassemia patients? By ex-thalassemia, I mean patients who have post-transplant. And so iron overload is something that we battle with a lot. Endocrine dysfunction is certainly on top of our list. Liver dysfunctions like chronic hepatitis and liver fibrosis, growth monitoring and cardiovascular disorders. So, are there any PG students here? Any PG students here? Anyone?
Not anymore.
Not anymore. Thought of asking a question. So, just quickly winding up, post-transplant complications, we all know there are early and late complications, and as he clearly pointed out, Dr. Weber, there was one of our patients also who had, eventually we found out that she had chronic liver GVHD, but she was being treated for bronchiolitis, bronchopneumonia, given 3 to 4 weeks of antibiotics. So it is important for patients to, be monitored and come regularly. So the early complications that we deal with is infections like bacterial, viral and fungal infections, non-infectious complications like hemorrhagic cystitis, sinusitis obstruction syndrome, TTP, respiratory complications, acute GVHD, and the late complications are eye complications like cataract, Zika syndrome, dry eye, cardiovascular, respiratory, hepatic, and the list is ongoing. So yeah, the take-home message would be all patients with thalassemia major should definitely undergo transplant, especially between 3 to 7 years of age, and they should undergo bone marrow transplant. We should catch them quickly. MAC is the preferred regimen in match sibling donor transplants. The haploidentical transplants are definitely not lagging behind. They are doing pretty well. Bone marrow is the preferred source of allogenic transplant. Complications like GVHD and CMV reactivation are some of the common complications that we see. And need of incorporation of more novel agents as a part of conditioning regimens in future so that haplotransplants can also become an integral part of our treatment system. Thank you.
Thank you so much, ma'am, for such an informative talk and discussing various case scenarios. Now I invite Dr. Rajiv Kasliwal, sir, Professor and Head of Department Endocrinology, Mahatma Gandhi Medical College and Hospital, Jaipur, for his insights on the topic Growth and Development Post-Transplant.
Good evening, everyone. So I think I am the last one. My topic is post-transplant growth and pubertal development, as I was just listening in last 1 hour or so. That endocrine toxicities are being again one of the most common long-term sequelae. So, but this is more about the all kind of transplant which we see both benign and malignant conditions. So, the regimes which we use for conditioning and other things may differ from condition to condition. So, it's the overall data what is going to happen after transplant in terms of hematopoietic cell transplant. So, it's going to be introduction, then its impact on thyroid, growth, puberty, and there are certain specific things which we follow in patients with thalassemia. So, as I think it's hematopoietic cell transplant has become a standard of care for various malignant and benign conditions, and the survival of these patients are improving day by day. So, it's very important for us to address those long-term sequelae once the patient recovers from the original illness, and it's always like it's a human nature. They always ask more. So once they get rid of the thalassemia, then they want normal growth, then they want normal puberty, then they want normal reproductive functions, and it's understandable also. So I think that is why it is very important to take them early and treat them early. So very important thing I think that decides about the long-term endocrine sequelae as far as concerned is what kind of conditioning regime we have used in those patients. So that history, whenever a patient is being seen by an endocrinologist, has to be taken very carefully because the toxicity depends on the kind of conditioning regimes you are using it. There are multiple drugs. I think I don't need to tell these things to you. And then there are types of radiations. Different radiation protocol are being used, single, TLI, TBI, TL, and then single fraction, multi-fraction also. Why it is important to know? Because every one of them has their different separate toxicity profile, especially when it comes to endocrine functioning. And then the most common thing which get affected is the growth hormone. It's like growth failure basically. Then there's a pubertal failure, and third one is basically the thyroid dysfunction and then thyroid neoplasia. So the key factor, as I just mentioned, is one is definitely the type and intensity of the conditioning regime. That's the most important one. Second one is at what age the transplant was offered, and somehow the data suggests that boys do little worse than the girls when it comes to endocrine functions. So coming to the thyroid functions, we all know that it's a very important hormone which is responsible for growth, especially during childhood period. Various metabolic dysregulation also happen because of hypothyroidism, and then there is a long-term risk of developing thyroid neoplasia. The figure when it comes to thyroid dysfunction is almost around 1/3 patients develop subclinical hypothyroidism, and almost 10 to 15% patients develop the overt hypothyroidism at the end of 3 years or so. And of course, it all depends what kind of the regime which you are using. With chemotherapy alone, whether it's a cyclophosphamide or it's a busulfan cyclophosphamide combination, it's relatively less affected. But with TBIs, whether it's a single fraction or multi-fraction, of course single fraction is more toxic. The incidence is quite significant. And all these endocrine dysfunctions, when it comes, the incidence and prevalence depend when you have tested them. So as the time passes, actually the prevalence of these deficiencies increases. Like when we talk about thyroid dysfunction, the incidence of thyroid dysfunction or prevalence of thyroid dysfunction can reach up to 70% 20 years down the line. So so regular follow-up or regular monitoring is very, very important even if they are not there immediately after transplant or so. So this is just the upper one is showing that the cyclophosphamide, busulfan alone have a lesser incidence. The highest the toxicity, thyroid toxicities happen with busulfan TBI combination. And if the transplant is being done at earlier age, so that also affects the ultimate thyroid dysfunction also. They have a higher chances. So sorry, at late age. So and then as I discussed that the TBI plus busulfan regime care is highest, especially conditions like Hodgkin's where we use local radiotherapy as a part of pre-transplant treatment. There we focuses the neck area and in the direct exposure of thyroids. Those cases have a highest risk of developing thyroid dysfunction later on. As I just mentioned earlier, single dose TBI is more toxic, almost 50% incidence of thyroid dysfunction compared to fractionated, where the incidence is somewhere around 15%. And it is mostly the primary hypothyroidism, that's what we want to know, because that is very important to diagnose them early, because if we TBI can lead to central growth hormone deficiency, but it does not lead to central hypothyroidism. So that is, it's important to know, because that is how we are going to decide whether you are going to use T3, T4, TSH for screening or only TSH. So it's basically primary hypothyroidism leading because of direct thyroid toxicity, not because of the hypothalamic pituitary dysfunction. The second important part is the risk of neoplasia in these children. Normally thyroid cancers are very uncommon in pediatric age group. However, children, especially chemotherapy regimens, do not lead to increased risk of neoplasia. It's the TBI that leads to increased risk of neoplasia. Again, the prevalence depends whether you are clinically doing the screening or the USG. The incidence on USG in the nodules can go up to 50% almost. And again, the onset of disease can be anywhere 2 years down the line to 40 years, 30 years down the line. And the peak incidence is generally being seen around 15 to 20 years down the line after the transplant. Just to emphasize the fact that the risk of thyroid neoplasm in a patient who would receive some sort of radiation to thyroid is almost 53 times higher than what it is there in normal child. So that is kind of a relative risk we are looking at it. So the screening is quite important, and it's a readily doable screening. Now treatment wise, I think I will not go into detail. It depends on whether you have overt or subclinical. Overt are a clear guideline. In subclinical, it's more of a patient to patient basis. Thyroid nodule, if it's benign after FNA, you can monitor them. If it's malignant, generally these nodules who have been generally thyroid cancers, which happens after radiation exposure, have actually poorer prognosis compared to the the garden variety thyroid cancer. So we need to be more careful and more intensive in terms of treatment in these patients. Coming to the growth part, again the growth is a multifactorial thing, and one of the key factor is the hormones in addition to genetics and nutrition. And different hormones play a role differently when it comes to different age groups. Like initially it is GH and thyroid, later on it's a GH and actually sex hormone. And so combination of deficiency will ultimately affect the outcome in terms of growth. Normally we will see the delay or growth default, after 2 to 3 years of transplant. Thalassemia is a different case because there is already pre-transplant lot of stenting, but it's, as I said, it includes all kind of patients, including acute conditions like leukemia. So normally after transplant, 2 to 3 years it takes for the growth failure to manifest. The factors which affect ultimately the growth is total, whether we have used TBI as a conditioning regimes, whether patient have received craniospinal radiations as a part of pre-transplant treatment, then what kind of chemotherapy, cyclophosphamide or busulfan cyclophosphamide, both, and the age of transplantation, then chronic GVHD after transplant, because many of these patients receive long-term steroids, which again is a very deteriorating effect on the growth. So that is also there. And then if the puberty is affected or not, because on the later spike which we see during pubertal age, it is a combination of GH plus sex hormones. So the deficit is going to be more if both are going to get affected. As I just mentioned, chemotherapy only regime, cyclophosphamide it causes the least toxicity. Busulfan is a drug which can cross blood-brain barrier. It has a neurotoxic effect, so it will affect hypothalamus. So any regime which is containing busulfan is going to affect the growth. However, and then of course chronic GVHD and steroid use will also affect the growth. This is just to highlight the long-term growth outcome, growth velocity in terms, especially as we can see. Normally what we have is pubertal growth spurt whenever the puberty happens, but because of the the use of these conditioning regimes, especially containing busulfan, there is a blunting or flattening of the pubertal growth spurt. So ultimately that leads to, or that contributes to, the lesser final adult height. So it happens both boys and in girls. So but the most important toxicity in terms of growth happens is in the patient who have received TBI as a part of their conditioning regimes. The same principle, single dose is more toxic than fractionated one, and the prevalence after single dose is almost 75 to 80% of growth hormone deficiency, while it is almost 40% with fractionated. So fractionated though have a lesser toxicity, but still they carry significant risk. So these patients needs to be monitored very well in terms of growth. Now another factors which is very important in these patients are that the growth, spinal growth or the upfront growth is affected more compared to the limb growth. So that we need to keep in mind. Younger the age, greater is the risk, because younger the age, more is the growth potential. And if you expose the bones early or the growth hormone deficiency early in the course, it will lead to more deficit in terms of growth. And again, somehow the boys are affected more than the girl. And especially in patients, again, those who have received the cranial boost because of the underlying condition, those are going to get affected more severely compared to those who receive only TBI. And clinically, we can always, diagnosing the growth hormone deficiency is at least screening is very simple. You have to just take the height, calculate the growth velocity, which we can do in our day-to-day OPD. And once they fails in terms of growth velocity, then maybe they can be seen by dedicated endocrinologists to further decide about the treatment and evaluation. The important thing which I will need to highlight is that onset can be delayed, so wait for 2 to 3 years to see whether the growth is affecting or not. GH is a pulsatile hormone, so doing a single GH is not going to rule out. There are specific special tests that are available that should be done. And IGF-1, which is generally a good marker in idiopathic or congenital growth hormone deficiency, is not a good marker to screen the growth hormone deficiency. In post-transplant patient, the sensitivity specificity is almost 50%. So that we need to keep in mind. GH deficiency impact is not only in terms of linear growth, it affects, especially in adolescent age group, it also have an impact on percurrence of peak bone mass, so very important. Otherwise, they are going to be osteoporotic and then they are going to have a fracture, then again development of lean body mass, then the dyslipidemia and long-term cardiovascular risk problems. So it's not about just the growth, it's actually multi-system affection. Now coming to the impact of GH therapy in these patients, just to see this graph, if we treat growth hormone deficiency timely, just to say in this cohort, like patient who had an age of transplantation less than 10 years and received growth hormone, they have a least deficit in height SDS compared to those patients who have a transplant below 10 years but did not receive growth hormone. More than 10 years, because again most of the growth has happened already, and so the residual growth is less, and then especially puberty is spared, then the benefit of GH may be plus minus. But again, data is old. There is, to be honest, there is no very good data available still, because different people have different criteria to define growth failure. Some even just have used the growth monitoring only, not even the biochemical test to prove it. But overall, after 10 years, then we need to sit and decide whether we want to use it, not to use it, and it's a patient-centered. The predictor of response is younger the age, better is going to be the response. Longer is the duration, better is going to be the response. That is the somehow again boys do poorly compared to girl, and there is those patients who did not receive craniospinal radiation do better. And whenever we are counseling growth hormone therapy, I think there is no pediatrician, but so just want to mention that the response to growth hormone therapy in growth hormone deficiency idiopathic cases are excellent. It's like 20 centimeter in a year in first year and 15 or 10 to 12 centimeter in second year almost. But because these patients have been exposed to radiation, the epiphyseal itself gets damaged, so the response will not be as dramatic as it's going to be in congenital GST. So that counseling should have been done to the patients at the baseline. It's a costly therapy. So I think the expectation should be there again, and then the problems where there may be an asymmetry or discordant in the growth of lower segment versus upper segment, or spinal deformities which we need to take care. So another factor is which is being discussed a lot of time is about the safety of GH therapy in these patients, and for that matter all kind of pediatric oncology patients, especially again intracranial tumor and so there was a lot of debate about earlier, but recent data, especially like last couple of almost a decade or so, with long-term follow-up have shown that there is no excessive increased risk of either relapse, whether it's a leukemia or whether it's a intracranial tumors and all, or even the second or the other, even if those patients who did not have a leukemia at the baseline, there is no increased chance of blood-related malignancy. There are some tumors that has been reported that like osteosarcoma or meningioma can be there in some of the patients, but data is very controversial. Some study says it's actually the same in both the groups. There is, in some study there is marginal increase. So as of now, it is considered it's a very unlikely event, an exceptional case scenario. Otherwise, more or less now GS therapy is considered safe in post-transplant period. Growth failure is real, common, multifactorial. The TBI, cranial radiation, busulfan, cyclophosphamide, as the patients are at high risk. Start early, sustain it for more than 2 years. Give it to the younger patient, prepubertal age group. You will have a very good outcome. And the secondary malignancy risks are very, very rare. Last is the puberty. So as we know that there are a lot of things which happens when there is an onset of puberty. There is an activation of hypothalamic-pituitary gonadotrophic axis, LS, FSH pulsations increases, then you will have secretion of sex steroids, and ultimately it does the two things. One is of course development of secondary sexual characters, but it also boosts the growth velocity. The peak which we see during the time of puberty is the result of both growth hormone surge as well as increase in the secretion of growth in the sex hormones, which increases the efficiency of IGF formation secondary to GH action on the liver. So it is important to have puberty for both of these reasons. Again, post HCT hypogonadism is what we need to know is mostly actually hyper-hypo. It's not hypo-hypo. Very few cases have a hypogonadotrophic hypogonadism or what we call as secondary hypogonadism. It is mostly but the more common one is the primary or what we call as hypergonadotrophic hypogonadism because of the end organ damage like testis and ovary. Now another important thing which we need to keep in our mind is in male child the puberty is basically being controlled by two separate hormones, LH and FSH. So LH works on leading cell and FSH works on germ cell and seminal tubules. Germ cells and seminal tubules are more sensitive, so these patients develop agiospermia more. However, the leading cells are relatively resistant, so these patients can have a normal testosterone, they can even have a normal secondary sexual characters, maybe with slightly increased LH, so that is the difference. While in female, when the ovarian failure happens, it's the single follicular cells or ovarian follicles that controls both the fertility as well as development of secondary sexual characters. So all girls will have delayed puberty as well as infertility, while in male child, sometimes you may have discordance between the development of secondary sexual characters. They may be well developed otherwise, but when it comes to sperm or fertility, then they are actually agiospermic. So that is another difference. Again, the type of conditioning regimes is going to decide. Cyclophosphamide alone does not affect that much. Busulfan is a very toxic, gonadotoxic drug. So whenever it is being used as a conditioning regime part, then it of course going to affect. And then of course, so almost 60. When we talk about the incidence wise, almost the incidence is around 50% to 70% depending on the paper to paper or different cohort. And again, it's a TBI, which is the most toxic kind of a thing. most toxic kind of a regimes, again especially whenever there is direct exposure, so almost again 50 to 60%, especially those who receive single dose, almost 70% patient will have delayed puberty. Again, if you use, or sometimes we need to use the testicular radiations as a part of treatment, so those patients who receive direct radiation to testicles or where the testicular shielding is not done, like in leukemias, there the toxicity is more and delayed puberty incidence are almost 80%. Younger the children, they are more likely to recover from the damage. If you are giving it in older patients, then they are more likely to have a sustained damage. So that if we need to start monitoring for puberty around 10 to 11 years of age. We can do clinically by doing tenor staging at least 6 monthly or so. And if we need to consider is a delayed puberty if there is no onset of puberty before 13 years in girls and 14 years in before 13 years in girls and 14 years in boys, or there is a start of puberty but there is an arrest, or if there is an increase in LHFSH or biochemical markers of failing HPG axis. So and whenever this happens, timely initiation of treatment will give you pubertal surge. It will help us in achieving the pubertal growth spurt also, and as well as development of secondary sexual characters. These are various protocols which we use in induction of puberty in these patients. This is in the girls. Normally, nowadays we use estradiol, valerate or etastradiol rather than what we used to do in earlier ages where ethyl estradiol was done, which was used, which is more toxic. Now this replacement, the only thing which I want to highlight is very, very safe. It is not like post-menopausal hormonal therapy where there are lots of side effects if it is not being selected properly. So this is a physiological replacement. It is actually very much required. We should not worry about, or we should not assume the toxic or the various side effects which we see in post-menopausal HRT whenever we give them a prepubertal girls. Again, there are special protocols for boys, and it's basically increasing dose. We try to match the nature, not just to pump the sex hormones or testosterone at one go. It's a gradual up titration which leads to normal physiological development of puberty. There are very well defined, laid down screening guidelines by various society. I will not go into detail at what age, at what clinical pointers, at what investigation we need to use. I think it's very well available, and we should follow these things, and maybe at times we can take the help of our endocrinological colleagues to have a regular screening. Thalassemia, especially when it comes other than growth, thyroid and gonadal, because of the iron deposition, they have a specific set of toxicity, especially when it comes to endocrine. So hypoparathyroidism is very common. It is common almost in 30% cases. Then we can have insulin-dependent diabetes because of the deposition of iron in pancreas, almost in 10 to 15% cases. Rare cases of adrenal insufficiency, primary adrenal insufficiency has been described. All these patients, because of concurrent hypogonadisms and expanding marrow, they can have a poor bone quality also. So long-term risk of osteoporosis, which is probably the most under-recognized entity I think on this world. So under-recognized condition in this medical science is osteoporosis, which generally we realize only after the fracture happens. So this we need to get sensitized and monitor very well. So to conclude this thing, endocrine abnormalities is very common. It depends on what kind of conditioning regimes are being used or have been used in the patients. Long-term regular monitoring is required because a single examination does not rule out. It's a progressive thing, it's a evolving thing, so you need to monitor them at a particular period depending on the logistics throughout the life probably, especially thyroids, because growth and all after once they have achieved their final height probably does not play that much of a role, but when it comes to thyroid and sex hormones, then it needs to be lifelong monitoring. And of course the results are very gratifying if we can diagnose them in time, and if we can initiate them in time, the results are good, and we can actually give them a very good quality of life which all of them actually deserve, especially when they go a procedure like PMT as a part of the treatment. So this is, I think nowadays the time is of thumping the chest, so this is from my side. Thank you very much. And if there are any questions, I can...
The empty halls and the huge crowds at the reception counters in the morning The scientific session had actually been designed so that, we as doctors, as primary caregivers would be able to deal with thalassemia, which is a huge health burden in our country. And with the way the things are, it seems as though studies are no longer a part of our curriculum. We don't want to do anything that is extra. But I see quite a few people here, and what I really want is that we should give a huge round of applause to some of the undergraduate students who not only took part in the debates, the paper presentations, but have been sitting here throughout attending all these sessions. So please join me in applauding all those students. So anyway, I think it's time to thank everyone who was instrumental in bringing this into the picture, and I request all the organizers to please come up on the stage so that at least we can have a photograph for memories. Keep.